أتقدم بالشكر للجنة المنظمة على عمل جدول جميل ومتكامل وإحضار ناس متميزين as speakers و as chairpersons كمان. فنبتدي اليوم أول topic about lupus. We all know lupus. lupus في العيادة عندنا إحنا أكثر مرض مخيف وأكثر مرض that tricks us. نبتدي أول توك إن شاء الله about lupus nephritis. الدكتور محمد الخويطر. Dr. Mohammed Al-Khwaitar, I have attended few talks for him. He is an excellent speaker. He is a consultant nephrologist, King Saud University, Medical City. تفضل دكتور محمد حياك الله. حبيبي حياك الله.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Thank you very much, the organizing committee, Dr. Mohammed, Dr. Abdullah, for the invitation. I'm so proud and happy to be here actually every year to attend this unique conference of rheumatology with the particular attention on lupus nephritis from my side. I'm going to talk today about some of the historical overview of the management of lupus nephritis. I will also touch base on the pathophysiology of lupus nephritis and why it remains challenging when it comes to the management. And we'll also talk about the new updates about the management of proliferative lupus nephritis. Refractory lupus nephritis is outside the scope of my talk today. So I have nothing to disclose. As we all know, in 1980s, the cyclophosphamide has been used to treat lupus nephritis, and it was a big shift in the management of lupus nephritis, as it actually helped a lot in terms of decreasing the progression to end-stage renal disease. Having said that, we know the side effects of cyclophosphamide of an old NIH protocol, which was infertility, premature ovarian failure, which actually was a big thing to deal with back then. In 2002, Eurolupus protocol has been initiated, and their follow-up also have shown that Eurolupus protocol was as good as the modified NIH protocol. So that was, again, good response, and when it comes to side effects, it actually has less side effects profile in comparison with the NIH protocol. In 2009, there was again a landmark trial, the ALMS trial, that actually introduced CellCept with a very good kind of evidence into the management of lupus nephritis. But the question remains, were cyclophosphamide and MMF enough? Let's just close and zoom in and close in and see the results of the ALMS trials when it comes to complete renal remission. And the complete renal remission was defined as having a proteinuria of less than 0.5 grams. How much of those patients have attained complete remission, whether they have received modified NIH protocol or they have received MMF? It's only 23% and 27%. Okay? The rest of the patients did not attain complete remission. So it shows you that we are actually lagging behind when it comes to the effective management of lupus nephritis. There is another meta-analysis, a systematic review and meta-analysis study that looked into the patients of United States from 1971 to 2015, and they included more than 18,000 patients. They basically looked at the rate of end-stage renal disease. في pointer ما في pointer. طيب, as you see, with cyclophosphamide, mid-1985, it started to be used. Then we have a decreased slope of end-stage renal disease incidence until 2000, or let's say mid-1950, sorry, mid-1990s, where the plateau of end-stage renal disease continue at the same level. So all what we have seen is the effect of NIH protocol of cyclophosphamide. Changing the protocol to Eurolupus did improve the fertility, of course, but did not change the progression to end-stage renal disease. MMF, more, let's say, has less side effects profile, but it did not change the course of lupus nephritis when you compare it to the cyclophosphamide of NIH protocol. So they are not game changers. Why? Why the Eurolupus protocol and MMF are not game changers in the management of lupus nephritis? Because actually the pathophysiology of lupus nephritis is quite complex, all right? So when the presenting cells present the antigen to T cells, the T cells will proliferate to B cells. B cells will produce plasma cells. Plasma cells will produce immunoglobulins. B cells will co-stimulate T cells on the other side to stimulate the T effector cells, and T effector cells will produce interleukins and interferon. So targeting only T cells by giving cyclophosphamide, MMF, Imuran may not be enough. Why not to target B cells, for example? Why not to target the co-stimulation between B cells and T cells? Why not to target interleukin? Why not to target interferon? Why not to target plasma cells? Why not to target complements? So many actually medications have been tried in order to get this disease under control. Rituximab was tried in 2012, LUNAR study, and came negative. Acrelizumab, also anti-CD20, has been tried in 2013 and as an add-on therapy, and the study was negative. Abatacept, in two studies actually, an ACCESS trial and abatacept trial in 2014, and also came out negative. Many disappointing, actually, studies in the management of lupus nephritis. However, in 2020, we all know this study, the BLISS lupus nephritis study, belimumab. Without diving into the study, you know it very well, it came, the result, for the first time, it came out as a positive study. However, I have to say that they have changed the primary endpoint from complete renal remission to a new definition, which is primary efficacy renal outcome. And the primary efficacy renal outcome, it did not mean that the patient will have complete remission in terms of proteinuria to less than 0.5 grams. Actually, they increased the level to 0.7. Why they increased it to 0.7? To make it positive? I will say that, you know, their rationale is when they looked into the patients of lupus nephritis and they found that when the proteinuria is less than 0.7 in the first year, those kind of patients will have a better prognosis and better outcome. So based on this observation, they actually modified the complete renal remission into the primary efficacy renal response, hoping that those patients who achieve this point of less than or equal to 0.7 gram per day will probably do better in the years to come. So when they compare the belimumab plus CNI steroid or belimumab plus MMF steroid versus the standard therapy, the result actually was positive, 43 versus 32. When it comes to complete, all definition of complete renal response, it's still positive, 30 versus 20%. So this study actually was positive. Having said that, 50% of patients, they did not have any kind of response, neither complete nor partial response, which tells you that the management of lupus nephritis is really actually challenging. Secondary analysis after 2 years. I just want to show you that belimumab doesn't work very well when the proteinuria is high, in terms of partial remission or in terms of complete remission. When the proteinuria is more than 3 grams, the belimumab will not show any added benefits. Okay. You may argue with me that patients with proteinuria of more than 3 grams were not represented well in the study, and that's why the study was not positive. Actually, this is not true. The patients with proteinuria of 3 grams represented well in the study, and they actually account for 40% تقريبا in each arm. Voclosporin study, Aurora 1, was published in 2021. And as you know, the study was positive at 1 year. It showed that the rate of complete remission is significantly better with voclosporin, MMF, and steroid. There was no cyclophosphamide in this study. There was an argument that CNI may not be act effectively well if you have proliferative lupus nephritis. May be good for membranous, but may not be good for proliferative lupus nephritis. Well, this secondary analysis focused on this point. How, if I have proliferative lupus nephritis, class 3, class 4, and proteinuria of more than 3 grams, will voclosporin be still positive or not? This study actually has confirmed this. Using voclosporin in patients with proliferative lupus nephritis, it's going to be positive when you compare it to MMF and steroid. Okay. After the randomization, after the first year, they followed the patients for 2 years. So total of 3 years of voclosporin. Aurora 2 study was published, and the Aurora study showed that actually when it comes far to the end, at 36 months, the voclosporin, it seems that it will not act very well as it was in the first year. The p-value was 0.051, borderline as the time goes. So yeah, that raised some questions. What if I applied the 0.7 gram criteria instead of 0.5 grams criteria? Would that make the study positive? Yes, actually. So when we change it to 0.7, adopting the definition of good renal outcome, we will find that the p-value is 0.045. Okay. When to use voclosporin and when to use belimumab. If you have proteinuria of more than 3 grams, use voclosporin. If you have extrarenal manifestation, use belimumab. If you have chronic kidney disease with GFR of less than 45, use belimumab. If the patient is pregnant, you can't use either one. We don't have yet a safety profile to indicate their uses in pregnancy. If you have given cyclophosphamide as an induction therapy, don't use voclosporin. There is no evidence supporting that. Voclosporin study was actually based on MMF and steroid standard therapy. 2015, a new study was published about optunuzumab anti-CD20 type 2 for the management of lupus nephritis. Now let's talk about the anti-CD20. Yeah, we have 3 anti-CD20s that have been used in lupus nephritis. Rituximab, even though we're using it in refractory lupus nephritis, and we have good, let's say, good observational study indicating its use, but we don't have RCT that was positive to indicate the use of rituximab as an add-on therapy from the beginning. And there was a big disappointment back then in 2012. Ocrelizumab is another anti-CD20 type 1, but it is humanized, not like rituximab. It failed, actually. It basically, the study was stopped early because of the side effects. Okay, so why do I want to use optunuzumab then, if the rituximab and ocrelizumab were negative? Well, it acts a bit different. Its effect, it's type 2 anti-CD20, where the cytotoxic effect in terms of depleting B cells is stronger than rituximab and stronger than ocrelizumab. And that actually was observed in Nobility study, the phase 2 trial. They found that the optunuzumab deplete the B cells very deeply and over a short period of time. And also, they did a secondary analysis for the LUNAR study, the study with negative rituximab outcome. When they looked into it, they found that those patients whom we have B-cell depletion over a short period of time, they tend actually to do better when it comes to the renal outcome. So the concept, deplete B-cells very strongly and over a short period of time, that would probably has an impact on the outcome of lupus nephritis. Okay, so that is on paper, right? It seems that anti-CD20 type 2 better than anti-CD20 type 1. But as we all know, when we apply this clinically, will we see the same observation? Did we apply it in the first place? Yes, we have one study actually, not in lupus, but in CLL, where they compare chlorambucil versus chlorambucil and rituximab versus chlorambucil and optuzumab. And those patients who have received the combo of optuzumab and chlorambucil did better in terms of free survival events. So yeah, I think we have all the justification to proceed and go ahead with this study. This study was published recently in the beginning of 2025, and they actually divided the patients into 2 arms, the steroid MMF and anti-CD20 versus steroid and MMF. No cyclophosphamide here as well. Okay, they give the optunuzumab 5 to 6 times. So 2 doses, 2 weeks apart, day 1 and 2 weeks. Then 2 doses at 24 weeks and 26 weeks. Then you have the option either to give 1 dose at 52, or you have the other option of giving 2 doses at 50 and 52. So total of 6 doses or 5 doses. In addition, they tapered the steroid fast over a short period of time to 7.5 milligram by week 12 and 5 milligram by week 24. Okay. So they applied the criteria of complete renal remission, i.e. proteinuria of less than 0.5 gram. And the result was positive. The adjusted difference was 13.4% between the 2 arms. Okay. Okay, let's dive in and do subgroup analysis. It seems that the effect is more pronounced when the proteinuria is more than 3 grams. And it seems that the effect and the impact is more pronounced when class 5 is in. So if you have class 3 and class 5, class 4 and class 5, you will see better response to obinutuzumab. Okay, so now how would we apply all of these information into clinical practice? How the guidelines say about these kind of evidence? All right, so let me ask you a question. If you have patients with lupus nephritis, will you start with the standard therapy or triple therapy? And when I say triple therapy, I mean voclosporin or belimumab. Who's going to say to standard therapy? Okay, triple therapy. That's the guidelines. Okay, all right. So, all right. Yeah, the one who says two therapy, I don't think they are wrong. They are, yeah. And those who said triple therapy, they are not wrong too. This is the EULAR update in 2025, where actually stated that it's better to use triple therapy, and they included obinutuzumab. Okay, will you use obinutuzumab over belimumab or belimumab over voclosporin? There is no really good evidence to guide us on this regard. Okay, but the one who is going to use standard therapy actually is not wrong. The KDIGO guidelines give the option to use, from evidence medicine point of view, standard therapy or triple therapy. Okay. Right. I believe, yeah, we'll come into it. Okay. So the same for American College of Rheumatology guidelines. They are recommending using triple immunosuppressive therapy. Okay, how about the dose of steroid? So again, the kidney outcome guidelines, based on evidence, they actually open it to the clinician to decide whether to use the high dose regimen or moderate dose regimen and reduced dose regimen. And that's why they give also the option to use standard therapy or triple therapy. In the rheumatology guidelines, they're actually focusing on using low dose of steroid. And if you're going to use low dose of steroids, you have to justify it from evidence medicine point of view. And that's why they want to use triple therapy. So in order to justify the small dose, you would actually include a third agent, all right? But if you want to make it open to the clinician judgment, here you will have the option of standard and the option of triple therapy, the option of high dose versus moderate dose versus reduced dose. This is the steroid regimen used in obinutuzumab study. No pulse methylprednisolone was given in the anti-CD20 study of obinutuzumab, okay? They used 0.5 milligram per kg of oral steroid, maximum of 60. When to stop steroid? Difficult question. KDIGO guidelines suggesting, it's not recommending, it's just suggesting that you stop steroid when you attain complete remission, 12 weeks after you attain complete remission. In obinutuzumab study, steroid was actually continued throughout the whole study at 5 milligram. Okay, how about the maintenance therapy? Well, if you're going to use voclosporin, you're going to continue on voclosporin for 3 years. If you're going to use belimumab, you will continue on belimumab for 2 years. If you're using standard therapy, it's better to use MMF as a maintenance therapy. If you can't use reasons, azathioprine is the second option. If you can't use azathioprine because of pancreatitis or hepatitis, and you can't use MMF, you still can use CNI like tacrolimus or cyclosporin as a maintenance therapy. Okay. Hydroxychloroquine is recommended. When it comes to evidence, it doesn't have that great evidence, but given the experience that we have with hydroxychloroquine, the safe side effects profile, they have granted use of hydroxychloroquine 1C. Okay, so one more thing. How about class 5 lupus nephritis? Pure class 5 lupus nephritis. How would you manage those patients? I brought this because there is a difference between the KDIGO guidelines, the kidney, and between the EULAR. In the kidney guidelines, they said when the proteinuria is nephrotic range, 3.5 grams or above, you use the immunosuppressive therapy. In dermatology guidelines, EULAR, when the proteinuria is more than 1 gram, that is enough to start the patients on immunosuppressive therapy. So why we have a bit two different opinions in the membranous lupus nephritis? Because we don't have good evidence, right? So it's always, when you don't have good evidence, you will have different opinions. Yeah, key point. SLE is a very heterogeneous disease with complex pathophysiology, which makes the appropriate management actually difficult. We're still behind when it comes to the successful rate of complete remission. Variation in molecule gene expression might explain why some patients respond well while others do not. More than 15 lupus nephritis trial of phase 2 and 3 are ongoing and targeting different pathological point, which makes us, inshallah, optimistic. Here is an example of ongoing phase 3 trials. Belimumab and rituximab is expected to be published, inshallah, the second half of next year. And firulumab, the IRIS study, may take actually some time. Secukinumab is expected to be published next year as well, inshallah. Thank you very much.
Thank you, Dr. Khwet. That was a really informative talk. The next speaker is going to be Dr. Fatma Drebi. She is a consultant rheumatology and intermedicine, American Saudi board certifiers. She has a PhD in immunology, and she works at King Faisal Specialist Hospital and Research Center. She's going to explore a new therapy in the field of lupus, which is chimeric antigenic receptors T cells therapy as a therapy for lupus, ushering a new era. So, Dr. Fatma, the podium is yours.
Assalamu alaikum warahmatullah. My name is Fatma Drebi. As Dr. Ali introduced me, I am one of the rheumatology consultants at King Faisal Specialist Hospital. I would like to thank the organizing committee and Dr. Sultan for inviting me to speak today. And I am honored to be here in this event with Dr. Al-Khwater. He talk about the guideline of lupus nephritis, make my job more easy. So I will speak about the CAR T cell therapy in evolving role in management of SLE. Okay, no disclosure. So this is my goals and outline for lecture today. So cell therapy and using the power of our body cell to treat and prevent disease, it's rapidly expanding and transformative, and this will be used in the future. cellular therapy, gene therapy has a potential to cure disease and repair cell, and this is the treatment for the next 20th century. So it has been already established in oncology and being tested in transplant, and we see now potential in autoimmune disease. So let's start with the structure of chiremic antigen receptor. As you can see here, this receptor is a simple, but it's an elegant chiremic antigen receptor which contain, when they discovered this receptor, actually when the researcher noticed that the complexity of the T receptor, that they can simplify it by putting the signal 1 and signal 2 in the cytoplasmic domain of the CAR T cell. And then they actually joined the antibody portion in the extracellular domain, and then with the transmembrane domain connecting the intracellular and extracellular. What I want to point that each part of this chiremic antigen receptor very important for efficacy and function of the receptor. So when we have the CAR cell or CAR T therapy, so we need to have a target. So our target either CD19 or CD20 or BCAM. So for CD19, as you can see in this picture, we're going to cover from pro-B cell until the late plasma cell. How about the CD20, which we're going to cover from pro-B until early plasmablast. BCAM, which we're going to cover from plasma cell to plasmablast. So after knowing the structure of CAR T cell and knowing the target of CAR T cell, then how we were going to apply it. So this is a complex structure, but I will going to walk you through it. First, here, as you can see, patient will going to come to the pheresis unit. So we'll do leukapheresis to collect the T cell. Then after that, after collecting the T cell, we introduce the CAR to T cell by using a viral vector. Then the T cell will expand with the CAR T cell. After that, we'll freeze it, then ship it to the center. Before giving it to the patient, we use usually lymphodepletion therapy like cyclophosphamide or fludarabine. Then after that, infuse the CAR T cell, which will lead the CAR T cell recognize the pathogenic B cell and kill the cell. So that, just I have one slide about the spectrum of CAR-based treatment. So first, how about the transduction method? So we do have currently two methods, either viral method or lipid nanoparticle method. So what we currently use in the clinical trial, the viral vector. Also, we do have the type of a procedure, either autologous or from the patient himself, or allogenic from healthy donor, or in vivo. And we have different type of cell, either T cell, gamma delta T cell, or natural killer cell. So this table actually shows the different between CAR T cell, between autologous and allogenic CAR T cell. I want to highlight some point. If you go with autologous, the dosing usually in million, but in allogenic, the dose in billion. If you can see here, in order to get autologous CAR T cell, usually we need 2 to 4 weeks, but in case of allogenic, it's usually available in demand. Usually, the administration time for autologous need to be administered in high tertiary center, but in allogenic, usually patient can get it in infusion unit. Safety, so the allogenic CAR T cell, it's more safer than autologous. So this is a figure show the effectiveness of CAR T cell. As you can see, it's living drug with more than 1,000-fold expansion in vivo. Also, they have serial killing with more than 1,000 ability to kill the target cell in vivo, and it can migrate, including the CNS. So it's a good medication, even in case of CNS disease involvement. So how about toxicity and limitation? And this is what we know from the hematology literature as being reported about cytokine release syndrome. They have a grade for it, which is grade 1, 2, 3, including fever, hypotension, hypoxia. Also, they report neurotoxicity side effect, and again, they have a grade for it and include the change in level of consciousness and other items. They have also hematotoxicity side effect, and then the most important thing, the clonal expansion and the risk of T-cell transformation and secondary malignancy. So knowing those things, so how about applying CAR T-cell in autoimmune disease, especially in SLE? So that will lead to that a group in Germany, which they report the first case in 2021 for a lady with severe lupus, systemic lupus erythematosus. This lady, she was on multiple medication, as you can see here, rituximab, MMF, tacrolimus. And then they do first the leukapheresis, and after that they did lymphodepletion, and she received the CAR T-cell. After she received the CAR T-cell, as you can see, anti-depressant DNA went to 0. Then how about the SLEDAI? The same. So what happened to this lady? So after 3 years from the CAR T-cell, she is in complete remission, no treatment, no sign of autoimmune disease, and normal life. So that's very good result. And then you can see on the other side, the CAR T-cell, the B-cell, the SLEDAI, and the anti-depressant DNA level, which all of them went to 0. So this led to the same group to publish 8 of series of the case with severe refractory SLE, and what they found, 8 of those patients achieved DORIS remission at 6 months. Not only that, this remission sustained up to 29 months. And as you can see in those, this figure, the SLEDAI, anti-depressant DNA, and C3 and urine protein ratio being normalized after the CAR T-cell. I want to point that this is a figure from Dr. George Shett, which does the figure for the 8 patients that they received the CAR T-cell. This guy, he always pointing, this guy, he is the DJ who loved the sun. Then after getting the CAR T-cell, he went outside and he got sunburned, but he did not get lupus flare or lupus. And all of them free of treatment. So then again, we do have a systemic review, which being published in June 2025. Those group, they review all the literature about CAR T-cell that's been published, 5,905, and from those publications, they have review 16 study, and from those 16 study, they have a total of 145. So what happened to those 5,000? So what they mentioned in this systemic review, that the rest of the study either reporting the actual study. The actual study, it's only 8 full paper published and 8 abstract published and included here. This table shows the 16 study that included in this systemic review. I will gonna go through it. So where do those study happening? So 8 of them in China, 1 in Italy, 4 in Germany, 1 Spain, and 1 in Australia, 2 in Italy, and 4 in United States. So for those 16 study, 13, they got a single product targeting CD19, and 3, they got a bispecific product. 12, they received autologous CAR T-cell, and 4 study, they received allogeneic transplant, a CAR T-cell, not a transplant. So how about the efficacy? So if you can see this, in this curve show, 13.1, they achieve 13.1 at baseline. This is the SLEDAI. Then after 3 months from the CAR T-cell, it went down to 3.6, and then went down to 2.3 at 6 months, then 1.4 at 12 months. How about other outcome efficacy? So as you can see here, the efficacy outcome were reported in 133 out of 145. Of those, 80% had follow-up of at least 6 months. The reported outcome that was mentioned in those study, 64 for DORIS, 56 for low disease activity, and 91 for drug-free remission. And if you can see here, 70% achieved DORIS, and 89 achieved low disease activity, and 84% achieved drug-free remission. And also in this systemic review, they have tried to see if there is any difference between autologous and allogeneic CAR T-cell, but there is no difference. And if there is any difference between bispecific and CD19, but they did not find any difference. How about the autoantibody and complement? Again, the C3 and C4, normal or normalish in 75 out of 79. How about the anti-depressant DNA, which decreased in 72 patients and normal in 47? Other antibody like anti-Smith, anti-histone, anti-nucleosome, which reported in only 2 studies and show the same decrease in those antibody. How about the difficult to eradicate antibody like anti-U1 SNRMP, anti-ribosome, anti-SSA, anti-Ro60, anti-SSA, Ro52? It's been reported that it's normalized in 12 out of 13 patients, and those patients treated with bispecific BCAM CD19 CAR T cell. So how about protective antibody? So we do have 2 studies which they report the protective 2 study. The first study, which is from a German group, they report that the protective antibody decreased in pneumococcal and SARS-CoV-2. And the other study reported that reduction in tetanus, diphtheria, and antihepatitis. And as you can see in this figure, that this is the time of CAR T cell infusion. Here, the level of antibody before the CAR T cell, and then after the CAR T cell dropped the level, then after the vaccine went up. So, like those people, if they got the vaccine, it will gonna the level of antibody, it will gonna go up. So here, how about the B cell depletion and reconstitution? So all group reported successfully B cell depleted. As you can see here in the figure, the autoimmune B cell was there. Then after the CAR T cell depleted, then B cell reconstitution was observed by most group around 2 to 3 months post-infusion. And with some group reported reconstitution as early as 40 days or later as 6 months. So this is another study which Dr. Khwater mentioned that about optinizumab. So how about the B cell depletion in lymph node, not only peripheral blood, because all of those medications, they can deplete the B cell in peripheral blood, but how about in the organ? So actually, this is very important study, which they have 4 group of patients. In each category, they recruit 4 patients. The first group, post-obnitumab, which is CD20 that Dr. Khwater talked about it. The second group, which is post-belantamab, which is T-cell engager. The third group, post-rituximab, which anti-CD20. And the third group, post-CAR T-cell therapy. If you can see, the first one, this is through the H&E, and this is the CD19, and this is CD20. The first one, the CD19 and the 20, this is by immunohistochemistry. So if you can see the brownish color, that means positive. If there is no dark brown, it is negative. So if you can see from the figure, the B cell depletion in the CAR T cell, post-CAR T cell, both CD19 and CD20, both of them negative. So both of them depleted. But when you compare it with obinutuzumab, still there is some element of CD19 and CD20, although it's better than rituximab, if you can. Obinutuzumab, still there is some element of CD19 and 20 compared to the post-rituximab, which there is a lot. And in between, the T-cell engager. When you see the other figure, I put the peripheral blood and I put the lymph node. In the peripheral blood, I put the like this figure taken from the study. So if you can see in the figure, pre and post, all of them, all 4 medication deplete the B cell from peripheral blood, but the CAR T cell, the only medication depleted from the lymph node. So the conclusion from this, that CAR T cell deplete the B cell from the lymph node, not only from the blood. So this is another study, this is a letter to the editorial, was published in New England Journal. So for a lady who 16 years old girl with childhood onset lupus and lupus nephritis. As you can see here in the figure, that before CAR T cell and 6 months after CAR T cell, the IgG, C3, and C1q, all of them depleted and cleared. So again, the CAR T cell, it's not only deplete the B cell from blood and not only from the lymph node, also from the organ. So that's a good thing too. So how about the genetic? So this is this study was done to study the genetic profile in patients received CAR T cell before and after. And what they noticed that the most down regulation gene in T cell after the CAR T cell is interferon. So how about the safety effect? So this slide show the safety outcome from the 16 study that I presented before. So I will gonna go through them one by one. First one, the CRS, which is the cytokine release syndrome. As you can see here, total patient got CRS 81%, 56%, and only grade 3, 1%, grade 4, 0. If you can see the onset usually from 1 to 10 days, the duration from 2 to 5 days for the most cases, and all 81 events resolved either without a treatment or with non-steroidal anti-inflammatory drug or with tocilizumab and for receive glucocorticosteroid. About other side effects. So for ICANS, a total of 3% they got, one patient in each group. So usually the symptoms in patients with receiving with SLE, tremor, dysphagia, speech difficulty, ataxia, lethargy, altered mental status, and subclinical seizure activity. Usually those develop from 8 to 10 days, and those patients was treated with glucocorticosteroid and anakinra. And the most important thing, there is no neurological sequelae were reported. How about other side effects? Before going to other side effects, this figure just I put it to compare the side effect, comparing people with SLE compared to lymphoma and leukemia. As you can see here, patients with SLE, we have 145 from the systemic review, and large B-cell lymphoma and leukemia. A grade 3 or 4 in cytokine release syndrome, 1% compared to lymphoma, 13%, and leukemia, 13%. When we go to ICANS, which is the neurotoxicity, 1.5 for 3 or 4 grade compared to 10%. So clearly, what's been hypothesized that autoimmune disease, they do have less B-cell burden compared to the hematological malignancy. That's why the side effect less. That's what's been hypothesized so far. So how about other safety outcomes? So infection in 19%, 7.6 were severe with 9 pneumonia, 1 UTI, and meningitis. So this guy who died from pneumococcal meningitis, he was unfortunate because he did not get the vaccine either before and after the CAR T-cell. He was refusing the vaccine. How about other side effects? It's been reported severe cytopenia in 40%, and they attributed either to CAR T-cell or the lymphodepletion regimen before the CAR T-cell. Prolonged more than 28 days in 5%. How about other side effects? The hypoglobulinemia in 26 patients, and 8 of them received IVIG, macrophages activation syndrome in 2 patients. So how about concern of malignancy? As I mentioned, in hematological malignancy, it's been reported. Actually, in November 2023, FDA alert report 2020 case of T-cell lymphoma following BCAM or CD19 direct autologous CAR T-cell therapy in hematological malignancy. How about autoimmune? Still, we don't have any reported case, but overall, the benefit of those therapy continue to overweight the potential risk. So after we talk about the autologous CAR T-cell, the indication and the safety and the efficacy, so how about the cost? So as you can see here, it's manufacturing required time, money, and experience, medical center. Also, there is a lot of logistic and low feasibility and accessibility. So this is the cost in dollar, and it required 3 to 6 weeks to get it. So is that the option here, or do we have something else to might consider it until we get better? So that which will lead me to talk about T-cell engager. So the T-cell engager usually bispecific antibody, which contain more than 2 distinct antigen binding sites. As you can see in the figure that it's antibody, one part bind to the T-cell, the other part to B-cell, which make the T-cell attack the B-cell and attack the B-cell. So this figure, I put it in the first column that show the monoclonal antibody, which the rituximab, like rituximab, obinutuzumab, and in the extreme, the CAR T-cell in form of the efficacy, depleting the B-cell remission, and in the middle, the T-cell engager. So the T-cell engager, it shows some efficacy. It's been used in hematological malignancy, and there is many cases reported in rheumatoid arthritis and 1 case in SLE with good response. So what's next? So the CAR T-cell therapy randomized controlled trial, this is the center, and we are fortunate to have in King Faisal Specialist Hospital in Riyadh a trial for recruiting CAR T-cell therapy for SLE patient, myositis and vasculitis. And also we have the T-cell engager, and we are hopefully soon to start recruiting patients for SLE and SLE with or without lupus nephritis and rheumatoid arthritis. So this is a great news. So if anyone has a patient with refractory SLE and they think that it is CAR T-cell is a good option, they can refer it to us or contact a rheumatologist. This is my summary and thought points, and I think I'm good. Thank you so much. Thank you. Thank you.
Thank you very much, Dr. Fatma. New informations and very well, in easy way presented, and hopefully that's going to be a good future for people with difficulty in the normal treatment. The next speaker is one of the well-known rheumatologists in Saudi Arabia, is one of the seniors as well, pediatric rheumatologist, Professor Suleiman Al-Mayouf, working at King Faisal Specialist Hospital as a head sections. He's a professor at the Al Faisal University. He's very well known for lots of publications. So he's going to share with us his view about childhood lupus and is in the way of challenging in clinical practice. So Dr. Mayouf, the podium is yours.
طيب السلام عليكم ورحمة الله. سعد الله صباحكم بكل خير. أولا شكرا للدكتور محمد دكتور عبد الله for the kind invitation, and thank you Dr. Ali for this kind presentation. My apology, I just came out from flu, so probably my voice will be interrupted from time to time. It will be difficult to talk about childhood lupus, especially after these two wonderful intensive talks from the previous speakers. So I choose to talk about challenges in clinical practice. I will just give brief background about childhood lupus, very brief, what we are facing, and I will use the real cases encountered in practice to show the challenges in real practice. I have nothing to disclose. We know that the challenges encountered in real practice can be summarized in three domains: diagnosis, treatment, monitoring. My talk will be focused mainly on the diagnosis. I will not talk anything about treatment and the monitoring. So the childhood lupus, like adult lupus, the exact etiology of lupus remains incompletely understood. And the pathogenesis of lupus is complex, and there is no wonder, because the pathogenesis involve abnormalities across the facet of immune system. So anything in the immune system can be responsible about the lupus manifestation. And classical teaching, the lupus is primarily a polygenic disease. In our practice as pediatric rheumatology, we are seeing a lot of cases of monogenic lupus, and this is one of the challenges. I will show you maybe one case or two from this perspective. As Dr. Muhammad and Dr. Fatma emphasized, that it's a heterogeneous disease with variable severity, with relapsing, remitting course, and unpredictable course outcome. Now, we have special consideration in childhood lupus, and the boundaries between lupus and immune dysregulation disorder or inborn error of immunity are blurred. So these boundaries probably it's difficult, especially when we are talking about inherited lupus or monogenic lupus. And we are receiving many cases, referrals from our colleagues from immunologists, labeled as immune deficiency turned to be lupus. And we also seeing patients with more severe symptoms at onset comparing to adult, as well as more aggressive clinical course. And of course, they are requiring more treatment if we are talking about steroid and the requirement for other DMARDs. Now, we have limited treatment options compared to adult lupus, and even we compare it to other childhood rheumatic diseases for juvenile arthritis, we have enough list to choose among the treatment options. In childhood lupus, probably this is a bit limited. Other problem we are facing in childhood lupus, the proper definition of disease activity status, all we adopted from adult practice. And yes, we are validated, but it's not really originated from pediatric patient. Now we have also stage of adolescence and self-management capacity, and this will come to the medication adherence will affect on the treatment outcome and response. We are facing problems with the vaccines and the childhood. We are aware about the growth and development age group. Now, the diagnostic challenges in childhood lupus, we can summarize it due to different reasons, but these are the main reasons. Heterogeneous and atypical presentation may present with overlapping with other condition and sometimes with isolated or uncommon features delaying the diagnosis. From now, I will just share with you cases, and probably you agree or disagree with me, but at least let us see what we can get. So this is a 12-year-old boy presented with a 3-year history of peripheral arthritis, mainly the knees and wrist. The working up at referring hospital showed high inflammatory markers, autoantibody positivity, and low complement levels. And they labeled him as lupus, as expected. And he was treated with a treatment based on that diagnosis. After 1 year follow-up, presented with enthesitis and back pain, which is a bit weird. So the thought about infection workup, including Brucella and TB, were negative. So other workup, including RF, anti-CCB, HLA-B27 were negative. So this is the X-ray. Those who are expert in the X-ray, they can see there is left sacroiliac joint abnormalities, and this is confirmed by MRI, showed there is sacroiliitis. So is it common to see SLE with sacroiliitis? At least in pediatrics, it's not that common. So 6 months later, presented with progressive disease course, chest pain, pericardial effusion, and he had vasculitis rash, malar rash, leukopenia, and even the double-stranded DNA is escalating, and persistent low C3, C4, and prove him to have lupus nephritis. So what is the diagnosis? Lupus, or lupus with enthesitis-related arthritis. This is the term we use it in pediatric. We don't use spondyloarthropathy or SPA, or overlap syndrome, or lupus syndrome. So any thought? 2? Lupus. Okay. So let's just remind you, you know better than me, arthritis, it's common in lupus. Up to 90% patients, they present with arthritis, and even as initial presentation, up to 50%. And typically they have short duration, transient, mainly affected peripheral joint. They respond very well to treatment, even with the steroid, and typically non-erosive. And the axial involvement rare, mostly case report and from adult. If we are talking about lupus, it's a descriptive term. So it is not really a diagnosis, and people use it just to describe patient with lupus and RA manifestation. And as pediatric rheumatology group, they try to use the same term, though many people disagree. And we know that lupus is poorly defined in both adult and children, and it represented a diagnostic challenges. And this is recent systematic review to convince people with this concept, but still it's not well accepted among pediatric rheumatology. So let me share with you another case. This is a 12-year-old girl referred with arthritis, joint deformity, ankles, knees, small joint of the hand, and you can appreciate from the X-ray there is deformity and erosive changes. And she has alopecia, skin rash in form of eczematous tight sinus skin, and she was fatigued, asthenic appearance. And here you can see the labs. She had significant high inflammatory marker, high ANA, and negative double-strand DNA, rheumatoid factor high and low complement, and was negative for proteinuria. And this is her MRI showed active erosive arthropathy with tenosynovitis. Again, is it overlap or lupus؟ طبعا اللي قال أول لازم يتبع. So lupus, okay. The first patient, we don't have that time the genetic testing. And this patient, we did genetic testing and came back positive as homozygous variant for BTD, which is biotinase deficiency. And this may explain her at least some manifestation. And interestingly, we had biotin based on this result, and it showed significant improvement, of course, in addition to her treatment for lupus in terms of steroid, Plaquenil, and others. So is biotin deficiency has a role in her arthritis, at least from the literature? I couldn't find anything, but I cannot ignore this genetic result. So what I'm trying to say, the overlap concept is unsatisfactory and outdated with current molecular immunogenetic testing. We have to dig and find something to explain the manifestation rather than give overlap or redundant medical term. So the lupus manifestation might be the initial presentation of inborn error of immunity, not on that, or it can be also attributed to inborn error of metabolism. And we have limited experience showing that, including the immune deficiency status and also the inborn error of metabolism. So I'm trying to deliver the message. The overlap probably it's outdated and we need to rethink about this term used in practice. So the big question, is it a causation or association? And this is very important. Yes, it can be a cause, and these need to be proved by further genetic testing. And I'm very glad that Dr. Fatma will start and launch her lab soon. And this will help us to, inshallah, to run functional assay to prove this genetic positivity. Is it related to the clinical or phenotype or no? So the second case, a 13-year-old girl presented with 1 month history of fever, fatigue, myalgia, including lower limb. And she was ill-looking, hypertensive, tachycardia, reduced breath sound, and she had facial rash and oral ulcer, and you can see her labs compatible with maybe macrophage activation syndrome or HLH, if you want to call it, but she had evidence of lupus as well. She was admitted to ICU. She was mechanically ventilated, and she required vasopressors and covered with antimicrobial agent. Fortunately, she came out through this after treatment for lupus and macrophage activation syndrome, and she was good, transferred to the floor. Shortly, she developed difficult swallowing and lower limb weakness, and it showed high CK and LD, and you can see the MRI consistent with myositis. Now, is this myositis related to hair lupus or other cause? And the biopsy showed necrotizing myopathy, infiltration, but there was no inflammatory cells. And this is the entity known as inflammatory myopathy with abundant macrophage, or EMAM. Now, as I asked you before, this myositis manifestation, is it related to lupus or macrophage activation syndrome? The distinguish between macrophage activation syndrome and lupus is very, very difficult, because both they share the same manifestation and laboratory, unless you have index of suspicion looking for serum ferritin, otherwise you will miss the case. And we know that good percentage of patients of lupus present with myositis, and they don't have specific inflammatory changes, just myositis, not like dermatomyositis with specific changes. But there are rare myopathy reported with lupus, especially with macrophage activation syndrome, as I said, EMAM, or immune-mediated necrotizing myopathy, and to distinguish between the inflammatory and non-inflammatory just by histopathology, looking for the inflammatory cells. So another case, 15-year-old girl at 7 years, clinical and lab feature showed lupus and started on steroid. Unfortunately, she lost follow-up. At age of 11 years, she had presented with constitutional symptoms, arthritis, and proximal muscle weakness, and you can see she has high inflammatory marker, high CK, and double strand, and ANA low complement. And the MRI confirmed she has myositis. And this patient, we did the gene, and genetic testing, it came positive for ISG15, one of the interferonopathy, though her presentation was lupus. And this case was reported by Dr. Al-Wajain a long time ago, and it is one of the interesting cases, and she get a winner during the Lupus Academy for her oral abstract. So I'm trying to say myositis in lupus, especially if the presentation is not typical, we need to think about other causes, explain the lupus and other manifestation. So the third case, I'm very glad Dr. Mohammed Al-Khwaitar is here, and I'd like to hear during the comment this case. We know nephritis is common, major organ involvement in childhood lupus, maybe more severe than adult, and it might be a subclinical, and typically lupus nephritis is confirmed by the presence of full house glomerulonephritis. So this is a typical or classic teaching. This is a 5-year-old girl referred to pediatric nephrology. We are not the primary. So we are seeing this patient as a consultation. She had renal impairment, proteinuria, and she has also mild constitutive symptoms, no clinical features of lupus, and found to have nephrotic range proteinuria, very low serum albumin, and ANA only 1 in 60 with negative double strand and other antibodies. She had only borderline C3, and C4 was normal. Renal biopsy showed full house glomerulonephritis, class 3, and the West this time was negative. So would you suspect lupus in this case? Would you call this lupus and treat it? As a rheumatologist, would you accept as a referral, or you will say for your colleagues, Thank you, and keep the patient with you. Now, there are different classification criteria, and one of these classification criteria, SLIC classification criteria, which is widely used among pediatric rheumatologists and adult rheumatologists, and this is well defined and validated with good sensitivity and specificity. This allows to classify patients with isolated biopsy-proven lupus nephritis with positive ANA or double-strand DNA. In that patient, she had only ANA positive but full house glomerulonephritis. And this is what people call stand-alone renal SLIC criteria. I don't know if this term is commonly or popular among rheumatologists and nephrologists. So the question is stand-alone renal SLIC sufficient for childhood lupus? If yes, do such patients differ from those meeting full SLIC criteria? I would like to hear from adult rheumatology colleague what's their input, and of course Dr. Muhammad will help us in this regard. So we conducted a small study comparing stand-alone SLIC criteria with full house with patient with full lupus criteria. And yes, these are small number, but we try to, this is the number patient. You can see patient with biopsy-proven nephritis and SLE without nephritis. And we try to compare it with the stand-alone SLIC criteria patient. Interestingly, there was a few differences between the two groups. So just to cut it short, there are different in response to treatment and outcome and the severity of nephritis. So we believe patient meeting the stand-alone renal SLIC criteria may represent a different subset characterized by more severe renal involvement. So in summary, lupus is a heterogeneous disease with expanding boundaries due to diverse etiopathogenesis. The concept of overlap is often unsatisfactory, arising suspicion for monogenic inflammatory immune dysregulation disorders. Classification criteria serve as a tools for stratification rather than definite diagnosis, and genetic testing support early diagnosis, optimizing clinical management and genetic counseling. With that, I will stop and thank you.
Thank you, Prof. Sulaiman. Very interesting talk. Will all the speakers please sit for discussion on the podium here? So the floor is open for any questions. If anybody have any, I'm sure there are a lot of issues. Yes, Dr. Afan. Can we have?
Thanks to all speakers. Thank you, Dr. Fatima, great presentation. My question is to you. How can we be sure that, the response of lupus is due to the CAR T cell itself rather than the strong, good dose of chemotherapy during the preparation?
Yeah, so this is really good question. Actually, there is a study back in the 90s, I think 90 something, but they initially, back in the day, the treatment for lupus with the fludarabine and cyclophosphamide, and at that time, those patients received chemotherapy, but lupus nephritis and SLE being refractory. So to answer your question, even those patients back in, I forget when was those study, but I'm happy to share it with you. Those patients receive not once, but before CAR T cell, usually we give lymphodepletion one time. And usually, until now, we don't have a fixed regimen. The regimen based on the trial, based on the protocol. But what's being used, cyclophosphamide and 3 doses of fludarabine. That's what we've been used as one time before receiving the CAR T-cell therapy. Back in the day, when they study lupus nephritis, those patients receive single dose without any improvement, and they receive multiple doses of fludarabine and cyclotherapy, which lead to toxicity, and then the study was stopped because of the toxicity. So we know from back in the day, with chemotherapy alone, it will not gonna put you in a remission.
Thank you. What about your local experience at King Faisal Hospital?
So we're just starting to recruit patients, and this is a good news that we start to recruit patients. But until now, we are in the process. But we have a clinical trial to recruit CAR T-cell for myositis, lupus nephritis, and vasculitis. And also we have the T-cell engager, which this is a new modality to treat lupus nephritis and rheumatoid arthritis.
Thank you.
تمام شكرا تفضل دكتور.
Thank you, doctors, for the excellent presentations. I have two questions for Dr. Fatma. The first is, are we dealing with a long-term remission or a lifelong remission? And why do you think that some patients may relapse over the long term? Now, the second question is, when looking into the candidates for CAR T-cell therapy, you may see that the majority of them would be suspected to have failure of multiple biologics before going into the trial. So why wouldn't the early stages of the disease, where they are severe, are considered for such therapy?
Okay, thank you so much for
the prognosis of the patients.
Thank you for the question. So what I understand, the first question, the goal of CAR T-cell, is it long-term remission or because what we are targeting with CAR T-cell, it's a cure disease, to cure the disease. Is that the question, or?
Yes, but the thing is, are we dealing with long-term or lifelong? So why would some patients relapse and get the disease again?
So to answer, actually we don't have data until now. What we do have, like from the systemic review that I present, we do have 145 patients, and those patients we do have up to 6 months. So we don't have enough data and enough time to answer this question, but we are looking for long-term curative rather than long-term. Why do some patients relapse and require, because there is one case they report relapse and got another CAR T-cell with combined CD19 and BCAM, and this patient, this regimen put her in remission, but still we don't have enough data on that. The second question about?
So the second question about the candidates for the CAR T-cell therapy, usually, especially in King Faisal Hospital,
Absolutely.
they would say that patients with multiple failures of biologics would be a candidate for such therapy. But I think that patients in the early stages would benefit more, especially into preventing the complications of the disease. So why would you only consider the patients with multiple failures?
Okay, good question. Thank you for this. The second question. So actually, I do have a paper about who will gonna get CAR T-cell, or who's the candidate people for the CAR T-cell. Until now, we don't know who's the candidate, either early people with poor or very poor refractory, or like a marker for, if we do have a marker or genetic marker that indicate those patients will get poor disease or very complicated disease. So we can offer them before they got all the regimen for the biological therapy for SLE. So actually in our center, we do have a trial. So each trial, they do have their own inclusion criteria. So we don't prescribe it as in a standard care of therapy. So in order to those patients to get the CAR T-cell, they're supposed to be under the trial, and those trials, they have a criteria. So we don't control those criteria.
تمام good. Anybody have one? تفضل دكتور.
You present different medication in lupus nephritis, from chemotherapy, immunosuppressive, and biologic. And we know that lupus nephritis, it's part of manifestation of SLE. Is there any study showing the effect or the best medication for the other manifestation of SLE, like vasculitis, pulmonary hemorrhage, and lupus nephritis?
Sure. Thank you for the question. We don't have a study that compare these kind of medications head to head for extra lupus or extrarenal manifestations like arthritis or like cerebritis. Having said that, we know that we know that CNI effect and impact on extrarenal manifestation is limited. So if you have a patient who has active arthritis, not controlled enough by the standard therapy, adding CNI probably will not be the best here. Belimumab has been shown to act well on those patients who have arthritis. How about cerebritis? We usually, when the patient has cerebritis, the rheumatologist will take over the care of the patient. And correct me if I'm wrong, when we have very bad head like this, we usually tend to use cyclophosphamide as an induction therapy for those cases.
In our hospital where I work before in King Faisal, دائما قديمك نديمك هو we use the cyclophosphamide when there is multi-system involvement. The second question to Dr. Fatima, with the reported cases of lymphoma and high cost of CAR T-cell, will put this as less encouraging to use in SLE patient?
So the question one?
The reported cases of lymphoma and high cost of CAR T-cell.
Yeah, so actually in lymphoma or in hematological malignancy, they report 22 cases only. And it's been more than, I think, 20,000 of patients, they got the CAR T-cell. So it's small number compared to the number of the patients, they got the CAR T-cell. So far, we don't have any reported case in autoimmune disease, although we don't have the same number that it has been reported in hematological malignancy. The cost, yeah, it's still high, but compared to putting the patient on remission, no immunosuppressed medication, no infection, no hospital admission, no hemodialysis, that will be, I think, a wonderful. But in between, we do have something called a T-cell engager, which it's not very expensive like CAR T-cell, and not like rituximab or B-cell, which you can get some remission with that treatment.
Hey, Doctora?
Thank you.
Can you give?
Thank you very much for the excellent lectures for all the three presenters. But my question for Dr. Fatima, what's your goal for CAR T-cell? How many patients per year?
Thank you so much for asking this question. For now, CAR T-cell therapy, it's not proven in our country, and it's not yet proven as a standard of care therapy. But we do have a clinical trial, and based on the clinical trial, usually they give us number, and they give us the indication who the candidate for the CAR T-cell therapy. So we don't have a clear target. But if you have any good candidate, you can just email us or refer this case for CAR T-cell, and we will review the case, and if the patient is eligible, we can put her in the trial.
Thank you.
Absolutely.
Doctor, I think this is the last question.
Thank you very much for your presentations. My question is for Prof. Mayouf. So the patients Prof. you presented, some of them were almost about to be transitioned to adult care, so they're like 13, 14. And sometimes we discuss with our colleagues and adult patients who I do believe that they have underlying genetic mutation, but they don't go for genetic testing. I'm not sure what is the practice in adult among like other colleagues. Are they doing genetic testing if there's suspicion?
Well, I think the vision now a bit different from the previous. So people, they are starting thinking about these diseases. They may present with late presentation and starting considering genetic testing. And of course, those with well-established diagnosis, they will take care of those patients, especially with people like Dr. Fatima has two specialty, immunology and rheumatology. But I'm sure now the new era, people are more aware about genetic defects as cause or maybe explanation for many entities labeled in the past as overlap or maybe lupus or whatever people need to think about it.
Thank you very much. Thank you, speakers. Excellent talk. And thank you, everybody. I think now we move to our next session, which is JSK.
Thank you, Prof. Sami. Thank you for all speaker. Now time for satellite presentation. The first satellite will be sponsored by GSK company, presented by Dr. Maida Khalifa. He is consultant dermatology internal medicine, King Saud Hospital, Unayzan Qasim. Welcome, Dr. Maid.
Assalamu alaikum. Good morning, everybody. First of all, I would like to thank Dr. Muhammad and Dr. Abdullah for keeping this conferences updated and continuous. And welcome to our lovely region, Al-Qasim. And we'll talk today about some slides in updated SLE and the management of SLE. It's sponsored by JSK, and this is my disclosure. In the classic teaching, we said the SLE is the disease of 1,000 face. So each single organ can be affected by SLE. And if you leave this disease uncontrolled, more organ damage will happen to the patient. And the organ damage, actually, it's not from the SLE per se, but also from our medication that we are giving it to the lupus patient. And we are giving a heavily immunosuppressive medications like a cyclophosphamide and others. The organ damage is actually from the SLE or from the medications. And once the organ damage it happens, it's lead to the further damage, decrease the quality of life, and the early mortality can happen. And they said actually almost a 60%, despite of the standard treatment, they have some frequency of a flare, and especially in the first few years of the diagnosis. And we know the bad form of SLE, usually it happens in the first 5 years. And most of those patients, more than 80 patients, they are keeping using the steroid in the beginning of their diagnosis. And there is a meta-analysis of 10 studies. They said only a 1-point increase in the death, in the damage index lead to a 34% increase in the death risk. So that's why it's very important to control the disease from the beginning. And the slide actually it shows the damage it can happen from the SLE and from the medication. And can you believe the simple medication, the glucocorticoid that we are giving it to many of our lupus patients, even the small doses from the 2.5 milligram to the high dose, the 30 or more than even 30 milligram, it can lead to a variable side effects from the simple hyperglycemia to the vascular necrosis. And one of the commonest side effects that we are dealing with, it's the osteoporosis that induced by our medication. We have many institutes, actually Dr. Muhammad already mentioned about the KODAIGO, and we have the EULAR, we have the ACR. And from those institutes, actually, we are taking our guidelines for treatment of the lupus nephritis mainly. In the EULAR guidelines in the 2013, they said in each visit you have to assess the lupus activity in each visit. And at least the organ damage, it should be assessed annually. And we know the treatment is a case by case. It's dependent on the presentations of the patient. And the early diagnosis, early management lead to a good and better outcome, minimizing the risk of flare and improve quality of life to those patients. Again, actually, in the EULAR recommendations, you are familiar with that. Actually, they divided to the non-renal and renal. And in the non-renal, actually, we have many manifestations like in the musculoskeletal, cutaneous, and other. And our aim in the non-renal to use a steroid less than 5 milligram per day. And they said in the non-renal, yearly initiation of the immunosuppressive medication, our standard of care like the hydroxychloroquine or others like the methotrexate, azathioprine, actually help us in minimizing, and we are using it as a steroid-sparing agent. So it's helping us to minimize the dose of steroid. And they said the belimumab as well, it's one advantage of this medication, it helps to minimize the dose of a glucocorticoid in lupus patients. this slide, we have a general, this is in the non-renal, we have a general measurement. We are using it to all of our patients, avoid the sun exposure, exercise, avoid smoking, and actually they divide it to the mild, moderate, severe, depend on the disease activity index. And if you see the hydroxychloroquine, this is our traditional practice. It's a part of all line of presentations, and the steroid, either oral or IV, with the variable doses, also it's there. And if you see the traditional treatment like methotrexate, azathioprine, and MMF, it's there. And now we have many biologics that approved in SLE. We have a targeted therapy like belimumab and everolimus, and in the refractory we have others treatment. And actually our target in the EULAR recommendation, either to achieve a remission or at least a low disease activity, and these are the definition of both. This is in the lupus nephritis. Again, in the lupus nephritis, as Dr. Mohammed Al-Khawaitar already said, our aim to use a smallest dose of steroid to those patients, and early initiation of the triple therapy, the immunosuppressive medication that include belimumab. It helped us actually to use a low dose steroid, either in the induction or even in the maintenance. And the maintenance in the EULAR recommendation, it's different from the KODAIGO recommendation. Here they said it's at least 3 years, either plus MMF or azathioprine. This is actually one of the commonest slides. We are using it in whenever we have presentations about lupus nephritis. We have adjuvant therapy, we know, like the ACE inhibitor and others, and the initial or the induction and the maintenance. If you see, we can use a belimumab either with a cyclophosphamide or MMF. This is in the induction, or we can use it for at least 3 years in the maintenance with MMF or azathioprine. And our target actually to achieve a proteinuria in 3 months, or reduction in the proteinuria more than 25%, in 6 months more than 50%, and in 1 year actually our aim to achieve a proteinuria less than 500 milligram per day. This is another institute already mentioned by Dr. Mohammed Al-Khawaitar about the KODAIGO, and actually it was a little bit similar for with the EULAR recommendation, and this is a history actually of the belimumab using it in lupus nephritis. Belimumab, they said initially it was approved in 2020, and in the KODAIGO they said we can use in 2021 we can use the belimumab in lupus nephritis. In the EULAR recommendation, they advised to use it, but in the 2014 actually it was a part of their treatment in lupus nephritis. Again, this is in the KODAIGO. If you see it, it's almost similar to the EULAR recommendation. Our aim to use a low dose steroid in those patients. We initiate with the triple therapy, and the maintenance actually it was 2 to 3 years. And they add a class 5 in KODAIGO recommendations, and it was mainly for the high-risk patients. And this is the dose administration, or our aim to use a low dose steroid. And if you see the KODAIGO, actually the benefit of adding belimumab as early as possible, or it will be a part of our early medication, it's helped us to achieve a complete renal response more than 70%, kidney protection in more than 50%, and the preserved kidney function in 60%. And as I said, it helped us to minimize the dose of steroid. If you see this line, actually, if you see the microangiopathy line, it's out from the beginning, and even the chronicity of lupus nephritis. Mainly, we are dealing with the active form of lupus nephritis, either class 3 and 4 plus minus 5 as well. And if you see in the purple color at the end, the belimumab, we can add it from the beginning of our diagnosis in lupus nephritis. And some slide about only the history of belimumab. It was studied initially in 1990, and in 2000 it was actually it was the first biologic approved generally in SLE. In 2017 we have the injectable form of belimumab, and in 2019 was approved for the pediatric age group, and we got approval in 2021 in the lupus nephritis. And this is what I said actually. Now we are moving from the traditional to the targeted therapy. And we know that traditional therapy, many medications we are using it till now actually, like the hydroxychloroquine, Imuran, or azathioprine, others. And we are moving now to the targeted therapy. And why we said it's the targeted therapy? Because we find the belimumab, it's act only on the autoreactive B cells. We know we have many B cells in the lupus patient, but not all those cells are active. For one advantage of the belimumab, actually, it's act only the autoreactive B cells. For once we block those receptors, actually, we are minimizing the cytokines that lead to active manifestations. If you see it here, active manifestation in the cutaneous, in the musculoskeletal, or in the kidney. For once we block only the autoreactive, actually it helps us to control the disease with those manifestations. So that's why we call it's a targeted therapy, because it's act only, and if you compare it like to the rituximab, it causes a pan depletion in the B cells. But in the belimumab, this is one of the advantages. And this is actually, it's not practical, and I don't think we are using it, we're measuring the bliss level, but they said once you have a bliss level more than 2 nanogram per milliliter, actually it's give you a hint that the lupus may flare. And not only clinically, but one of the advantages of belimumab, it can minimize or decrease the anti-double strand level and improve the C3 and C4. So this is the summary from the KDIGO and from the EULAR recommendations in SLE in general. Belimumab, it helps us to minimize, or we're using a steroid-sparing agent, minimize disease activity, and this is the organ, it shows a good efficacy with belimumab, the joints, skin, and kidney, and decrease the organ damage. And this is in the lupus nephritis. If you see the percentage, all it show the favorability to adding or using belimumab from the beginning. And thank you so much.
Thank you, Dr. Moayed. The second satellite will be sponsored by Janssen Company, will be presented by Dr. Mohammed Al-Mansour. He is consultant rheumatology internal medicine, King Fahd Medical City. Mike is yours, Dr. Mohammed.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa sallallahu ala Rasulullah. Thanks, Mr. Chairman, for this arranging nice conference. And thanks, Janssen, for having me today. So my talk about gizolukumab and management of BSA. I will start my presentation with 2 cases from our clinic. So 35 years old Saudi male patient with 1-year history of skin lesions started in his scalp, trunk, as well as lower limbs. His scalp showed erythematous scaly plaques in occipital area demarcated, as well as over his trunk with lower limbs bilaterally. He has 2 nail bitting, as well as 1 nail with anecholysis. Started initially by his dermatologist on local therapy, including betamethasone, and his BASI score that time is 18.3. The patient was referred to a rheumatologist. He had some joint pain involving the small joint of the hand bilaterally, BIBs and DIBs, with morning stiffness for around 1 hour. He had also dactylitis, which is an inflammation of the whole fingers involving his left toe. In the clinic, we did a musculoskeletal ultrasound that showed there is a tenosynovitis of grade 2 and peritendinous edema in the left third toe, as well as tenosynovitis involving multiple joints of the hand bilaterally, with minimum erosion in the 4th and 5th DIBs. So this is a similar photos not for the patient, but for a similar presentation. His lab initially showed very high inflammatory markers of CRP of around 27, ESR of 61, autoimmunity, ACPA, and rheumatoid factor were negative. So renal liver blood counts were normal, serology for hepatitis, HIV, quantiferon negative, DAPSA score is 26, which is around moderate disease activity, as well as a BAS-DAS of around 4. So we diagnosed him with BSA, as you know all, by his Casper criteria. He's meeting around 4 points. So patient was started initially in methotrexate, and we started him in 15 milligram, then we increased it to 17.5 with mild improvements over 6 months for his skin and arthritis. So we decided to start him in biological therapy, in gozalocumab. We give him an injection every 0.4, then every 8 weeks. And we saw him in the clinic after 16 weeks. His skin improved, BASI scores around 50, and his dactylitis is improved. DAPSA score dropped from 26 to 10, and BAS-DI as well dropped to half. So next visit after 6 months, his symptoms also improved regarding skin joint as well as his dactylitis. The second case is MB, 42 years old man with severe psoriasis, started 3 years back, seen by his dermatology in the region. He is from the eastern region, started topical therapy without improvements. Then they decided to start him in conventional DMARDs, methotrexate, but he developed high liver enzymes. So his labs initially showing high inflammatory markers, negative autoantibodies, renal liver complete blood counts were normal, DAPSA score around moderate activity, and BAS-DAS of around 4. So started in gozalocumab with good improvement in his skin and peripheral joints within 6 months. So he was complaining of lower back pain, which is inflammatory in nature. We request X-ray, didn't show anything, but his MRI, it showed that an active sacroiliitis bilaterally, which is non-axial or axial involvement of BSA. This is his MRI. In the first left, it's T1, then then T2 stair in the middle, and then T2 stair in the middle, then T2 coronal section stair, the last one on the right side. And you can show the hyper-intense lesions in both sides of the sacroiliac joints, which showed that there is an active sacroiliitis. We saw him after 6 months. Actually, his skin is much improving, and actually we decided to continue him in the same biologics, as he's improving also from the back pain. So what are the data of Tremfya? As you know, we have multiple phases, phase 2, phase 3, Discover 1, 2, as well as Cosmos studies with APEX trial. So what we will go through today is for Discover 2, which is more than 700 patients. They compared gozalocumab every 4 weeks, 8 weeks with the placebo, and the primary endpoint was ACR 20 at week 24. So the efficacy, as you know, as you can see here in the diagram for ACR 20, 50, and 70, it was met with both doses of gozalocumab versus placebo, as well as a secondary endpoints regarding ACR 50 and 70. Also, it was maintained up to 100 weeks regarding the ACR 20, with around 80% of patients was completed the trials up to 100 weeks, with around 70 to 80% improving in ACR 20. Not only this, but also for the secondary endpoints regarding ACR 50 and ACR 70, enthesitis and dactylitis also, it showed like greatly improvements over 6 months, 1 year, and almost 2 years in both sides of enthesitis and in both regimen of 4 weeks and 8 weeks gozalocumab. Skin, it showed like greatest improvements regarding the skin psoriasis, started from 6 weeks, 1 year, and up to 100 weeks. Haki DI score also, it was met with around more than 80% of them. It showed like greatly improvement compared with placebo, and minimum disease activity was met as well. So in bio-experienced patients in Cosmos trial, also it showed like great improvements with primary endpoints of ACR20 at week 24. It was met in both groups of gizilocumab versus placebo, and it was achieved for around 50% of them. They have met the primary endpoint, and they extend the efficacy up to 1 year. Resolution of enthesitis and dactylitis through 1 year, even for the bio-experienced patients. It was met in both in 6 weeks, in 26 weeks, 24 weeks, as well as 1 year, as well as comparing enthesitis and dactylitis in both arms were met. So in axial BSA, like in our patients, so as you know, we have the post-hoc analysis from Discover 1 and 2, and it showed that there is some improvement for the axial BSA regarding the involvement for BAS-DAS as well as DAS scores in patients with BSA with axial involvement. So as you can see, the BAS-DAI post-hoc analysis from the trials, BAS-DAI 50 and ASDAS clinical improvement, as well as ASDAS-MI with major improvements, and inactive disease, all of them, they met the improvement regarding the BAS-DAS as well as the ASDAS outcomes. We have the STAR, which is the axial involvement in BSA. It's still ongoing. And the primary endpoint was a change from the baseline in BAS-DAI in week 24 throughout 1 year of a study and up to 60 weeks. And it's still ongoing, but it will be resulted in next maybe few months. Most patients started in Tremfya and stayed for long term with high retention of around 8 to 9 out of 10. And safety profile, they don't have like active tuberculosis, anaphylaxis, or cases of IBD, which is very important. They don't have like any reported cases of IBD. The most common side effects is, as you know, the upper respiratory tract infections and mild infection that they didn't require hospitalization or ICU. What are the molecular differentiation of IL-23? As you know, we have around 3 or 4 of them. Different between gizilocumab and risankizumab. As you know, the gizilocumab is fully human, while Driza is humanized, which is around 80 to 90% with murin protein. And the joint response of interleukin-23 inhibitors in TNF refractory failure. So it showed improvement of around 45% in gizilocumab group versus placebo. And as we mentioned before, this is in Cosmos trial, but there is no data for the other molecules. In stopping radiographic damage, which is very important, from Discover 2, they have like a good improvement for the radiographic progression in Tremfya versus placebo. And this is an update from the EULAR guidelines in 2023 regarding the radiographic damage, as you can see here in the So the gizilocumab, they have some radiological improvements with axial involvement BSA. It's not yet recommended, but at least they showed some improvement. For ABEX overview, which is the most important trials that we have to go through, it's a multi-nationality, multi-center, randomized, placebo, double-controlled trials in more than 1,000 patients, multi-countries, around 29 patients, 29 countries, comparing gizilocumab with the placebo with confirmed diagnosis of BSA, at least first-line biological therapy with data of baseline as well as 6 months, 1 year, and up to 168 weeks. Study started in June 2021, and it will be resulted, inshallah, in 2027. So what are the patients? They include all patients with BSA, with active disease, erosion of more than 2, and active plaque psoriasis. The idea of this studies is to show the radiographic improvement with gizilocumab versus placebo. The primary endpoint was ACR20 in week 24, as well as Van der Haege score decreasing at week 24. So efficacy data from this trial, APEX trial, it showed like primary endpoint was met in both groups or both regimen of gizilocumab every 8 weeks or every 8 or 4 weeks compared with the placebo. And it was met the primary endpoint, which is ACR20 at week 24, as well as secondary endpoint of ACR50 and ACR70. And Van der Haege score also, it was decreased in both doses of gizilocumab compared with the placebo. For Van der Haege score, as well as a secondary endpoints, which is erosion score and joint narrowing or joint space narrowing score. So as you know, the dosing is starting 0.4, then every 8 weeks. There is some off-label to use every 4 weeks, especially in severe joint damage. This is my last slide, and thank you very much.
Thank you, Dr. Muhammad. Now break for 15 minutes.
Assalamu alaikum. So now we'll start the second session. I am glad to present Dr. Maha McKenzie. She's a consultant rheumatologist at Secretary Force Hospital, Riyadh. She is specialized in idiopathic inflammatory myopathy. She did rheumatology fellowship at George Washington University, USA. She's active in international research publication. Please, Doctora.
نبدأ عشان الوقت يعني خلاص. السلام عليكم ورحمة الله وبركاته. It's my pleasure to be here today, and I would like to thank the organizing committee, Dr. Sultan, for the invite. Today I will be talking about the myositis therapeutic landscape, current standards, and emerging targets. So my objectives for this talk is to appreciate the gaps and the challenges that limit our current immunosuppressive medication, to recognize the current therapeutic standards that we are using, to understand the evidence that support the commonly used immunosuppressive medication, and to identify emerging novel therapies in clinical development. So as most of you know, idiopathic inflammatory myopathy is a rare, very rare disease compared to other autoimmune disease, and very heterogeneous disease. It commonly affects the skeletal muscle, however, other organ involvement is very common, and the management is very challenging due to poorly and limited understanding of the background pathogenesis, and there is significant diagnostic heterogeneity between the subtypes. Our goals of management in idiopathic inflammatory myopathies mainly rely on reducing inflammation and controlling the skin. Sometimes myositis is a muscle involvement, very good controlled with medication. However, the skin in dermatomyositis part is very difficult to control. Restore and preserve the muscle strength, prevent organ involvement and damage, and to reduce morbidity and treatment toxicity for these patients, and finally to improve the overall quality of life for these patients. Our management strategy heavily relies on the pharmacological therapy. However, exercise and physical therapy plays a major role in restoring the muscle function for these patients. Photoprotection is very important in dermatomyositis patients, and malignancy management in high-risk patients. There is significant challenges in the management. First of all, it's a very rare disease. Recruitment and clinical trials is very difficult for these patients. There is significant inconsistencies between the classifications. For a long time of period, the mimickers and the overlap included in the classification criteria. However, the latest classification criteria in 2017 highly depend on the muscle biopsy, excluding or underrepresenting the necrotizing myopathy and the amyopathic dermatomyositis. There is significant heterogeneity between the subtypes, and there is different heterogeneity between the pathology of the background of these subtypes. There is diverse autoantibody profile, with each profile have a specific phenotype and prognostic factors, and there is significant inconsistencies between the treatment guidelines. There is different treatment guidelines worldwide. There is the German Society for Neurology and Dermatology. There is the European Neuromuscular Center guidelines. There is the Brazilian Society guidelines. There is the Japan College of Rheumatology. And finally, the British Society of Rheumatology. Very importantly to notice that IPM is excluded from most of the guidelines because of the limited effect of pharmacological treatment. Although there is significant difference between the treatment guidelines between the countries and the subspecialties, this is all expert opinion. It's not a randomized clinical trial driven. They are all agreed on the glucocorticoids as a first-line treatment with a target of tapering off between 3 to 6 months and inducing DMARDs as early as possible for these patients. Biologic treatment usually reserved for refractory diseases. The most used conventional DMARDs is methotrexate, have been shown efficacy in muscle and joint for this population. Azathioprine and mycophenolate as a second options usually for skin and ILD patients. Cyclophosphamide, cyclosporin, tacrolimus can be used for refractory disease for skin and ILD. Hydrochloroquine as an adjuvant in skin in dermatomyositis, and leflunomide, very weak data. Biologic DMARDs, different targets have been used, which shown proven efficacy is rituximab as a CD20 inhibitor, and abatacept as a C6 inhibitor, and IVIG. There is different ongoing clinical trials, including the interferon inhibitor, anti-FcRn, and complement factor 5. Synthetic targeted DMARDs, JAK inhibitor, have been shown in efficacy in clinical trials, prelim data. The ongoing data on the parasitinib, tofacitinib, ligotinib, and reloxatinib in IPIM. TYK inhibitor, TYK2 inhibitor, there is a positive result recently published this year, and we'll come to that, is a preopsitinib as a very good data on that. There is a multiple active clinical trial ongoing on myositis. However, the recent clinical trials on myositis, all of them came back negative, except for IVIG. Tocilizumab did not show efficacy on dermatomyositis patients and did not meet the primary or secondary endpoint. Rituximab, although did not meet the primary or secondary endpoint, it showed progressive improvement in the patient studied. Abatacept also came back with negative outcome, however, it showed some improvement. Ustekinumab was terminated early because of the fatality. Belimumab did not meet the primary or secondary endpoint and did not show improvement in the studied population. And zilucoplan, which is a C5 inhibitor, was negative. The first IVIG clinical trial that was done, which led to the approval of the US FDA for IVIG in dermatomyositis. The results of this study showed improvement of the total improvement score, 80% on the IVIG arm compared to the 44% in the placebo arm. What's the total improvement score? It's a composite score. It's very common to be used in myositis patients. It's subjective and objective. The subjective part is the physician outcome, the patient-reported outcome, the quality of life hack, and the subjective outcome, including the CK level and muscle enzyme level, MMT, which is a muscle power, and extramuscular involvement. IVIG in ILD. IVIG studied on antisynthetase ILD, which showed stabilization and improvement in the function, with some of patients get more than 10% gain in the functional capacities. IVIG in ILD, this is post hoc analysis for the ProDerm study that led to the approval of IVIG. Given the improvement in the muscle and cutaneous, it did show by 16 weeks mean pulmonary fast decline up to 37% in the IVIG arm compared to the placebo arm. And by the end of the study, which is 40 weeks, it shows sustained benefit. How about abatacept? As we said initially, abatacept did not meet the primary or secondary endpoint, which was negative trial. However, this is published on February of 2025, which showed beneficial benefit on post hoc analysis for necrotizing myopathy and polymyositis. Abatacept in ILD, this is a follow-up study on the ATTACK-MY-ILD, which initially showed no significant difference between the primary endpoint. However, by the end of the study, 48 weeks, it showed the trend favoring abatacept with decrease on the pulmonary function. However, it was not significant statistically. Rituximab. Rituximab, this is the largest trial done on dermatomyositis and polymyositis patients in 2013, the RIM trial. It included almost 200 patients. Although it did not meet the primary endpoint, it showed up to 83% patients achieve the clinical outcome benefits, including the skin and the muscle, as well as reduce the glucocorticoids dose. Rituximab in ILD studied on antisynthetase, specifically in NT-RO, which showed a clinical meaningful benefit in ILD associated with antisynthetase syndrome. Calcinuric inhibitors, this is an older study done in 2013, included 15 patients. It showed 13 out of the 15 patients with antisynthetase experienced either stabilization or improvement in the forced vital capacities. How about emerging new treatment strategy? There is a significant number of clinical trials ongoing. JAK inhibitor is one of the most studied recently. This is the first trial on the JAK inhibitor, which is the third trial. It's an open-label clinical trial which showed a strong efficacy on banned JAK inhibitors, specifically the tofacitinib, which is validated by the myositis response criteria. However, this is published this month, actually. It's a selective TYK2 JAK1 inhibitor. This is a trial, phase 3 trial, and 52 weeks of oral preupicitinib, 30 milligrams, significantly outperformed the placebo, with a TIS score of 46 compared to 31. The benefit include skin, muscle, and steroid reduction. Dozukibart, it's an interferon beta inhibitor, and a recent study ongoing on the phase 3 trial. However, phase 2 trial showed reduced activity on these patients, which make it a good target for therapy. And then the fragmented crystallizable receptor inhibitor. They are human monoclonal antibodies that target neonatal Fc receptors. The function of the neonatal Fc receptor, they recycle the IgG, which prolong its half-life, and by targeting this receptor, it reduces the circulating pathogenic IgG autoantibodies. This study was at an abstract presented in this TLR 2025. It showed phase 2 portion. The main TIS score for the patient treated with these antibodies, 50% compared to the 35 of the placebo arm, with a good tolerability side effects. Antifibrotic in ILD. Antifibrotic made its way on the 2023 chest ACR for the ILD disease. After this pilot study, this pilot study included 36 patients treated with nintedanib. Compared to 115 patients, it showed significant reduced incidence in rapidly progressive ILD with improved survival, which led to this trial, which is ongoing on nintedanib, is the MINT trial. It's still ongoing, and possibly having a result within maybe by the next ACR or ULR. What we know about immune-mediated necrotizing myopathy. Immune-mediated necrotizing myopathy associated with very high CK, no inflammation in the muscle biopsy with the necrotizing and regenerating, degenerating muscle fibers. It's been subcategorized according to the autoantibodies into SRB positive, HMGCR positive, or seronegative. The main treatment here is a corticosteroid with a taper target between 3 to 6 months, and to add DMARDs as early as possible. The main DMARDs has been studied well is the methotrexate, and as alternative you can use Imuran or Cellcept. Rituximab showed efficacy in anti-SRP necrotizing myopathy, and HMGCR showed a benefit with the IVIG. And for the HMGCR, always recommendation to stop the statin. This is a very small study on the plasma exchange for the refractory immune-mediated necrotizing myopathy. It's done in 6 patients. Refractory patient with high CK, it noted that there is significant improvement in the CK level among these 6 patients, which may be considered in our refractory patient. Including body myositis is one of the subtypes that's very refractory to our autoimmune pharmacological therapy. The main management here is supportive. There is a limited effect of the pharmacological therapy. IVIG can be used for dysphagia. It can give temporary effect. However, usually it doesn't last. What have been studied and showed no effect is a myostatin inhibitor. By inhibiting the myostatin, you improve the muscle growth, which is a very important issue for these patients who have significant atrophy with prolonged disease. Protease heat shock receptor modulation, it acts by enhancing the protein folding and prevent the misfolding of the protein. These studies did not show any effect for these patients. However, there is a promising approach with targeting the KLRG1 cells, which is abundant in the pathology of these patients. There is a phase 3 trial on the mTOR inhibitor, the sirolimus. Sirolimus acts by inhibiting the by improving the autophagy and decrease oxidative stress on the myofiber. Follistatin gene therapy, it acts by inhibiting the myostatin, so promote the muscle fiber regrowth. I can't talk about the emerging strategy without talking about the CAR T cell. And after the initial talk this morning, I can't add more about the mechanism of the CAR T cell. So what we know about CAR T cell in idiopathic inflammatory myopathies? From the evidence we know on autoimmune disease, specifically lupus disease, they have very good and promising data. We looked at the myositis benefit from the CAR T cell. There is a very few case report and case series on CAR T cell and myositis. Main studies were antisynthetase, necrotizing myopathy with NTSRP, juvenile dermatomyositis. What's shown over benefit-wise from the CAR T cell, they had remission for most of these diseases with drug-free survival up to 15 months. They had seronegative conversion for some of the patients, and in the skin, they have complete resolution of the skin rash. In terms of muscle, as you can see, they have normalization or near normalization of the CK, and in terms of the muscle power measured by the MMT, they have normalization or near normalization of the MMT. In terms of the ILD associated with the antisynthetase, these patients have significant improvement in symptoms as well as in radiological features. What we know about myositis in Saudi Arabia? There is a very few studies that done in Saudi Arabia about myositis patients. It's a rare disease. There is a limited number of patients on these studies. Although much appreciated effort done, it's an epidemiological studies mainly looking for the subtypes and the myositis-specific autoantibodies correlation and the cancer association. Which from this, I would like to call for building a nationwide myositis registry, which will help us in updating the Saudi epidemiology data and to identify the clinical spectrum, the autoantibodies association, the cancer association, and the genetic behind these patients. And also to capture real-world outcome to guide the Saudi-specific practice. And this can be done by multi-center collaboration, standardization of the data collection, and enable research and trial participation. Finally, I would end with take-home message from this lecture. The glucocorticoids and conventional DMARDs remains the backbone for our treatment. FDA approved and showed benefit across the skin, muscle, and ILD. Rituximab, abatacept, cyclophosphamide, calcinuric inhibitor plays an important role mainly for refractory and ILD disease despite mixed trial outcome. And emerging therapy including JAK inhibitor, interferon blockade, FcRn inhibitor, CAR T-cell, and antifibrotic are reshaping the therapeutic options. And hopefully we'll see some promising results by next year, including myositis. It's a lack of effective pharmacological treatment, and the treatment lays mainly on the supportive management. Thank you.
Assalamu alaikum wa rahmatullah. First of all, thanks for the invitation. Your meeting is always inspiring and always informative. I would like to introduce the second speaker, Dr. Lujain Akbar. She's a consultant pediatric rheumatologist from King Fahd Hospital of the University Al Khobar. She is going to take us through the unresponsive patient navigating a complex juvenile dermatomyositis patient. Welcome, Dr. Lujain.
Assalamu alaikum. Thank you, Dr. Mohammed, and I would like to thank the scientific committee for their invitation. This is not my first time in قصيم. دائما نشكركم على حسن استضافتكم. فالله يعطيكم العافية دكتور محمد، دكتور عبد الله وجميع الأعضاء. فبسم الله. Navigating complex JDM. JDM, which is juvenile dermatomyositis, so I have no disclosures. Now, these are the outlines. I will try to highlight on some practical points that are relevant to adult rheumatologists when these patients are transferred to your care. So why do we focus on refractory JDM first? It is the predominant form of juvenile idiopathic inflammatory myopathies as an adult. And second, up to 30% of these children will continue to have a refractory disease although they're being treated with DMARDs. Now, in one prospective cohort, after 10 years, it showed that these patients, up to 60%, will have still persistent disease, and they were in their adulthood by that time. They were transitioned already, and they were on DMARDs. Now, these kids carry a huge psychological impact, and also the disease is beyond the functional instability or disability, so they lose their independence. And one of the challenging aspects here is the psychological factor. So they cannot really express their anxiety about the disease, what are their thoughts. And also, one of the unique complications in these patients is calcinosis. And probably these patients will be referred with the later complications like calcinosis to your care. So JDM is not equal to adult dermatomyositis. They both share the myositis, the pathognomonic rash. However, they have some similarities and differences. These are listed in the table. I will not go into details in the list, but I just want to focus on 2 points. First, vasculopathy. Patients with JDM, vasculopathy plays a major role and a crucial role in the pathogenesis. And these patients might have, like, for example, manifestations like GI bleeding, perforations, which carries a high risk of mortality. And the second point is mitochondrial dysfunction. This has been an area of interest in pediatrics in the past years. So they found that enlarged mitochondria, or the megamitochondria, causes increased interferon signature, which will cause more refractory disease. And also patients with calcinosis were found to have some calcifications within these mitochondria. So this might be a new target or approach that we will have within the next near future. Now, moving to features, it is interesting how some myositis-specific antibodies that are shared behave differently among both age groups. For example, in antitif gamma, you're watching for malignancy. Pediatrics, we're not watching for malignancy. In fact, we do not link patients with JDM with malignancy unless there is something atypical, of course. So moving to a case presentation. This is a 10-year-old Syrian boy who was diagnosed abroad initially as a case of JDM based on cutaneous manifestations, muscle weakness, and elevated muscle enzymes. So he received corticosteroid pulses, IVIG, MTX, and hydroxychloroquine. However, due to his refractory and progressive worsening, he was switched to CellCept 3 months after initiation of MTX. 6 months after switching to CellCept, he was referred to my clinic. That was in October last year. So I will summarize collectively his findings. First, we'll start with cutaneous. So you can see that the CAT score was 11. He had most of the manifestations in JDM. So he had ulcers, active ulcers, and cutaneous ulcers. He had obvious telangiectasias, which indicate severe vasculopathy, as well as nail fold capillary loss. He also had other manifestations. Now, he had an interesting finding. He presented with nose and lip swelling, which is honestly not really common to see in JDM, but if it's there, it might indicate severe vasculopathy, which is actually the case in this patient. So moving to muscle, the CMAS, or the Childhood Myositis Assessment Scale, which is corresponding to, or like the MMT in adult, was very severe, 2 out of 52. He was almost bedridden when he presented. Muscle enzymes, he had burned out disease, almost normalized. He had a positive anti-TIF gamma antibodies. ANA was strongly positive with negative extractive and nuclear antigens. Now, this will be relevant later for the course. MRI, as you can see, he had proximal and distal severe myositis with muscle atrophy. Actually, all image muscles had severe myositis. He also had, as you can see, fasciitis and also generalized subcutaneous edema. Now moving to GI, before he presented, 2 months before presentation, he had severe abdominal pain on daily basis. At that point, when he presented to the clinic, it was obvious that he had severe disease. We got him in. On the day of admission, he had an active lower GI bleeding. So CT abdomen with contrast showed enterocolitis. Other workup was unremarkable, really. Our colleagues from gastroenterology were not willing to go in because this is relevant to the disease, and they were concerned about the active vasculopathy/vasculitis. So we started at this stage because it's a life-threatening complication, the bleeding, methylprednisolone pulses, IVIG, IV cyclophosphamide. We resumed MTX, but it was subcutaneous rather than oral, and hydroxychloroquine. We continued from there on cyclic pulses, and the rationale is that these patients will not absorb medications, so we have to guarantee their delivery. And initially we started every week, and then we spaced it. Now, subcutaneous MTX, to be honest, was questionable whether he will absorb it with the generalized edema, but it was at least better than the oral medications. Unfortunately, 2 months after that regimen, he had a vertebral compression fracture, which added to the burden of disease. He had severe back pain, inability to mobilize for almost 2 months. Probably it was due to the cumulative dose plus the pulses that we have introduced. Fast forward, after 6 months, he was doing better. So you can see the scores have been improving. There's no GI symptoms. Vasculopathy has improved. However, in terms of severity, he had severe skin and myositis specifically. Due to logistic reasons, eligibility issues, we could not offer him IV biologics. So one of the limited options really was adalimumab. And this is one of the differences between adult and pediatrics. We do utilize anti-TNF, especially in calcinosis. So 2 months after adalimumab, unfortunately, he again started to get worse. So he had cutaneous ulcers, again, GI bleeding, progressive weakness. After a month of arrangement for rituximab, we finally got it through Jam'iyya, which I'm really thankful for, back in June. I was optimistic, to be honest, initially, but again, he continued to regress, or continued to not improve, at least. So in terms of GI, now it is early true for us to judge rituximab effect within 2 months of administration. Some patients will require anywhere from 2 to 5 months, but still this progressive disease refractoriness deserves reevaluation. So we got him again, and GI, he had chronic GI bleeding over the past 2 to 3 months with anemia that required transfusion, and CT showed improving enterocolitis. Other parameters also were reassuring. So it was obvious that he needs time after these interventions. Muscular, subjectively, he was feeling much stronger, but our parameters, objectively, he was not improving. CMAS was static. MRI showed actually progressive and worsening muscle edema. So at this stage, we went for muscle biopsy. Are we dealing only with JDM, or there is something additional? We did not have all the stains during that time. So what we got is that it is inflammatory immune-mediated myopathy, no grading for severity, no details. He developed also new calcinosis. Now, calcinosis is expected at this stage because usually it's around 2 to 3 years after diagnosis, and it is a consequence of an old battle that has not been treated. So it was not surprising. What was really surprising was the renal manifestations. So he developed new onset proteinuria, hematuria, mild. This is not part of JDM. So we were entertaining the possibility of either drug-induced nephrotoxicity from MTX, or for example, drug-induced lupus from adalimumab that has been recently introduced. We did renal biopsy, of course, and it was suggestive of immune complex glomerulopathy or glomerulonephritis. Again, that month we had shortage in stains. We did not have immunofluorescence, so I cannot really label the patient as lupus nephritis. But given the background that he had the newly developed anti-double-strand DNA, which was negative 6 months back, and the positive low complement, probably we're dealing with the lupus myositis overlap, more severely myositis. So one of the options, therapeutic options that would not utilize the pathway was interferon. Knowing that it's a shared pathway between patients with severe JDM and severe lupus, we introduced tofacitinib. Now this, to wrap it up, this is the last visit. So He's 2 months post-tofacitinib, 4 months post-rituximab. He's receiving IVIG and hydroxychloroquine, low dose of steroid. Patient's apparent global assessment is at its best. The patient is happy. However, cutaneous also, you can see the improvement after 1 year. There's improvement in the vasculopathic changes here in the telangiectasia. He doesn't have GI symptoms. However, his muscle disease, he feels much stronger, he's happy. But from our point of view, we are nowhere near clinical remission in muscle disease. He cannot walk more than 5 minutes independently. And his CMAS is static, he's developed new calcinosis. Now, psychologically, the patient initially, when he presented, he had persistent tachycardias. We did thorough investigations for these tachycardias, and later we learned that he has anxiety. This anxiety was relieved after 6 months almost of gaining trust, understanding the disease, and this is one of the important challenges in these kids. They will not ask us. They will go to ChatGPT, they will ask Google, and they will not seek our medical advice. So other than that, therapeutics, he received multiple DMARDs, as you can see, 7 DMARDs now he's improving, yes, but we had some bumps in the road, so he had the multiple vertebral fracture, and just with this week, he was admitted with an abscess for drainage. But at least he's doing better. Still, he is a refractory severe case. Now, this will list the features that indicate refractory disease course, whether it's serology or clinical manifestations. The highlighted in red were present in the patient I discussed, so it is obvious that unfortunately he will have a refractory disease. How do we define refractory disease? Well, back in 2004, the IMAX introduced or came up with the Big 6 core set measures. Later, it was adjusted to fit into our pediatric age group by Pinto. And in 2016, the ACR-ULARD made a huge effort to unify the definitions and with different cutoff or thresholds for pediatric and adults, saying that none of these are practical, honestly, on day-to-day basis. They are for clinical trials. We do not have a formal definition for refractory JDM. Basically, most of the experts are utilizing persistent disease activity despite steroid and 2 or more DMARDs. The cutoff duration is different. Some are utilizing 1 year, some are utilizing 3 months. So the therapeutic milestones, I will go over the landmark trials in pediatrics that have shaped our practice and what is coming from novel therapeutic approaches. RIM trial, it was already discussed. So rituximab did not achieve the primary endpoint, yes, but there was improvement in majority of patients. And in a post-hoc analysis, it showed that JDM patients improved more than adult dermatomyositis, especially if they had myositis-specific antibodies. Now, the second one was a new onset JDM, the randomized control trial. So they divided patients into 3 arms. First, it was the prednisolone alone. Second, prednisolone plus either MTX or cyclosporin. This is for induction, not refractory cases. They found that combination therapy is higher or superior than the only prednisolone. And they found that MTX had this better safety profile than cyclosporin. From there, we had the shared recommendations, 2017. So this is the way we start our patients' management. We usually start with steroid IV methylprednisolone pulses, plus methotrexate, plus or minus cyclic pulses, and IVIG. We usually start with every 2 weeks for 3 to 5 doses, and then we space it monthly. If the patient has severe disease, then add or change cyclosporin. If there is no improvement or there is refractory disease, we have multiple options, including rituximab, anti-TNF, or cyclosporin. There is no winner among those agents, so it's more of a trial and error approach in these patients. Now, in the same year, we had a survey rather than a recommendation or guidelines for calcinosis. You can see that most experts used to intensify immunosuppressive therapy as the first line. So as you can see here, IVIG, glucocorticoids, I have to address colchicine. It is used in patients and it is beneficial for patients with calcinosis. Now, if the patients are not responding or symptomatic to JD or to calcinosis, we have alternative agents. So we can introduce alternative therapeutics that will not counteract our therapies like bisphosphonate, calcium channel blocker, sodium thiosulfate, and there is currently a trial on sodium thiosulfate and aluminum hydroxide. Now, there were conflicting reports regarding the newer agents like JAK inhibitors. Also, laser therapy and local steroid injections are still have conflicting reports. saying that the mainstay therapy for calcinosis is controlling the underlying disease because it's the result of an untreated myositis. Now back to JDM overall, real-world data. In 2022, we had systematic literature review on biologics and JDM, and you can see that we used to use anti-TNF more than rituximab in 2022. Another systematic review in 2024 flipped the ranking. So now rituximab is most commonly utilized in pediatrics, and then anti-TNF. And rituximab usually is used for skin disease, but of course we use it also for muscle disease and refractory disease with 60% improvement. Anti-TNF, as I mentioned, calcinosis, it's important, with an overall improvement of 44%. These are some of the biological options that we utilize. We have, of course, more only case reports, isolated reports, but these are the most common. Now back to the timeline. Last year, we had our first CARA, which is the Childhood Arthritis Rheumatology Research Alliance, biological DMARD consensus treatment plans for refractory, moderately severe JDM. So this time, they favored rituximab over the other biologics that are listed here, and they defined refractory disease as non-response to conventional DMARD over 3 months. Now, this algorithm provides a good framework for us, but still it has its limitations. So first, they did not address the upfront combination with biologics from the start, from the induction. So some patients' step-up approach may not be really suitable for them with severe diseases. Second, JAK inhibitors were not addressed as they were newer agents while they were developing these algorithms. Moving to some newer agents, JAK inhibitor, I will not go into the pathophysiology. Dr. Maha did justice for the newer agents, but I'll just give you a comparison. Most commonly utilized JAK among both groups was tofacitinib. You can see the response rates in pediatrics was excellent in cutaneous and muscles. Interstitial lung disease, this is not accurate. They excluded patients who did not respond for some reason. Calcinosis, our response is not good as an adult. And it was interesting to see the adverse effects. So as expected, the most common adverse effect was viral infection. However, we do not really see malignancies and thromboembolic complications like adult patients. Maybe they will have it when they're transferred to your care, who knows. And secondly, the mortality. Adults, they have much higher mortality than pediatric, probably due to the non-response to interstitial lung disease. All these were based on weak evidence, but good news, we have now an ongoing trial in baricitinib in new onset JDM. Now the other therapeutics, whether it's JAK inhibitors, TYK inhibitors, anifrolumab, B-cells beyond rituximab, are mostly from data from adults. We have limited data in pediatrics. CAR T-cells, which is the highlight of almost any conference. I just wanted to show you the first pediatric patient who received CAR T-cell in 2024. He is in clinical remission after introduction of CAR T-cell. So it is a promising therapeutic strategy in these patients, but the data are limited and it's not available everywhere. Now moving to some interesting options. The past years, as I have addressed, that patients with refractory disease were found to have enlarged or megamitochondria. Just to make it simple, oxidized mitochondria leads to upregulation interferon signature. So one of the therapeutic options, an interesting one, was NAC and acetylcysteine, which is an over-the-counter expectorant medication. So this is one of the translational studies in JDM. So they found that introducing NAC to patients with JDM reduced the interferon signature gene expression. I'm not promoting for it. I have never used it to my patients, but I thought it was interesting to share it. Another underlooked entity is diet. We know that there is a bidirectional relationship between diet and inflammation, and Mediterranean diets have proven effect in, as a pro-inflammatory, decreasing the pro-inflammatory cytokines as IL-1, IL-6, interferon gamma, TNF, as also NF-kappa-B. And in one study, it showed that Mediterranean diet might improve patients with JDM, saying that, I'm not saying that it will control the disease by itself as a solo measure, but it might augment the anti-inflammatory effect we're trying to deliver for our patients with non-toxic effect. To summarize or to wrap up refractory JDM, I tried to gather all the consensus treatment plans and recommendations in a slide. I have to address that calcinosis, refractory lung, we do not have any recommendations for those or isolated recommendations. We're now utilizing more rituximab and JAK inhibitors in interstitial lung disease. And in this talk, I did not cover the very severe entity where patients who require plasma exchange or stem cell transplantation. This is beyond this talk. And please do not forget about the adjunctive therapies, especially psychological well-being, bone health, nutrition in these patients. Some unmet needs and future directions will have already been discussed, but I'll just go over the important points. So most of the data are weak data, and the evidence are basically from case reports, case series. We have limited trials in pediatrics. Second is the therapeutic gaps. So most of the consensus treatment plans and trials did not really include really severe manifestations. We're talking about GI, vasculopathy, perforation, calcinosis. They were excluded from these trials. Multiple therapeutic options exist. Until last year, we did not have a preferred biologic, for example. They just favored rituximab last year. And we do not know if we have a window of opportunity. And if we do have a window of opportunity, what is the timeline? So maybe we should do more upfront for our patients with severe disease and we have to step down rather than step up. Third and finally, we do not have predictors or biomarkers that are accurate really to go for personalized medicine, and we have different phenotypes and myositis-specific antibodies. To conclude with, patients with pathognomonic skin rash and myositis are all diagnosed as case of JDM, but as maybe Prof. Mayouf in the morning have showed us that these patients might have really underlying disease, like autoinflammatory diseases. And even if they're really JDM, they have different phenotypes, which will complicate the diagnosis and the therapy. Now, refractory cases require re-evaluation from head to toe, looking why they're refractory to make sure we're not missing anything, and also reconsideration of the therapeutic pathway. If we're utilizing B cell, then we have to move to T cell, interferon, and maybe mitochondria in the near future. So novel therapeutic approaches are on the way, hopefully, within the next few years. And by that, I concluded. Thank you very much.
Dr. Jain, for your informative talk and complex puzzle case. I would like to call our speakers to take a few questions. So please. Anybody have any question? Yes, Doctora. Dr. Al-Badr.
Okay. Okay. Thank you for all both speakers. My question for Dr. Eugene. Regarding your case, this was a difficult case. What about, the management of this boy had vertebral fracture. So how you manage? What do you think about it? Do you think this can be cause of steroid-induced osteoporosis, and what is your plan for this patient?
Okay, so starting first with the cause, I think it's a combination of more than one cause. First, before I saw him, he was on like 8 months of high dose of steroid, plus the pulses that we have introduced, so it's a combined effect. Now, I don't think 1 month, 2 months is enough to cause vertebral fracture. This is number one. Number two, the disease itself. So he was almost immobilized. He had the fracture once he started to gain his muscle, and he started to sit. So at that time, he had the compressions. Second is that there are lots of details that I have not mentioned, including that he received the zoledronic acid. He is actually on zoledronic acid for osteoporosis. So he's on vitamin D, calcium, zoledronic acid, but still he developed the vertebral fracture.
Victoria, question there for you.
Thank you, Dr. Lujain and Dr. Maha, for the excellent talk. My question for Dr. Maha about the article that you mentioned. They tried plasma exchange for the necrotizing myopathy. And they mentioned that there is a drop in the CK level. What about the clinical manifestations, like the improvement in the muscle weakness? Was it faster than the the standard medications or the same?
So as you mentioned, it's a very small study. It was done on 6 patients of necrotizing myopathy that failed multiple therapy. It's been refractory. What showed from the result is that there is significant drop in CK. However, subjectively, they had some improvement. But the main thing was from this study is the drop in the CK. Okay.
Any other question? So, Dr. Jain, I know your case is a bit difficult. So, what we observe, we have now, maybe we'll publish our data in Medina. The problem with your patient, he came late to you, and you know dermatomyositis should be managed. Really, you should act on the immune system quickly and very strong to suppress the problem, because even the myositis will not be reflected in your inflammatory markers. So that patient was late. Your patient, I guess he was having muscle disease, even more severe ones. So maybe I guess that the selection between the TNF and rituximab. So why don't you start, for example, rituximab, since that patient was having severe muscle disease, rather than anti-TNF?
He is on initially.
Yeah,
So he was started initially on cyclophosphamide MTX, and then adalimumab was chosen due to logistic reasons. He's not eligible. So we cannot get him IV biologics. When we tried to get it, we had like 1 month of arrangement. So currently he's on tofacitinib and rituximab combined. To be honest, if it was another patient that I can get rituximab, I would have given him maybe combination of cyclo and ritux.
Being a moderator, I will ask another question. How would you combine both? It was risky for the patient to combine 2 biologics and the patient developed abscesses.
It is risky, I know, yeah.
So based on
it is risky, yes.
Rather than discussing these issues. Anything in the literature that support the use of combination?
Some case reports, not really, there's no support, for JDM, so it's only case reports. The risk of infection is high, I know that, yes, it has been discussed with the family, but the progressive disease, he's been following with me for 1 year now, he cannot walk more than 5 minutes, that's a lot. So he's independent, now he's dependent. We need to treat it.
So from my opinion, I guess the main message here to just, I use triple therapy from the start. I go with the steroid, methotrexate, IVIG, and we found that calcinosis is very rare. For those patients who did not start triple therapy, they end up with complications, lung disease, calcinosis, and then we will not be able to control all of these since it was developed. Dr. Abdul.
My question to Dr. Maha, when you will choose or you will start with cyclophosphamide immediately, which patient do you think will benefit from?
Unlike pediatric patient, we don't utilize cyclophosphamide in our adult population, as you can see. They usually, for a pediatric patient, I think they are more refractory, more than resistant to medication than our patient population. Cyclophosphamide usually reserved for the ILD in patients with dermatomyositis. Very rare to use for muscle involvement. Okay, but it's very good for ILD. It acts very well.
Yeah, Dr. Alajay.
Can I ask a question, Dr. Maha? So when our patients are transferred to adult care, do they behave the same as adult, or they continue with like pediatrics? They have the vasculopathic manifestations, ulcers.
From my experience, I worked with a pediatric population before. But however, here now I see mainly adult population. I think it depends more on the onset, so they will behave as a pediatric more than adults. Usually, yes, with the severe calcinosis resistant, which we usually don't see in adult population.
Dr. Salman?
As we know, we have many antibodies in myositis. And those antibodies carry some of them carry bad prognosis. Is those antibodies will guide you to use different medication than the other?
Absolutely, yes. And the future is for the myositis-specific autoantibodies. And now the coming guidelines will include more of the autoantibodies and how to manage. For example, if you have MDA5, you have very sensitive for symptoms of ILD. cough or whatever. And maybe you can choose even medication for these patients. I have one patient, MDA5, I started him with a Celcept, which act both on skin, on ILD, and on the muscle. So I think, yes, your choice of medicine is also depend on the myositis-specific autoantibodies.
Maybe my one last question for Dr. Awal. Do you give maintenance retox for patients who received rituximab, and when to consider it, and for how long you'll give this maintenance?
Maintenance
Rituximab.
Rituximab.
Yeah, so do you give it, for example, every 6 months, and for how many
So what
doses
have
in
been
those
used-
cases refractory treatment?
Yeah, in myositis, what have been used is 2 doses every 6 months. However, sometimes if you have high, and for most of the criterion trials and cohort, they check for the CD19 and CD20, which we don't have here. And mostly we guide it by the symptoms. But I wouldn't do more than 6 months. And after 2-3 years, you can adjust the dose.
So one last question by Dr.
My question to Dr. Maha, please, regarding inclusion body myositis, is special type of myopathy, and even the pathogenesis is different from other type of myopathy. Is it autoimmune disease or metabolic disease and mitochondrial dysfunction? I ask you if any evidence for use of antibiotic or bioglitazone, some medication used as a treatment of inclusion body myositis. We already use IVIG in treatment because it's not responding well to immunosuppressive medications.
So as you say, inclusion body myositis is a confusing subcategory, and many worldwide they've been managed by neurology even. So we don't have much information about pharmacological therapy. All what we use being refractory for this kind of disease, mainly because of the poor understanding of pathogenesis. So I'm not aware of anything that will act, except for the ones I talked about. It's promising, but however, nothing been concluded yet.
Okay, by this I will end our session. I would like to thank our speakers for really their informative talk. Thank you very much.
Assalamu alaikum. So now I will introduce Dr. Hanan Reyes. She will talk to us today about the real-world evidence for psoriatic arthritis treatment and the treatment to target in RA patients. I think we all know Dr. Hanan Reyes. She's a consultant rheumatologist at Prince Sultan Military Hospital, and she's also the head of the Saudi Society of Rheumatology. So we'll try to finish the lecture in 20 minutes. I know that you're all waiting to go to the Friday prayer.
السلام عليكم ورحمة الله وبركاته. صباح الخير. طبعا اليوم جمعة مباركة. I know we're just before Jum'ah prayer. Thank you, Mr. Chairman, for the introduction. Thank you, Lily, for choosing me to present their satellite symposium. I will promise it will be practical session, and so no worry. As you know, real-world evidence is helping us to optimize care for management of patients. Here, our topic today about psoriatic arthritis, followed by rheumatoid arthritis. So I will try during this session to explore how real-world evidence is essential. All of you know that, of course, that the controlled trial is a fundamental for approval of any medication. But in real life, in these controlled studies, they exclude patients with comorbidities, specific age group, lack longevity, so sometimes we need to see the long-term effect of these medications, sustainability, safety, and so on. So let us see. So this is my disclosure. We'll start with navigating real-world evidence, effectiveness beyond clinical trials in psoriatic arthritis. So I will go through the complexity and the challenges for managing psoriatic arthritis. We'll go just quick through the guidelines of management of psoriatic arthritis, and then we'll go through the trials, from trials to real-world evidence, and specifically the impact of excusumab, IL-17 inhibitor, in transforming psoriatic arthritis treatment. Okay. As you know from the study of multinational assessment of psoriasis and psoriatic arthritis, it was found that there is a delay in management of psoriatic arthritis up to 5 years. Another says from Saudi Arabia up to 7 years. There is still challenges because we know that psoriasis and psoriatic arthritis is multifaceted phases with musculoskeletal manifestations differ from peripheral arthritis, axial, dactylitis, enthesitis, skin involvement, plus of course eye, GI involvement, and the other comorbidity. Sometimes we have difficulty. The patient reaches to us as a rheumatologist late. He used to be either with primary care or for diagnosis of psoriasis or under dermatology, and they thought pain is related to the skin. And we know from different studies that delayed management of patients with psoriatic arthritis as short as 6 months, it can cause morbidity and destruction of the joint. So still we have challenge. We need to have early referral. We need to manage these patients early in order to have them into a remission. And the other thing that the need for multidisciplinary team to manage these patients, as I mentioned, with all of these manifestations, we need multidisciplinary team. And all guidelines, whether EULAR, GRABA, as well as the Saudi guideline, indicate the importance of multidisciplinary team in the management of psoriatic arthritis. I will talk about the EULAR recommendation for management of psoriatic arthritis since it's the most recent one. And all of you know that managing psoriatic arthritis, it depends on which domain is there. Is it mainly peripheral arthritis? Is it mainly axial or skin? So always we need to choose some medication that can cover all the domain. And in all guidelines, whether it is the EULAR or GRABA or the other, indicate that for peripheral arthritis, all approved biologic you can start. Whether TNF inhibitors with all type, IL-17, IL-23, IL-12, 23, and JAK inhibitors. But we choose the therapy based on the comorbidity or the presence, for example, of uveitis, then you avoid IL-17, you use anti-TNF. If there is inflammatory bowel disease, use TNF, IL-20, and so on. So you choose your therapy based on the domain as well as the comorbidity. But in general, IL-17 showed effectiveness in all domains, including axial involvement. So most of the guidelines, they prefer it. But as I mentioned, all in the same line if we need to manage peripheral psoriatic arthritis. But if we need to manage axial, we choose either TNF, IL-17, or JAK inhibitors. Here you can see these things that I have mentioned in GRABA, EULAR, as well as EULAR ASAS. As you can see here, all biologic IL-17 inhibitor with all type of anti-TNF, IL-23, JAK is equally recommended. But if there is more of skin, you choose IL-17 or IL-23. And during my presentation, I will show you some comparative study to help you to select which biologic or JAK when you manage such a patient. Of course, for axial, IL-17 or TNF or JAK, so there is no indication of IL-23. This is the Saudi, or we can say it, Ministry of Health guideline. I will not go through it as Dr. Naif will present it afternoon fully, but it emphasizes more or less the same regarding the importance of treat to target. Target is remission or low disease activity, and you need multi-team to manage these patients. But here what they choose in all domain after failure of methotrexate or non-steroidal, they choose IL-17 as a preferable therapy in Ministry of Health. Okay, so from clinical trials to real world. So we saw that all these biologic can be work. When we are in practice in the clinic, we want to choose what biologic is there. Is there is head-to-head study? Yes. In 2019, we have, maybe most of you know it, the SPRIT study, which compare IL-17 ixekizumab versus adalimumab, and the outcome was mainly ACR 50 or plus BAS 100, complete resolution of the skin. And in this study, initially, the primary objective is non-inferiority to anti-TNF or adalimumab, but it was, the result shows superiority, not inferior, and not only on ACR 50, but also I will show you in remission state and minimal disease activity. Another study in 2020 of the other IL-17 secukinumab, which is EXCEED study, again, secukinumab versus adalimumab, it showed both they are effective, but not superior. In 2021, the SELECT study, whereas they compare obadacitinib to adalimumab, both are effective, but not superior. Just to go more in the details of the SPRIT study, you can see here at week 24, DAPSA remission was in 27% in ixekizumab group versus 18% in adalimumab. Not only that, up to 50% they have minimal disease activity at 24 compared to adalimumab. So in this study showed superiority of IL-17 ixekizumab. So from head-to-head study to real-world evidence, this PROSPERT study, which is psoriatic arthritis observational study for the persistence of the treatment, because persistence of the treatment indicate effectiveness. So it's a multinational observational perspective. They more than 1,000 patients with psoriatic arthritis with different diagnoses. 6 countries, mainly European, UK, Spain, Germany, and so on, with 14 medications were compared. So any patient with active psoriatic arthritis, whether he is in prior biological or targeted therapy or naive, start with active, they included, and they start them into any form of therapy, and they follow them over time. Mainly through DAPSA, as well as minimal disease activity. The eligibility, adult, 18 to 80 years, with a different diagnosis, as I mentioned, more than 6 months, and you can see this, all medication is included because this is real world, and they left it to the treating physician. And targeted therapy, JAK and pseudo-diesterase inhibitor. They did baseline assessment at 3 months, at 12 months, and the main outcome, the persistent on the therapy and the discontinuation rate. You can see here at the time of diagnosis or entry of the study, around 300 patients in the ixekizumab cohort and the rest of the patients on other type. It's clear that ranging disease duration between 7 and 9. In the cohort of ixekizumab, it was 9 years, and prior biological or targeted therapy up to 70%, which indicate that patients treated with ixekizumab had high disease burden and treatment experience at baseline. And let us see what was the result of this study. You can appreciate here that the achievement of DAPSA remission at week 12, 44% in ixekizumab, and it was equivalent to the other IL-17, which is 46%. And again, you can see it here in TNF inhibitor, more or less the same, but it's more better than IL-23 and IL-12-23, and equivalent to JAK. So in this real world study showed that the efficacy in the joint almost comparable to all other type, but more beneficial than IL-23. And what about in the skin? Resolving of the skin, it was superior to the other. You can see in ixekizumab, almost 60% have clearance of the skin manifestation. So this graph showed the comparison of ixekizumab to the other class. We know that the baseline is different. They use a specific statistic to differentiate. And at 3 months, you can see they are almost equivalent with other mode of action of biologic, but it's better, as I mentioned, than IL-23. At 12 weeks, you can see here, again, comparable, but the JAK little bit equal or comparable, a little bit JAK at 12. But the good thing, that's early improvement on ixekizumab. So the key takeaway from this month 3 and 13, at month 3, ixekizumab was significantly better than IL-12/23 and IL-23, and it is as effective as TNF and JAK inhibitor. So this give us more trust when we manage our patient that these medication work in the real life equivalent, and then we choose according to the comorbidity and the other availability. At month 12, ixekizumab was numerically better than IL-12, but as effective as TNF and other mode of action JAK inhibitor. So in line of EULAR recommendation, almost 1 out of 5 patients achieve DAPSA remission with ixekizumab and TNF at month 12. What about the safety? Over all indication, it seems to be safe. The only thing is mild injection site reaction. Candida infection, 2%, which is equivalent to the other biologic when we review it. So it's mild. Regarding the inflammatory bowel disease, you can see very negligible in most of it's 0.1, 0.8. And this is what we use to afraid in patients usually with psoriasis, because they might have element of inflammatory bowel disease. So it seems to be safe, but we have to take the history. We have to be sure that they are not having Crohn's or ulcerative colitis. So this is an injection, usually 80 milligram. We give loading dose of 160, then every 2 weeks for 3 months, then monthly. And as a conclusion for psoriatic arthritis part, psoriatic arthritis is a complex heterogeneous disease with multidisciplinary approach essential. And therapy should aim for remission or low disease activity across all domains and to improve the quality of life. IL-17 inhibitors are recommended by all guidelines in the first line with the other biologic. In the BROSPRET, which is the real-world study, ixekizumab was proven to be effective treatment for both joint and skin symptoms despite high disease burden and treatment experience. Evidence from the real-world evidence as well as randomized control study support the use of IL-17 ixekizumab as a first-line biologic across all domains. Now coming to the second part, inshallah it will be like another 10 minutes, which is rheumatoid arthritis. يعني حبيبة now treat to target. 5 دقائق بس؟ Okay, we'll go quickly. So regarding the treat to target, we'll go through the EULAR recommendation and the importance of treat to target in management of rheumatoid arthritis. All of you know the rheumatoid arthritis guideline. I will not go through it. The good thing that in the EULAR 20, just last June, they have the updated guideline where there is a change mainly in phase 2. In phase 1, we know, diagnosed, have treat to target, and your target is remission or low disease activity. At 3 months, at least, you have to have 50% improvement in the symptoms. And at 6 months, you have to reach to the target. If not, you go to the other phase. So you start with methotrexate, small dose of steroid, build up the methotrexate, no improvement, go to phase 2. In phase 2, previously, in the previous guideline, 2022, they make it if patient have severity index or not. In the new guideline, no need. Once he failed phase 1, means that he's severe. So immediately you shift them either to add biologic or targeted therapy. And they put it all in the same line. And again, you follow treat to target. If no improvement, you change the class. So, treat to target journey. How treat to target affect the outcome? The story of treat to target started in 2004 with tight control, whether tight control changed the outcome. And it was come from Tikor study where they did 100 patients versus 100 and published in Lancet and showed those with tight control, regular follow-up, show much better outcome, reaching remission and less radiological progression. In 2010, the EULAR put treat to target as part of our essential to follow. And again, in 2022, it's mandatory for each patient when we manage them to put the treat to target strategy. But what about real life? There is a study, what would they call it, perfect study, where they compare JAK inhibitor, baricitinib, to other form, because all will be in the same line. But they compare it with treat to target strategy. And this is the first real world study. They use treat to target as a comparative, and they compare it to the other, any anti-TNF. So two group, one on bari, one on anti-TNF. And outcome of this study, as early as 12, we have higher remission and with baricitinib group. Of course, later on, they are equivalent, but early, they have more of remission, and even regarding the radiological progression, they're almost the same. This is the Tikor study of 2004. So, how does baricitinib perform now under treat to target concept? So, we mentioned in the perfect study how it works. Here, to compare the controlled study to real world study. In the controlled study, all of you know the RA beam study, where they include more than 1,000 patients and they compare bari to adalimumab. And in this study, at 12 weeks, the remission, as you can see, with bari was 24, with adalimumab was 19. In the perfect study, at 12 weeks, this is the real world, showed remission rate of up to 76% at week 12 compared to the TNF inhibitors, which is 46%. Other real world, be real. This is the most recent with several countries. Started in the European, and then other countries were included, including our center, Prince Sultan. We are part of this study. Here, what was the main of this study? Patient, either one cohort will be on bari, if there is active and they follow, and the other cohort, if he's active, choose whatever you think is good, whether anti-TNF, non-TNF, other JAK inhibitors, and they measure the longevity, how long these patients continue in this therapy. And of course, the baseline, some of these patients biological naive, and some they failed one or more medication. And what was found that more than 40% of these cohort on baricitinib, they have higher persistence versus TNF and other mode of action. More patients treated with baricitinib remained on the treatment, and you can see here that this plot, they choose hazard ratio to compare, and anything less than 1 mean more persistent to on therapy. So for example, overall, if we compare it overall bari to all biologic, it's 0.6, which means 60% more liable higher to persist on the therapy compared to the other mode of action. And it was more persistent in all form, in those who are naive biologic and those who are experienced failure of previous biologic or targeted therapy, even the age group, whether they are younger than 65 or more than 65. And you can see here the how long they stay. Overall, for Bari, the median stay was around 16 months. For those who are naive, 17.6 months. And for those who are already experienced failure of other therapy, the longevity up to 24 months. What about rheumatoid arthritis beyond? This is from the first controlled study, the BEAM, as well as the BUILD study. They follow those patients with low disease activity and remission over time, up to 7 years. And you can appreciate here from the graph, they have as early as 25, low disease activity up to 70%, which is persist over time in patients with baricitinib. And again, those who achieve remission as early as 24, 40%, and with time it increased up to 60%, and it persists for 7 years. Is Bari work only to suppress inflammation? Just 2 slides about the effectiveness of baricitinib in the bone health. So it increased the bone density and the quality of bone. And this is a real case of 60-year-old male who got refractory to be managed with multiple medication. In 2019, he was started on baricitinib, and the bone density was measured through biopsy over these 4 years. At baseline, you can see here that active with 14 swollen, 22 joint tenderness. The bone VAS is 84 with high CRB, and the bone density was 296. Over time, within 1 year, patient into remission with no pain, decrease in CRB. The bone density initially more or less the same after 1 year. After 2 years, persistent remission with increase in the bone density to 315, and at 4 years, again, remission with increase in bone density. So the good thing about JAK, and here baricitinib, the good effect on bone. And we know that rheumatoid arthritis is a risk factor for osteoporosis. So if patient eligible, and we assess the risk factor for giving JAK inhibitor, and he is eligible for JAK, so JAK is a good option for these patients. About the safety, again, among all of these studies, more than 24 study real world, as well as the controlled study, there is no much increase. Usually we're afraid about the risk of thrombosis, mass, and so on. So in these, there is no major increase. The main things, you know, with hypercholesterolemia, keep your eye on patient on JAK and measure the blood cholesterol. The other things rarely, but can be observed, neutropenia, hypertriglyceridemia, some case of diverticulosis, but it's very rare, less than, you can see, less than 1%. And there is something about weight gain. I have good number of patients on JAK. I never saw the weight gain, to say the truth. So you know about Bari, it's 4 milligram. We give it if patient active. We start with 4 milligram. When he is in remission, we can reduce the dose to 2 milligram, observe. And the good thing that we have these 2 doses, so we can, if patient flare again, we can put him back on the 4 milligram. So as a conclusion, baricitinib considered effective, not only in the inflammation, but also for the bone health, easy to be taken with good outcome and good safety profile. Thank you for listening, and it's open for discussion.
Thank you, Dr. Hanan. Any questions, Dr. Hanan? I think one of the, you showed us that ixekizumab injection site reaction was higher, but I think
it's 4 to 7%.
Yes.
So, and mine.
But I think they used to have citrate, but now citrate free, right? So this is a lower risk for injection site reaction. Any question for Dr. Hanan?
IL-17, actually I have more experience with secukinumab, and now for the last 7 years, the IL-17, very safe medication, to say the truth. Okay. I never see this recurrent infection or so, or any complication. Yeah.
So if there is no questions, we can conclude the lecture. we'll be back here at 1 p.m. inshallah to talk about psoriatic arthritis disease. Thank you. شكرا لا خلصت في وقت كويس ممتاز.
والله قلت لك شجعتني قلت ما قلت للاستاذ بسرعه انت هتقدم السعودي خليته 17
بتكلم اليوم ليش؟ بقول موضوع بقول هذه المشكله.
السلام عليكم ورحمة الله وبركاته. جمعة مباركة على الجميع، وأتمنى إن شاء الله إنه الجميع برضو يعني أخذ nice break و had a delicious lunch. So following which I don't think we would, people would have to be more, will be as focused as if. So the worst time is the pre-meal and after meal. That's the worst time where attention might be significantly compromised. Nevertheless, I think we got good speaker today, as it is the case on the preceding sessions and for the session to follow. The good thing, I think, you, Dr. Ibrahim, Mohammed Sultan, Dr. Frej, I do thank you a lot for your invitation and very remarkable and marvelous work you've done over the last 5 years. Things are getting, they've started extremely well and getting better and better. And I think they've intentionally chose this, the speaker of this session following the lunch, who will be able to very much draw your attention, get you excited, and from that it gives me the pleasure to present the first speaker, our colleague Dr. Ibrahim Al-Hamoud, who's a consultant rheumatologist at King Fahd Medical City in Riyadh. He's also the chairman of the Rheumatology Scientific Committee, and he also holds other administrative as well as scientific appointments in different sectors. Dr. Ibrahim Al-Hamoud will talk and address it's a spa session anyhow, and he was going to give us kind of a road map in the field of spectrum of spondyloarthropathy. Dr. Ibrahim.
Thank you, Dr. Ahmed. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. First of all, I would like to thank the organizing committee for inviting me to be with you today, talking about the spondyloarthropathies, the road ahead. So now the spondyloarthropathies, as you all know, it is a group of many diseases. So I'll try to talk about the axial spondyloarthropathies, both radiological and non-radiological, and then we'll touch the PSA. So when we talk about axial SPA, it's a very complex disease, and it's a very heterogeneous disease, as you see, variable clinical manifestation and variable extra-articular manifestations that occur in the same patient. So our target nowadays is to prevent the structural damage of the disease, and this currently indicate a very high unmet need for the available treatment. So now this is the available drugs for the axial spondyloarthropathies. We have 5 anti-TNF, as you see here. All are approved for treatment of axial SPA. And then we have IL-17 pathway, secukinumab, followed by ixekizumab, and lately bimekizumab. And IL-12, 23, Stelara has been tried and failed. IL-23 blockers, the risankizumab, has also been tried and failed in axial SPA. And then we have targeted synthetic or JAK inhibitors, both TOFA and UBA are approved for treatment of axial SPA. And we have very ongoing trial for the third IL-23 pathway, guselkumab, Tremfya, and we're all eager to see the result of the STAR trial that hopefully we're going to publish the abstract in the coming ACR. So now, this slide summarizes the treatment of radiological axial SPA for the anti-TNF that has been tried in the radiological axial SPA in bio-naive. And here they reported the ASAS 20 and 40. As you see, the ASAS 40, it's ranging between 50 to 60% by maximum, different anti-TNF, but we have to keep in our mind it's not head-to-head comparison. There are some variation in report whether it's 12 or 16 weeks, but it gives us a hint that whatever anti-TNF is being used, the ASAS 40 is expected not to be more than 60%. It's ranging between 50 to 60%. And then the ASDAS inactive disease, as you see in the slide, it's less than 1/3 of the patient, whatever anti-TNF is given, they will achieve inactive disease. If you look for the golimumab, infliximab, Cimzia, and the last one, it's again infliximab and Cimzia. It looks like better, however, it's not head-to-head comparison. So again, this indicates a high unmet need. The anti-TNF, although they are 5 different agents, they are almost similar in the efficacy. And then we move to non-radiological axial SpA, which is very important because in 2 cohorts, in our cohort as well as the King Saud Medical City University, they have more patients with non-radiological axial SpA. And those patients are more likely to be women. Okay, so when we look to the different anti-TNF, again, look to the ASAS 40. First of all, we have to keep in our mind it's not head-to-head comparison. So you cannot compare the efficacy of, for example, adalimumab versus certolizumab. But it gives you a hint that even the ASAS 40 in non-radiological axial SpA, it is less than 50% with all the different anti-TNF in this group of patients. And then we have secukinumab, which is the first IL-17 inhibitor that's approved for treatment of radiological axial SpA. And again, if you look here to the ASAS 40 and 20, it's up to 50% of the patients they achieve the ASAS 40, and 60 plus they achieve ASAS 20%. And the beauty with the IL-17 is the persistence of the activity of the response has been reported up to 5 years. So 50% of the patients they achieve ASAS 40 with secukinumab and persist up to the end of 5 years. And then we have the remission, because these drugs are new, so they reported the remission, the partial remission. And again, despite being a new medication, less than 1/3 of the patients they achieve remission with secukinumab, which is IL-17 inhibitor. And then we have the new, or the second IL-17 inhibitors. And as you see here, this is the COST-V trial. They reported in patients with incurred spondylitis or radiological axial SpA. Here the ASAS 40 and the ASAS 20. And again, just to keep in our mind, the number is almost similar. The ASAS 40, it's almost 50% of patients they achieved ASAS 40, and 62% they achieved ASAS 20. And then we have, again, they reported the similar to the secukinumab, the low disease activity, it's around 1/3 of the patient they will achieve low disease activity with this new IL-17 blocker. And then we have the third group, the JAK inhibitors, and the first one that's approved is tafasitamab, which is non-selective JAK inhibitor. And as you see here, the ASAS 20 was reported in 56%, which was superior to the placebo and persist up to the end of 1 year. ASAS 40, it is 40% of the patient, and it goes up to 50% at the end of 1 year. The second JAK inhibitors that's approved, which is more selective toward JAK1, is upadacitinib, Rinvoq, and the ASAS 40 was achieved in more than half of the patient for the first time, and the delta as compared to the placebo is more than 25. So we have more selective JAK inhibitor. It looks like more effective, however, it's not a head-to-head comparison. And then we have the ASAS response at week 14. The inactive disease was significantly superior to the placebo, 0 in placebo, and 16.1 in the Rinvoq. And the low disease activity in almost 50% of patients as compared to 10%. And as you see, so we have a new medication that looks very effective in treatment of axial spondyloarthropathies. So what's update? What is the most recent update for axial SpA? Now we know blocking IL-17, we have patients who are failed despite giving IL-17 inhibitors. And then we discovered IL-17 is not only a single cytokine. There are IL-17A, IL-17F, IL-17 complex of A and F. So if you give secukinumab or ixekizumab, they are IL-17A blocker. So what's about IL-17F? It might be effective. The other thing that we discovered, the IL-23 are effective in PSA, which is mainly mediated by IL-23. However, some of them failed. And then we know that there are IL-17 dependent for IL-23 and independent of IL-23. So the new medication is the bimekizumab or Bimzelx, which is the first one, and I will show you the second one, but this is the first one and the only one that's approved at this moment that's blocking both IL-17A and F. And now when we look to the non-radiological axial SPA, and we look here to the ASAS 40%, at week 16, it's more than almost 50% they achieved ASAS 40. In radiological axial SPA, again, almost 50% they achieved ASAS 40, and at the end of the year, it is more than 60%. So probably blocking the complete IL-17 might lead to better response, but again, there is no head-to-head comparison. And then one of the beauty things about the blocking both IL-17A and F, the efficacy has been demonstrated in almost similar number, whether they have been exposed to the anti-TNF or they are naive. If you look here to naive, it's 60%, and if you look to inadequate response, it is 55%. So it looks like blocking both interleukin-17 is very effective in treatment of axial spondyloarthropathies. Now we'll open the other page of spondyloarthropathies, which is PSA. This slide summarizes what has been approved for the treatment of PSA, and here things just to draw your attention, we have biosimilar for adalimumab, we have now for Enbrel, and we have for infliximab biosimilar. There is no time to cover all these available medications, but a quick look to the approved biological agents. Now we have again Bimzelx or bimekizumab, and as I said earlier, it blocks IL-17A as well as F, so it blocks all the hexamer, or whether it is FF, AF, AA. And the brodalumab has been withdrawn from the market because of the depression, which is again IL-17 receptor blocker rather than IL-17 cytokine blocker. And then this is for psoriatic arthritis. The anti-TNF, to summarize it, ACR20, it is around 50% to 55%. And it's variable, again, not to head-to-head comparison, but it gives us, even when looking for a very small minimal response, 50% of the patient, they will not respond to the anti-TNF. And then we have a new group, which is IL-17. And the good thing with PSA, we have head-to-head comparison. When they compare two previously approved IL-17 with the previously standard of care, which was adalimumab, as you see in both studies, there was no difference from arthritic manifestation. From arthritis point of view, there was no response. But the PSA is not only a joint. It's a joint and skin, axial, and dactylitis, enthesitis, and so on. So when we look to the simultaneous composite endpoint, ACR 50 and 100, there was clear separation and superiority of IL-17 secukinumab as compared to adalimumab. And the same finding has been again replicated with the other IL-17, which is ixekizumab, when they are looking for ACR 50 and PASI 100, which is complete skin clearance. And the separation was statistically significant at week 8. So what's new in PSA? There are many things new in PSA. It's not like axial SPA. First of all, we know Cosentyx or secukinumab, the approved dose is 300 milligram, 5 weeks, the first 5 weeks weekly, and then monthly. But based on future 5, you can use Cosentyx without induction dose. And even you can use the smaller dose, 150 milligram. You do need to start the patient on 300 milligram with similar efficacy if you are looking for ACR 20. But if you are looking for ACR 70 and complete skin clearance, probably 300 milligram is better. What does it mean in real life? If you have patient with mild to moderate disease, okay, you can start with 150 milligram. Or you can start 300 milligram without loading dose. So it depends, and this is very important to those who are facing economic or budget issue. You can reduce the budget by eliminating the induction doses. And then we have axial PSA. I'm always stressing on axial PSA because we have noticed people ignoring it and thinking it's not common. But we published our data. In our cohort, it's 32% of our PSA, they have MRI proven to have axial involvement. So it's not uncommon. What we need to look for it. The only medication that has been tested in RCT and shows efficacy in axial PSA is secukinumab based on Maximize. And whatever the methodology that has been used, whether it is multiple imputation, NRI, which is very aggressive method, or observed, as you see, the response was significantly higher, more than 65%, to 2/3 of the patient, they respond to Cosentyx if they have axial PSA. And again, as I said earlier, we have now ongoing trial start for IL-23. Till we have it, we don't know. I didn't bring TOFA slide about TOFA because the data about TOFA, although it's approved for PSA, it's very weak. However, we know abatacept has been approved for PSA, although they achieved only ACR 20 and BASI 50. So nobody is now looking for BASI 75, but it has been approved. So if you look to the Rinvoq data or the upadacitinib, it worked very well in PSA. Whether they are ACR 20, it's almost similar to the IL-17 numbers. So ACR 50, almost 40% of patients, they achieved ACR 50, and 16% of patients, they achieved the ACR 70. So what's new again? We have the third group in PSA that recently approved for treatment of PSA, which is IL-23. 3 agents, whether tildrakizumab, I don't know what's available in Saudi or no, gozelicumab, Tremfya approved, risankizumab, Skyrizi approved for PSO as well as PSA. Now what's important to us in rheumatology, if you look here to the ACR 20, they are almost the same. Tremfya, it is 76, risankizumab or Skyrizi is 64%. Again, it's not head-to-head comparison, but they are very effective in controlling the musculoskeletal manifestation. If we look to dactylitis enthesitis, and we believe IL-23 is a very strong agent to treat these clinical manifestations because the main cytokines for enthesitis dactylitis is IL-23. And again, it's not head-to-head comparison, but patients who are given gozelicumab, 50% they have complete remission of enthesitis and 60% complete remission of dactylitis. Skyrizi, 50% for enthesitis and almost 70% for dactylitis. What is good or important point with IL-23, this is the safest group. As a biological agent, the safest when we look to the side effect, and we know this data from different trials, but when we look to the Cosmos trial, which those who failed, not previously exposed, failed anti-TNF, and look here to the things in the red light, there was no opportunistic infection, no TB, no anaphylactic, no IBD, no death. So they are very safe medications. If you have patients with recurrent infection, patients who are at high risk of infection, you can use IL-23 as first line of therapy. So we have now in PSA, as I said, better than axial SPA because we have comparison, we have head-to-head. This study has been published as an abstract. They compare Tremfya, which is 23 blocker, versus Stelara, which is 12-23, and they found the superiority of Tremfya, which is 23, as compared to the Stelara. Again, this slide summarizes what I have mentioned earlier about all the agents that's approved for PSA, and you can see the indication for these different agents. So what's new in PSA? We have the third IL-17, as I said, bimekizumab, which is blocking both A and F. And as you see here, the response was dramatic response. This is the ACR 20, more than 70%, ACR 50, more than half of the patient, and ACR 70, almost 1/3 of the patients who are given bimekizumab, they achieved this number. BASI, this is very dramatic response, and our colleague in dermatology, they have the study that head-to-head Cosentyx, which is IL-17A, versus this agent, bimekizumab, which is blocking A and F, and they showed the superiority from the skin point of view for blocking of IL-17A and F. And because of the time, let me show you what in the future, what we expected in the future in spondyloarthropathies. We expect to have agents that have dual biological anti-cytokines that blocks both TNF, alpha, and 23, and different cytokines to be present in the market. This has been tried more with our colleagues in gastroenterology. Several case reports and case series, they reported combination. We expect to have dual biological anti-cytokine targeted synthetic, and there is an ongoing affinity trial in PSA comparing the combination of guselkumab with golimumab, which is anti-TNF, versus guselkumab, which is IL-23 blocker. We expect to have more bispecific anti-cytokine. That's why bimekizumab is not the only one. There is ongoing trial about sonelokimab, which is blocking both IL-17A and F. It's coming in the near future. Let me show you some new data. IL-17, all the available now are injectable medication, sub-Q. We are going to have an oral IL-17. This is izokibep, has been tried, and the result is very, very promising, similar to the other IL-17 blockers. Deucravacitinib, which is the first TYK2 inhibitor, the other JAK family, has been tried in PSO, approved, has been tried in PSA, and the result is very, very encouraging, and it's now ongoing for phase 3 for PSA with BMS. And we have now a combination that's combined TYK2 with JAK1 inhibitor, as I said, which is brepocitinib. The names are difficult, but they are very effective. And interestingly, there was no signal about the safety. There was no increase in the MACEs or no increases in the thrombotic events. And however, the combination is not always successful. This study has been published, which combined anti-TNF with IL-17A inhibitor. It's called ABT 122. As compared to the placebo, of course, is much better and achieve all the primary endpoint. But when you compare it to adalimumab, which is only anti-TNF, the only thing that shows superiority is ACR 70. So at this moment, we have to say we have to stop and not saying the combination will be successful and would be much better achievement of the end result as compared to the blocking a single cytokine. But in the conclusion, the pathophysiology and experience support that the disease of SPA is not depending on a single cytokine. And I clearly illustrate to you that IL-23, for example, if you block A, there will be escape for IL-17F, and there are some IL-17 that depends for IL-23, others are not. Whether combination will reduce the secondary failure and increase drug survival and better control, we don't know. Theoretically, it should be, but we have now one study that doesn't show this and support this hypothesis, but we'll see in the future. There are future efforts in managing SPA should be personalized medicine. If somebody having the skin more aggressive, you can use, for example, in PSA IL-23, those with IBD and extra-articular and so on. And unfortunately, there are no head-to-head comparing the biological toward targeted synthetic head-to-head, so we don't know which one is better than the other. And if your patient achieved remission, please always think about de-escalation. And that has been mentioned clearly in Saudi guidelines of spondyloarthropathies that's published a few months ago, that we have to think about de-escalation and reduction of the dose or the frequency if patient achieved remission. Thank you very much.
Assalamu alaikum warahmatullah. It's my pleasure to introduce our next distinguished speaker, Dr. Al-Hussein Asiri. He's the head of rheumatology division at Asir Central Hospital in Abha. He's a fellow for the American College of Rheumatology, and he has been a member of the GRABA since 2010. He will present today the spondyloarthritis mimics. So let's welcome Dr. Asiri to this presentation.
Assalamu alaikum. Good afternoon, everybody. Thank you, Mr. Chairman, for a nice introduction. In the beginning of my talk, I would like to thank Dr. Muhammad Sultan and Dr. Abdullah for a nice and invitation to have this talk with your presence. I don't have any disclosure. The outline of my talk, I'm going to talk about the SPA spectrum brief refreshment for the SPA ASAS criteria. And I'm going to talk about the why mimickers matter as a clinical and therapeutic implications of that. Then I'm categorizing the mimickers into first category, mechanical and degenerative, then infectious, metabolic, endocrine mimickers, then malignancies, and the other inflammatory syndromes. A key differentiating features is comparative summary. Then I will conclude my talk with the take-home messages. As you know, the spondyloarthritis is a group of interrelated inflammatory rheumatic disease sharing distinct clinical, genetic, HLA-B27, and imaging features. The axial SPA is a primary focus for mimickers of back pain. All the mimickers, they are actually simulating the presentation of axial SPA is the back pain. And as you know, all of you, if you know the ASAS criteria, if you have a patient with a chronic back pain more than 3 months or more, onset less than 45 years old, imaging arm, then is an imaging arm and clinical arm, sarcoiditis on imaging, X-ray or MRI, plus one or more SPA features, and clinical arm, HLA-B27 positivity, plus 2 or more SPA features. And you know SPA features including inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, and inflammatory bowel disease-related arthritis, good response to NSAID and family history of SPA and elevated inflammatory markers. And this is the ASAS criteria. So the why mimickers, why we have to talk and to know SPA mimickers. In fact, we have a patient impact as well as therapeutic errors. Patient impact, delay of diagnosis and treatment of true underlying condition like infection and malignancy, and this will lead to poor outcome of these diseases if you miss them. In addition to that, prolonged pain, disability, decreased quality of life, this will have a very bad impact in patient and the social life as well as the psychological impact on patients. Therapeutic errors, inappropriate exposure to biologics. As you know, the biologics are very expensive drugs, and if you misdiagnose the mimickers, you will start these medications, which is very expensive. In addition to that, you will lead to the unnecessary cost to the health care system, as well as the potential for serious adverse events like worsening the infection and malignancy. In addition, the failure to address the actual pathology of patient is having. The unnecessary cost to the healthcare system, the cost of wrong diagnosis is severe and impact in 3 keys. The first one, the clinical cost, the disease progression, the true underlying condition such as infection and cancer. Left untreated, this will be life-threatening and will actually affect the patient outcome on these diseases. Harmful treatment, the patient may receive powerful immunosuppressive drugs for SPA that weaken their immune system and dangerously worsening the actual disease. And irreversible damage, delay in correct treatment for true SPA can lead to permanent joint fusion and chronic disability. Other impact is the financial cost. The direct cost is wasted spending on expensive biological medications, often tens of thousands of riyals per year, and repeated doctor's visits, unnecessary diagnostic tests, and indirect cost like significant loss of work, productivity, income due to the prolonged disability, which often represent the largest portion of financial burden of the diseases. Personal cost, quality of life will be affected if you misdiagnose these diseases, leading to the chronic suffering. Patient will actually have a prolonged unnecessary stiffness, pain, fatigue, and this will actually lead to the psychological impact, with delay of wrong diagnosis strongly linked to the higher rate of anxiety, depression, and loss of hope. Reduce life quality. The combination of physical pain, mental stress, financial stress severely impact the patient, delay life and relationship and overall well-being of patients. So the main role of rheumatologist is to accurate diagnosis and accurate differentiation of these mimickers. The rheumatologist role is actually depending on accurate diagnosis through the by the diagnosing of inflammatory back pain, and requiring a skilled clinician to synthesize information from detailed patient history and through the physical examination, thorough physical examination, laboratory test, inflammatory markers, and careful interpretation of imaging, X-ray, and MRI. Is coming back. I want to go back. Yes. Yeah, we'll start with the we'll start with the first one, which is the first category, which is mechanical and degenerative mimickers. And this is the most common group of SPA mimickers. And the key challenge, differentiating inflammatory from mechanical degenerative spinal changes. And condition to consider in degenerative diseases is DISH, diffuse idiopathic skeletal hyperostosis, osteitis, condensus elae, OCI, and degenerative disc disease with the modic changes. And the Bastroph disease, interspinous. Then the clinical clue to differentiating DISH from ankylosing spondylitis or SPA is the older age of onset, usually is more than 50 to 60 years. Stiffness is common, but less inflammatory in nature, and often associated with a metabolic syndrome like obesity, diabetes, type 1, hypertension. Spinal mobility may be restricted, but often block-like fashion. Imaging, the key differentiator is the Resnick criteria, flowing ossifications along the anterolateral aspect of the at least 4 contiguous vertebrae, and the crucially preservation of intervertebral disc height and the absence of significant sacroiliac joint inflammation, erosions, fusion, or facet joint ankylosis. And enthesitis are thick and flowing. Syndesmophyte in SPA are, as you know, are thin and vertical. And this is the X-ray showing the DISH, comparing to the one in the right side is the inflammatory ankylosing spondylitis. And this is summarizing how to differentiate between DISH and ankylosing spondylitis. Then the other mimickers is osteitis, condensus elae. And the clinical clue for this condition is primarily affect the multiparous woman of childbearing age and present as a chronic low back pain of radiating to the buttocks. And the pain is typically non-inflammatory. Inflammatory markers are normal, no association with HLA-B27 or other extra-articular feature of SPA. And the imaging, the X-ray will demarcate triangular shaped sclerosis in the iliac site of the sacroiliac joints, and the sacral site and the joint space itself are typically normal. MRI maybe shows bone marrow edema in the sclerotic area, which can be a major source of confusion with the sacroiliitis. However, the edema is confined to the sclerotic area and lack of erosions. And this is the, if you look at the image in the left side, the typical of triangular shape in the iliac site of sacroiliac joint, which is indicating the OCI, and the other, on the right side, how the ankylosing spondylitis causing destruction and erosion comparing to OCI. The second category is the infectious mimickers. And infectious mimickers, the pain is often more accurate, severe, localized than typical inflammatory back pain. And the fever, chills, malaise are common, but not universal. Look for the source of the infection, skin infection, endocarditis, recent procedure, or IV drug users. Imaging with the gadolinium is essential. MRI with the gadolinium is essential. Spondylodiscitis, edema, and enhancing of the two contiguous vertebral bodies and the interfering the disc. The disc is often destroyed, an infection, unlikely in SPA. In addition to that, the septic sacroiliitis, typically unilateral and highly destructive. MRI show extensive edema, synovitis, joint fluid surrounding often soft tissues, muscle abscesses. And this is the MRI of the spine, how the infection is causing destruction of the vertebral body comparing to the axial SPA. And this is how the sacroiliitis infection unilaterally, if you see the MRI image, the unilateral sacroiliitis inflammation, which is usually indicating presence of infection rather than inflammatory SPA. The tuberculous spondylitis, the clinical clue for that is insidious onset, long duration of symptoms, constitutional symptoms, low-grade fever, night sweating, weight loss, may present with a spinal deformity or endemic region of area like our country. Imaging, a classical finding, anterior vertebral body destruction with a relative sparing of intervertebral disc initially, often involve multiple level of with the scab lesions. Large, calcified, paravertebral, cold abscess are characteristics. Sacroiliitis is less common than the vertebral involvement. Diagnosis requiring high index of suspicion of TB, confirmed by biopsy of histopathology and culture, PCR of the bone or abscess fluid. This is the how to summary the differentiating point between the infection and axial SPA. The third category of mimickers, they are metabolic and endocrine mimickers, and they are less common but important differential diagnosis for axial pain and and pony changes. Condition to consider: crystal arthropathy, gout and pseudogout, renal osteodystrophies, hyperparathyroidism causing bone pain, and sacroiliac pseudo widening due to the subcondylar bone resorption. And ochronosis, alkaptoburia, the classical, although rare disease, but it is a classical mimicker for axial SPA. How the crystal arthropathy mimic the axial SPA? Rare, long-standing cases, uric acid crystal tophi can deposit in the spinal and sacroiliac joints. This leads to the inflammatory back pain, bone erosions, even vertebral fusion that can mimic feature of axial SPA. These two facious masses can also compress spinal nerve, causing radicular symptoms. How to differentiate clinical history along the history of classical peripheral gout flares, big toes, and the natural history of gout. A lab test definitive diagnosis come from the identifying, as you know, the needle-shaped negatively bifringous crystal in the synovial fluid. Imaging gouty erosions are typically large and punched out with overhanging edges, and the dual energy CT is the high specific imaging modality that can directly visualize and quantify urate deposits. How the pseudogout mimic axial SPA. Calcium pyrophosphate dihydrate crystal deposit or pseudogout can occur in the ligament and disc of the spine that can lead to significant spinal stiffness, pain, destructive changes. The key differentiators, imaging, that key finding is a chondrocalcinosis, as you know, and the lab test, the synovial fluid analysis will refer rhomboid-shaped, weakly positive bifringous crystals. The renal osteodystrophy and hyperparathyroidism, how it mimics axial SPA. This condition arises from chronic kidney disease patient on dialysis, usually, and on X-ray there is subchondral bone resorption, and in the clinical context, the patient will have no case of chronic kidney disease or advanced chronic kidney disease. Blood work will show elevated creatinine, parathyroid hormone, and phosphates. Imaging look for the classic radiographic sign of parahyperthyroidism, such as salt and pepper skull, supraosteal resorption in the hand, bones, and Roger-Jersey spine. Alkaptonuria is the, as you know, is a rare autosomal recessive disorder of tyrosine metabolism and present in the third and fourth decade of severe early onset axial peripheral arthropathy, dark urine understanding, and imaging the pathognomonic severe premature degenerative disc disease with the wafer thin calcified intervertebral disc. The vacuum phenomenon is common, and sacroiliac joints can show narrowing and sclerotic, but typically lack of the florid erosions and ankylosis of axial SPA. And this is the typical of vacuum phenomenon is the evident here in the vertebrae. The fourth category is malignancy. The critical differential for the any persistent non-responsive back pain, especially with red flag. And the red flag patient more than 50, history of cancer, unexplained weight loss, pain, worse at night, breast, thoracic pain, neurological symptoms, condition to consider metastatic cancer, prostate, breast, lung, kidney, thyroid, and the multiple myeloma, lymphoma, leukemia. And the clinical clue for malignancy, pain is often consistent, progressive, and not relieved by rest or position changes. Poor response to NSAID may present with a pathological fracture or hypercalcemia. Imaging, the typical lytic or plastic lesion in the vertebral body or pedicles. Pedicle destruction is a classical sign not seen in the SPA. Myeloma, diffuse osteopenia, punched out lytic lesions, vertebral plana, compression fractures. MRI is the best modality. MARU replacing lesions are low in T1 and high in T2 and STIR, and enhancing with the gadolinium. The key is the involvement pattern, the focal destructive lesions rather than edema at the vertebral corners. Lab serum and urine protein electrophoresis, multiple myeloma, and the free light chain for myeloma and PSA for the prostate cancer. The fifth category is the other inflammatory syndrome, and the overlapping feature can cause significant diagnostic confusion. Condition to consider SAVO syndrome, synovitis, acne, postulosis and hyperostosis and osteitis, and the sarcoidosis. The clinical overlap with the SPA is axial, the peripheral arthritis, enthesitis, sacroiliitis. The key differentiating point is the severe acne in SAFU, then the palmoplantar pustulosis, and cardinal feature of psoriasis can all occur in both, more specific for the SAFU. Osseous, anterior chest wall involvement is called sternoclavicular mandibulo-sternal joints is the hallmark in SAFU, and the imaging is hyperostosis and the osteitis, and the, of course, HLA-B27 negativity usually is negative in SAFU while it's positive in axial SPA. And this is the feature of SPA of the SAFU. This is the nuclear imaging of SAFU patient with something called the sternoclavicular joint and sternum involvement. It's called bull's head sign. And this is the palmar rash, as well as the severe acne in the back. The other inflammatory syndrome is sarcoidosis. Sarcoidosis is considered a great mimickers of spondyloarthritis, and because of the multi-system involvement of both disease, and can affect the same part of the body, leading to significant overlap sign and symptoms as well. The clinician might initially suspect SPA when the patient condition is actually is sarcoidosis, leading to the diagnostic confusion. And how to differentiate the clue point to sarcoidosis, chest X-ray, the presence of bilateral hilar lymphadenopathy, and in the classical sign of sarcoidosis, and the blood test elevated level of angiotensin converting enzymes and high calcium level, hypercalcemia, are suggestive of sarcoidosis. The biopsy, the definitive diagnosis come from the biopsy of affected tissues and non-caseating granulomas. Clue pointing to the SPA, as you know, positive HLA typing and imaging pattern of characteristic pattern of spinal changes in X-ray and syndesmophyte and other changes in the skeletal axial joint, as well as the peripheral joints. Associated condition, personal or family history of psoriasis or inflammatory bowel disease, increasing the likelihood of SPA. And this is the summary how to differentiating point between the among these conditions with the axial SPA. And the conclusion and take-home message, think beyond SPA. Spondyloarthritis is the clinical diagnosis supported by imaging, but a broad differential must always be maintained. History is a paramount. Detailed history of pain, characteristic, systemic symptoms, a risk factor is the most powerful diagnostic tool. Imaging intelligently and interpret carefully, distinguishing syndesmophyte SPA from osteophyte degenerative like DISH. Look for unilateral destruction, infection, pedicles loss like malignancy, or iliac only like OCI. MRI is not a guarantee tool or a diagnostic tool for the SPA. Bone marrow edema can be seen in infection and in malignancy and even degenerative diseases, and pattern recognition is the key. Failure to improve an appropriate therapy in said biologics should trigger the diagnostic re-evaluation of your patient with a SPA. Thank you for your attention. I think this is the end of my talk.
Thank you very much, Dr. Al-Hussein. It's very quite refreshing. Actually, it's not just a basic thing. It's very important to consider all these, because during our clinical practice, I just got a patient a month ago, and his 50 who was being already an anti-TNF inhibitor, and he has seen in a private clinic, and he was just got referred to us, and this guy has DISH, no sacroiliitis whatsoever, and it's pure DISH. It was missed by someone who's patient anti-TNF for 6 months, and he's not getting better. Our next speaker, Dr. Naif Al-Ghanim. Dr. Naif is a consultant rheumatologist at King Saud Medical City in Riyadh. Dr. Naif is very active member of different society, and he's been engaged actually pretty much very actively in all the scientific activities in the field. And he's going to very much provide what we've been asking for a long time ago. We were kind of disappointed, frustrated by the absence of our own national registries in different rheumatic disease. And Dr. Naif is going to touch base on this very important matter. Doctor.
Shukran, Dr. Ahmed. Good afternoon, and thank you for having me today. I would like to thank Al-Qasim Rheumatology Conference Committee for their kind invitation. So today I'll talk to you about the PSA registry. The PSA registry is the first registry that is made by the Ministry of Health for rheumatological disease. And in the next 25 minutes, I'll try to answer the following questions. Why did MOH establish national registries for different diseases, including psoriatic arthritis? How does MOH decide which medication to be included in the registries? Is it possible to prescribe other medication or higher dose for patients with PSA? And what are the challenges that we face when we include the patient in the registries? So in 2022, Dr. Ahmed Jideh, the Deputy Minister of Health at that time, he ordered the establishment of the psoriatic arthritis registry. And the main reason is to be able to order 3 medications, secukinumab, upadacitinib, and guselkumab for patients with PSA. So and the question is why did they establish the registries? Why don't we just order the medication right away? And the main reason is financial, is to control the cost of high-cost medications, including biologic and JAK inhibitors, to guarantee that the patients who receive these medications really have psoriatic arthritis. We discovered that several patients were taking ustekinumab and ixekizumab, and the real diagnosis was osteoarthritis, for example. To strengthen the negotiation with the pharmaceutical companies and through what's called cost-risk sharing agreement. Cost-risk sharing agreement means that if the patient receives the medication and does not respond, then the pharmaceutical company will either give us free medications or they reduce the price. I'll give you an example. For example, let's say that you started patient on secukinumab and each injection cost $5,000. After 16 weeks, the patient does not respond to the medication, then the MOH tell the pharmaceutical company that the patient did not respond to the medication, and they reduce the price, for example, by 50%. Another example for cost risk sharing agreement is that, let's say that you started patient on drug A. After 3 months, patient does not respond to the medication. Then the MOH tell the pharmaceutical company the patient did not respond to the treatment, give us 3 samples. So the MOH receive 3 samples if the patient does not respond. And this is why we have to use the DAPSA, ASTAS to show the pharmaceutical company that the patient did not respond to the medication. So this is what they call it cost share agreement. Some they call it value-based agreement. So other indication for registries is we know that registries mirror real life. Randomized controlled trials usually exclude patients with comorbidities. It will enable us to see long-term results. It also allow us to see the efficacy when we switch between the medication. And finally, it will be able to identify the side effects of the medications who take the medication for a long time. So we are actually very late in the registries. The first PSA registry was more than 50 years ago. And it was made in Leeds, UK by Moller Wright. At that time, they didn't know that there's something called psoriatic arthritis. They thought they include patients who have psoriasis and inflammatory arthritis. They thought that this patient has rheumatoid arthritis and psoriasis. But because of this registry, we know now that there is a single disease entity called psoriatic arthritis. And it will enable us to know the pattern of the disease dactylitis, enthesitis, and axial SPA. And also it allowed us to know that there is a familial risk for patients to develop psoriatic arthritis. This is the map of the PSA registries worldwide. You can see in the United States they have, I think they have at least 20 registries for PSA, some some local and some are international. In Saudi Arabia, we have only one national registry. However, there are several PSA registries that is limited to universities or some tertiary hospitals. And this is the first registry that included patients from different parts in Saudi Arabia. So this is the list of the registries in the MOH. Actually, we are not the only one. We are late, the rheumatology. There are 3 registries for dermatology, atopic dermatitis, psoriasis, and alopecia. And through these registries, they can order baricitinib, for example, and ixekizumab for their patient. Neurology, they have a registry for multiple sclerosis, spinal muscular dystrophy. Pulmo, they have severe asthma and idiopathic pulmonary fibrosis. They ordered nintedanib through these registries for patients with ILD, and other registries like severe depression, retinal dystrophy, gene editing registry for sickle cell and thalassemia. So how did we establish the MOH registries? I think in 2022 or 2023, the MOH conducted a 3 virtual meeting over 2 months. It included me and Dr. Ibrahim Al-Hamoud and 1 dermatologist, Dr. Maysa Ashmawi, 1 pharmacist, and 2 registry platform coordinators from IQVIA. And then based on that, we established the PSA registry. It was launched in March 2024. The first patient actually entered about 1 month after the establishment of PSA registries. It included 19 regions and 44 hospitals. And they were able to conduct training waves for physicians. So how many physicians and hospitals are included in the PSA registry? There's 44 hospitals, and 95 consultant rheumatologists now have an access to the PSA registry. There's 234 total users, and these users include senior registrars, which is Tabib Naib Awal, and registrars, which is Tabib Naib. And these, they can't order the medications. They can log in. They can help you log in, and they fill their registries. And then the consultant rheumatologists go in and order the medication for the patients. So most of you, I think they have access to the registry. If you don't, let me know. Then you will receive an email from the MOH, and there will be a link that you'll activate it, and then it will enable you to have a username and password. This is how the PSA registry interface looks like. Once you get it, you have to press on the plus sign and choose IMM patient registration. Then you will have to order the demographic data and then choose from the registry. Is it PSA, is it RA, or something else? Once you order the medication, there is an very important thing you have to do. Once you enter the patient information, you have to contact the pharmacist at your hospital and tell the pharmacist that I have ordered the medication for this patient, because the pharmacist at your hospital, they have to go on and share the information of the patient with the central medication supply. If you don't inform the pharmacist at your hospital, the medication will be delayed. Then the pharmacist will contact the MOH. The pharmacist there will, at the MOH, will dispatch the medication to the hospital. So it's very important, once you fill and order the medication, let the pharmacist that work at your hospital or to know that you have ordered the medication for the patient. So the PSA registry was established based on a guideline. The guideline was published in 2024, but we took, I think, 1 year just to go through to make this guideline. It included 4 rheumatologists, me, Dr. Ibrahim Al-Hamoud, Dr. Al-Badr Hamza, and Dr. Iman Al-Khartas, 2 dermatologists, Dr. Mohammed Fatani and Dr. Maysa Ashmawi, and also there were many pharmacists from different MOH hospitals. This is not the first guideline for rheumatological disease. About 1 year before that, the MOH published a guideline for rheumatoid arthritis. And earlier this year, they published SLE guideline. And finally, a collaboration between the Saudi Society of Rheumatology, Dr. Hanan, and the MOH, we were able to publish the axial SPI guideline. So currently, we have 4 guidelines, but only 1 registry. So this is the flow chart of the medications that is for patients with PSA. You can see that there are 4 domains: peripheral arthritis, dactylitis, enthesitis, and axial PSA. The first line of treatment is IL-17 inhibitor for patients with peripheral arthritis. If they don't respond to IL-17 inhibitor, you can go to JAK inhibitor. For dactylitis and enthesitis, after the failure of IL-17 inhibitors, you can choose IL-23 inhibitor. And for axial PSA, you have to make sure that the patient failed also anti-TNF. And so the clear question is, why IL-17 inhibitor recommended as first line after the failure of NSAID and methotrexate? Why we can't freely choose medications like the one in the EULAR and GRAPPA? For example, GRAPPA for peripheral arthritis, you can choose from 6 different types of medications. So the answer is that this is what the MOH wants. We told them that we want the guideline to look like this, to be free, and they told us that if you don't choose the medication, we will choose it. There should be only one type of medication. And they told us that, okay, if you don't want to do it, the dermatologist did it. In 2020, the dermatologist published guideline, and you can see for psoriasis, only IL-23 inhibitors can be used, and for PSO and PSA, is IL-17 inhibitors can be chosen. So they said that we can't make you choose any medication that you want. You have to choose only one type of medication, because if you don't choose the medication, we will choose it ourselves. And the main reason is that if let's say that they chose IL-17 inhibitor, as which we did, then they can negotiate. They get a better price with the negotiation with the pharmaceutical company. So this is mainly a cost-driven decision. So why did we choose IL-17 inhibitor and not IL-23 or JAK inhibitors? I think you all know IL-17 inhibitor has dual efficacy in joint and skin. And it's the only medication that has been shown to be effective on axial PSA inclusively. As Dr. Ibrahim, he showed us that in the Maximize trial, secukinumab was effective, and in this trial, they included only patients with axial PSA. It's also effective in enthesitis, dactylitis. It has a good safety profile. So after that, we had to vote. So the voting included dermatologists, rheumatologists, and pharmacists, and we chose IL-17 inhibitor. These are the medication. After we established the registry, the MOH ordered or chose these medication to be included in the registry. And these are the disease activity tools that you have to be used to assess the patient disease activity. And this is why it's very important, as I said, that if you use these treatments or disease activity tools, the MOH can use this as a disease activity tool to show it to the pharmaceutical company and tell them, based on, for example, DAPSA, the patient did not respond to the medication. Or based on ASDAS, the patient does not respond to medication. For DAPSA, patients should improve by at least 50% after 3 months and achieve remission or low disease activity after 6 months. ASDAS should be decreased by 1.1 after 3 months and achieve remission or low disease activity after 6 months. For enthesitis, you have to choose MDA. And for dactylitis, it's very simple. You have to do digit count, and the digit counts has to be decreased by at least 1. So let's say that you started a patient on secukinumab, and after 3 months, the patient did not improve by 50%. Let's say it improved by only 25%. At this time, you can choose the second line treatment, and the MOH can activate what's called the cost sharing agreement and get free samples or pay less for the medication. This is the screening test. So for latent TB, you can order either IGRA or PPD, and you have to do chest X-ray. Lipid profile was included at baseline because of upadacitinib. JAK inhibitors can increase the lipid profile in patients with PSA. Okay, can I use interleukin-23 inhibitor or JAK inhibitors as first line for some patients? The answer is yes. Now you can use it. You have to just write in the text field. There's a free text field that you can write that you want to use, for example, upadacitinib or guselkumab as first line of treatment. And you say why. And the MOH is now very flexible in approving the medication. For axial PSA, the only two medications that you can use as first line now is IL-17 inhibitors or JAK inhibitors. You can't use IL-23 inhibitors, and this is because IL-23 inhibitors has limited evidence or limited data in axial PSA. There is only post-hoc analysis for guselkumab, and currently they are conducting a STAR trial for pure axial PSA, and the result will be published in 2027. Can I use higher dose for the medication? Yes, in special cases. For secukinumab, you can only use 150, but you can increase to 300 if the patient does not respond. You can say that either switch to another line of medication, or you can write that you want higher dose of the medication, or if the patient has moderate or severe plaque psoriasis. So if you want higher dose, you have to say that the body surface area more than 3%, or the PASI is more than 10. And then you will get approval for high dose 300 milligram. Guselkumab, there is only one dose, 100 milligram every 2 weeks. But if the patient has Crohn's disease, you can say that the patient has Crohn's disease and I want higher dose, and you can then use a 200 milligram every 4 weeks. For upadacitinib, again, it's only one dose, 50 milligram once daily, but you can use a higher dose for patients with comorbidities, ulcerative colitis, and atopic dermatitis. 45 milligram, I think they use it, 45 milligram as induction, and then 30 milligrams once daily. Can I use ixekizumab instead of secukinumab for patients with PSA, and can I use secukinumab in the registry? In 2022, I think what happens, what we call ixekizumab crisis, the MOH, in one night they decided, okay, you can't use ixekizumab for your patient with PSA. And we didn't know why. I didn't know why. And then I discovered that the dermatologist complained to the MOH that the rheumatologists, they are using ixekizumab and we don't have enough ixekizumab for our patient. So it's because the dermatologists complained, because of their complaint, they said, okay, stop, you can't use ixekizumab. So unfortunately, many patients had flare because of this decision. And the MOH, they said, this is a restricted privilege for dermatologists only. It's not for you. But they made some exceptions. They said, okay, if the patient is on ixekizumab before December 2024, you can continue using ixekizumab. For ustekinumab, they made decision this year. It's a new decision. They said that for ustekinumab, you can't use ustekinumab after August 2025. But if the patient is on ustekinumab before August 2025, you can continue using the medication. Okay, so 5 minutes. So difficulties faced by rheumatologists, I think you all know that. We don't have enough time to enter the registries. The registry is complex. There are many variables, and we don't have enough staff that can help us with entering the informations. And this usually can lead to incorrect data because we have to enter maybe wrong numbers. And the MOH have what they call patient support program coordinators. And these coordinators can help you mainly only with measuring disease activity tools. They don't have the right to, or they are not eligible to use the patient information or enter the data for you. So how rheumatologists manage these difficulties? Dedicated time. So in our hospital, we ask one of the staff to enter the patient's information at one time. For example, one half a day every Friday, or sorry, every Thursday. The staff go there and they fill the patient information. Sometimes they have to call the patient to know some of the missing information. Part-time support, and there is also some physicians refer the patient to other hospitals to get the medications. So how MOH chooses medications? Why did they choose secukinumab, for example, not ixekizumab? Why did they choose guselkumab and not risankizumab? They do something called budget impact analysis, BIA, and this is help them to estimate the price of the medication, or how much they will pay for the patient in the next 1 to 5 years. In this budget impact analysis, they look at the price of the medication, and they also look at what blood test patient will need, what are the possible side effects the patient will have, and possible hospitalization because of side effects. And also they look at the administration costs, especially for patients who are on IV medications. And based on that, then they can say, if they can't pay or if the budget allows them to use the medication. They also use something called ICER, which is incremental cost effectiveness ratio. Let's say that we have IL-17 inhibitor, costs $65,000, and now we want a new medication, IL-23 inhibitors, and the difference between the price is $20K, and then they use something called QALY. QALY is a quality adjusted life year, which means one QALY means that 1 year lives in good health. And they look at the difference, and then they divide the delta cost by the delta effectiveness, and based on the number that they get, they decide which medication. For example, some in the United States, they can include the patients, the medication, if the price is $50,000 per QALY. In the UK, £20,000 per QALY. In Saudi Arabia, we don't have a clear number for cost effectiveness until now. I think MOH has it, but they did not publish the number. Future rheumatologist registries could be RA, SLE, and axial SPA. The MOH is very clear. They will not include any new medications without registries. There's a lot, for example, anifrolumab, we wanted for our lupus patient. They said, we will not include it as formulary without registries. Baricitinib was approved to be used for RA, but until now, we can't prescribe it for our patient because we don't have rheumatoid arthritis registry. The only way to get these medication is through direct purchase order. My rule in the MOH is to give recommendations and the registry oversight. The final decision is by the MOH and mainly by the drug policy and regulation department. They make the final decisions in choosing the medication and establishing the registries. There's a good research opportunities. If you entered one patient into the PSA registry, you can access the data and do a study. You just have to write a proposal and send it to the Assistant Deputy for Drug Policy and Regulation. Currently is Dr. Sultan Shimari. I can share her information with you, and you can send the proposal to her, and you can do studies on the PSA registry. Currently, we have, I think, between 650 to 750 patients in the registry. So there's a good number, and there's a good opportunity to do a study on this patient. Finally, I know registries might be challenging, but it's the only tool and the best tool that we have to make sure that the patients received a good medication, to prove the efficacy of these medications in our population, and ensuring the safety of the medications. Thank you.
Thank you very much, Dr. Ghanem, and all our speakers. And we'll open for discussion, for questions and discussion now, the floor, please. Any questions for speakers. Doctor.
Thank you for informative lecture about spa mimics. And what about a typical form of ankylosing spondylitis in which the patient presented by spondylitis without sacroiliitis? Because I have patient 42 years old, presented by inflammatory back pain for 15 years, and every now and then when she do X-ray or MRI, diagnosed as DISH, because she doesn't have sacroiliitis. When I revised her case in PubMed, I found many published cases about a typical form of ankylosing spondylitis without sacroiliitis.
In fact, as you said, inflammatory axial SPA, you have to be very careful in assessing your patient. As I told you, detailed history, physical examination, then the interpretation of lab, inflammatory markers, in addition to imaging study. The imaging study should be interpreted by musculoskeletal radiologist, because if the image interpreted by normal or general radiologist will be a lot of pitfalls and mistakes of interpretation of these images. So make sure of all about these things. Then, in addition to the genetic study, as you know, Chilebe 27, it helps a lot. If you have all these data and you are sure this is axial or inflammatory SPA, then start your treatment. But the most important thing, as you told you, the details, clinical data, excellent interpretation by MSK radiologist. This is very important, because if these images interpreted by the general radiologist, a lot of mistake will be there, and in fact you will misdiagnose other diseases, or you can misdiagnose inflammatory axial SPA or peripheral SPA. So the most important is the excellent interpretation of the clinical data and imaging.
Actually, I started biological treatment patient with dramatic improvement.
May I comment
Dr.
on
Ahmed?
this? Yes. With regard to the one I quoted initially when I presented Asiri, this guy was in his 60s, and he doesn't have inflammatory back pain nor any SPA feature whatsoever. Just mid-thoracic pain, and he's diabetic, and more of stiffness, actually. So, by the way, he had also MRI done of the spine and did not show no bone marrow edema lesion. It's mostly just dish. So that's one. The other thing is psoriatic spondylitis. I think all of us know that 30% they will have only spine without sacroiliitis. So that's one thing I think one has to really be careful, even in the absence of psoriasis, because not all psoriatic patients have psoriasis at the time of diagnosis. So 30% of axial BCA, they have only spine involvement without sacroiliitis.
Thank you very much. تفضل دكتور.
Assalamu alaikum wa rahmatullah. Walid Hafid, beautiful actually session by experts, national and regional experts in the field. My question is to Dr. Naif. We sit back in the clinic. So I practice at one of the MOH hospitals in Makkah. And it's not really uncommon to express sometimes the frustration that we usually face when we have some sort of limitations in prescribing medications. But after attending your lecture, a lot really makes sense. The work that is done by colleagues at the MOH really makes kind of like sense now, and they're really doing this work instead of like doing it randomly. They do it in a more of, I would say, structured fashion. So what I was really wondering as a practitioner, is there a way that we can have, I would say, updated news, or I would say like quarter kind of like news on the decisions and the updates that are being taken by the MOH colleagues, so we can stay updated. The other point is that having this good number of patients in registries would definitely initiate a lot of research work, especially for those who are research enthusiasts. So how can we increase, or I would say optimize and enhance the collaboration, for example, between the Saudi Society for Rheumatology as well as the Ministry of Health, who's leading these registries? Thank you.
Thank you, Ali. So I think there is a good collaboration now between the Saudi Society of Rheumatology and the MOH. They had rheumatoid arthritis guideline made collaboration, axial SPA, and actually now we are working on having a recommendation for SLA referral, and this will be also a collaboration between Saudi Society of Rheumatology and MOH. For me, whenever they have, they say they want to do something, they want to establish, for example, guideline, I always try to involve Saudi Society of Rheumatology, and they are very flexible. They always said, yes, we want the Saudi Society of Rheumatology. So whenever I tell them to involve anyone, they said, okay, no problem. For the updates or the decisions, actually the decisions are made by the drug policy and regulation departments. The decisions actually sometimes I personally don't agree. For example, the choice of biosimilars. Or now we have biosimilar from Boston Oncologies. Before that, it was from Sandoz, and before that, even for example, infliximab, they changed it from biooriginal to biosimilar, and we didn't know actually we are using biosimilar until like 1 or 2 years. Unfortunately, these decisions are made without collaboration with the physicians at MOH. Not only with rheumatologists, but also they choose medications, for example, for dermatology or GI or neurology without involving a neurologist. So I'm open, I tell them that we should be involved. For example, if they choose rituximab, now we have biosimilar rituximab, they were supposed to talk to neurologists because they use it as first line for multiple sclerosis. They have to talk to oncology, and they didn't. They chose the biosimilar by themselves. These decisions, I don't know how they do it actually. I don't know how they decide, and I don't know when they do the decisions. I always try to let them know that they should involve physicians when they make these decisions. Sometimes they contacted me, sometimes they make the decisions by themselves. For example, ixekizumab, when they stopped ixekizumab, they didn't tell anyone that we will stop ixekizumab dispatch for PSA patients. So these decisions, unfortunately, I don't have rules in it, and they don't involve me or involve any subspecialties. And I'll try to convince them to involve physicians when they make these decisions in the future.
معلش Naif, since you've addressed, now you're addressing the collaborative work among different institutions, it seems like the one country with 6, 7 ministries of health. I mean, now we're talking about MOH with the Saudi Society. What about other health sectors? The military, MODA, MSD, the National Guard, the private sectors, King Faisal Specialist, universities. I think it's a bit tough task to do. I mean, is there anything in the horizon to overcome all these challenges and to come up with some, because
yes.
هو إذا تسمح لي الدكتور أحمد, regarding the registry, if you are asking about the Saudi guidelines, for example, it's not only about MOH representing 65% of the Saudi population when we talk about the health-related issues. This is not my talk. This is an evidence-based when it's raised in Majlis al-Sahhi. Now, this number one. Number two, in Saudi guidelines is not only MOH. We have one from Military of Defense, and we have one from National Guard Hospital. They are clinical pharmacists. Yes, they are maybe not rheumatologists. We have dermatologists from عندكم من الجنوب من العسكري الخميس مشير. So the committee representing all different ministries within the Saudi guidelines. Maybe they are not rheumatologists, but they are representing their own ministries.
But they're not officially authorized by the corresponding, honestly, we'd love to have all of this, but those are not just based on their sort of active involvement in different society. They're not officially represented. I'd love it to have this guy coming to our military hospital and mentioning to us, we want to apply this. We'd love to have it, but this is not happening.
Thank you, Dr. Ahmed.
I just want to mention something. Even, I don't think there will be a difference. يعني with all my respect, I mean, at the end, the recommendations, whether made by a rheumatologist. Yes.
Dear colleagues, can I say something? These are all logistics, this is not the time we discuss it. I mean, we are discussing the scientific presentation presented by our colleagues.
Thank you very much, Dr.
I mean, to deviate right and left will take a long time discussing.
I have two questions to one for Dr. Ibrahim, one for Dr. Asiri, quick. Dr. Ibrahim, do you think our current measures to detect axial spondyloarthropathy and psoriatic arthritis are valuable, and how we can improve it?
Well, if you look to the available assessment tools, the answer is not accurate, and we miss a sizable number of patients. And the reason behind that, the only thing that's probably more toward objective is the ASTAS. And it's very simple. We try to encourage everyone to use it because it's available in a smartphone, and it's very simple. It takes less than 1 minute. However, it will miss the extra spinal manifestation, because these diseases are multi-system, very heterogeneous. So that's why when we did the guidelines and we tried to choose one, it's very tough. I do believe the physician global assessment still play a major important role in monitoring any rheumatological disorder. So still, we wish to have a very objective, but still there is high subjectivity in assessment tools.
Thank you very much. My question to Dr. Asiri, do you think we should have mandatory screening tools for those patients with suspected spondyloarthritis? For example, patients with fibromyalgia, with other. Do you think we should have mandatory screening protocols for those patients?
In fact, as you know, the most important tool as a clinician in rheumatology is a history and physical examination. So for the time being, we do have only these tools is the most important. As you know, almost 99% of diseases, rheumatology diagnosed by history taking, good history taking, and good physical examination. In addition to the imaging and lab, it helps. The same as in the axial SPA, as well as the mimickers. The tools to pick up the mimickers and to diagnose correctly the inflammatory SPA is to take excellent and detailed history, which is, I think, it's the best, the most important tool in picking up these diseases. History and physical examination, in addition to the imaging and lab.
Thank you very much. Thank you very much for our speakers, and thank you very much. Next.
Thank you for all. Now time for satellite. It will be presented by Dr. Walid Hafid, well-known associated consultant, professor in Al Qura University and the Noor Hospital.
Assalamu alaikum wa rahmatullah. Shukran, Dr. Muhammad, for this kind introduction. Thanks, colleague in Novartis, for inviting me to present a few slides on a topic that was extensively actually presented and discussed. So I'll not take much of your time. It's a short talk, which I will be focusing on the following objectives. So the burden of axial spondyloarthritis and its impact on the activities of daily living. I'll walk you through the role of IL-17 in the pathogenesis of ankylosing or axial spondyloarthritis, and then what does IL-17 inhibition do in terms of preventing this role, and then I'll walk you through the 2025 Saudi guidelines for the management of axial spondyloarthritis. So let's start with the first. So I mean, these are I would say introductory or a little rundown information that we're all aware of. Axial spondyloarthritis is not just a disease that causes pain. If you look at the impact of axial spondyloarthritis on daily patient-reported outcomes, such as morning stiffness, pain, fatigue, as well as, nocturnal back pain. And if you look at the percentages, they're all, very high percentages. So it's not just a disease that causes pain in the lower part of the spine. It's rather a disease that leads to disability. That's why it's really important to tackle it and address it, at the earliest opportunity to improve patient-reported outcomes. Now let's move on to the second part of the talk, which is interleukin-17. So we know that interleukin-17 is one of the major pro-inflammatory cytokines that has a significant role in the pathoimmunogenesis of seronegative spondyloarthropathies. Now, how does IL-17 as pro-inflammatory cytokine does what it does? It is actually through two main pathways. So the first pathway that you can have a look at it at the lower part of the or left side of the slide. The trigger for this pathway is a mechanical stress that encourages some of the innate immune, I would say, system cells such as mast cells, neutrophils, as well as the lymphoid cells to produce more and more interleukin-17 into the circulation. Another important pathway that we're all aware of is the interleukin-23-17 pathway, and it is usually triggered by the activation of the immune system through different etiologies such as genetic predisposition, environmental factors, as well as changes in the immune system, which leads to the activation and production of interleukin-23 in abundance into the circulation, which in turn also increases the production and excretion of interleukin-17 into the circulation. So what does a medication or interleukin-17 inhibitor such as secukinumab does? It blocks these pathways by which it can prevent the clinical manifestations that we tend to see in patients with axial spondyloarthritis. Now, if you look at Cosentyx, it can provide early as well as sustained symptom relief in patients with axial spondyloarthritis. So in this a statistical graph on the x-axis, you can see the percentage of patients achieving ASDAS 40. And on the y-axis, you can see a duration that is extending up to 5 years. You can see that interleukin-17 inhibitor Cosentyx can beautifully have sustained disease control, and up to 80% of patients who were initially started on Cosentyx continue to be on Cosentyx up to 5 years of the study with significant numbers when it comes to disease control. Now, Cosentyx also provides sustained, I would say, improvement in BASDAI scores in both groups of non-radiographic axial spondyloarthritis as well as axial spondyloarthritis. As you can see here, that the initial BASDAI goes down by 50% in 1 year of the treatment course. How about Cosentyx in axial spondyloarthritis? So SURPASS study is a study that tested the ability and efficacy as well as safety of Cosentyx compared to adalimumab biosimilar, Hyrimoz, in preventing radiographic progression in patients with advanced, or I would say severe and active spondyloarthritis. Now you can see here in the screening period, they included patients who were not showing response on non-steroidal anti-inflammatory medications. On the other hand, they were biologic naive. Patients then were randomized in 1-to-1-to-1 fashion to 3 arms. First arm, secukinumab, 150 milligrams. Second arm, secukinumab, 300 milligrams. And the third arm was adalimumab biosimilar. The primary end point of the study was to check the radiographic progression at week 104 or 104. And what was noted that both medications were, met the primary endpoint in terms of, preserving the radiographic progression, and they were all associated with no radiographic progression at week 104 And that was really reassuring. In terms of the other secondary endpoints, one of the secondary endpoints was, is there any, further syndesmophyte formation during the period of the study? And what was noted is that both medications did well when it comes to their ability of preventing further radiographic progression, mainly in terms of syndesmophyte formation. In terms of side effects, you can see here overall safety and tolerability of secukinumab as well as adalimumab was not out of, or surprising. Majority of the side effects are the side effects that we usually see in, I would say, acceptable percentages in our daily practice. And these are some peace of mind, I would say, from consistent safety profile. So you can see that there were no, I would say, significant warnings when it comes to the utilization of Cosentyx in daily practice. Lastly, the 2025 clinical or Saudi clinical practice guidelines. So this is a guideline that was aimed to serve as a national reference for axial spondyloarthritis and to address some of the specific needs of the local populations in Saudi Arabia. As you can see here, that there were also some other objectives such as optimizing the guide for different treatment modalities, improving the patient outcomes, as well as guide and identification and treatment strategies to minimize the impact of the disease. Now, the guideline consisted of 14 panel, out of which there were methodologists, rheumatologists, family physicians, as well as clinical pharmacists. And again, it was a collaboration between the Saudi Society for Rheumatology as well as the Saudi Society for Clinical Pharmacology. And there was an extensive, search that was conducted that covered a period of 14 years, from 2010 to 2024. And whenever a recommendation, reached to an agreement of 70, it was, taken into the guideline. The guidelines issued approximately 31 evidence-based recommendations and 7 statements. And mostly these guidelines or recommendations were echoing what was also seen in the other international guidelines, such as the ACR as well as the ULAR ASAS and the Latin America guidelines. Now, again, the treatment recommendations were categorized into 3 phases. So first phase is non-steroidal anti-inflammatory medications for a period of 2 to 4 weeks. If there is no response or adequate response, then you would go to the second phase. And in the second phase, as you can see here, that patients were categorized into 3 groups. So the group in the left, which are those who have axial spondyloarthritis with coexisting IBD and uveitis. For this group, of course, TNF inhibitors were selected exclusively. A group in the middle, which consisted of patients who exclusively have axial spondyloarthritis, in which the recommendation was made to initiate either interleukin-17 inhibitor or TNF-alpha inhibitor or JAK inhibitor. And then a group in the right, those who were having axial spondyloarthritis with severe psoriatic arthritis or with enthesitis. And in this group, again, IL-17 was favored over TNF-alpha inhibitor as well as JAK inhibitor as a treatment modality. Now, the third phase is actually the switch and cycle phase, so in which if you did not see response from the medication that you started in phase number 2, then you would switch to another or cycle to another medication, depending on the best of your clinical judgment. So, ladies and gentlemen, to summarize, I would say that axial spondyloarthritis is a chronic inflammatory disease that causes pain, stiffness, disability with major impact on activities of daily living. IL-17 is a key pro-inflammatory marker that has a role in the development of the disease. Inhibiting this cytokine really leads to rapid and sustained symptom relief. SURPASS study showed low radiographic progression and comparable safety for secukinumab as well as adalimumab biosimilar over 2 years. And of course, the 2025 Saudi clinical practice guidelines recommend stepwise approach, starting non-steroidal anti-inflammatory first, followed by biologics, and then switching to improve outcomes. And I would like to thank you for your kind attention and listening.
Thank you, Dr. Walid. We'll start the fourth session, scleroderma and translational disease session. My pleasure to introduce the chairman, Dr. Fahad Al-Uqaili. She is consultant, rheumatology, internal medicine, military hospital. Welcome, Dr. Fahad.
شكرا. السلام عليكم. أحب أحيي زملائنا في القصيم على يعني نشاطهم وجهودهم ومثابرتهم بإعداد هذا المؤتمر للمرة الخامسة على التوالي. مجهود جبار ملموس ويعني ثري علميا. شكرا لكم حقيقة. I will introduce our next speaker, Dr. Rahma Al-Salmi, a consultant pulmonologist and immune and interstitial lung disease, about interstitial connective tissue disease and ILD. Welcome, Dr. Rahma. The floor is yours.
Assalamu alaikum jami'an, Jum'a Mubarakah. I would like to thank the organizing committee for giving me the chance to present in this very well-established national conference. So we're going to talk today, بعد الصلاة على الرسول الأمين عليه الصلاة والسلام, about the CTD-ILD recommendations. And we're going to highlight some clinical points and values that I'm sure they came across your mind as you practice and see a lot of CTD-related ILD. So I'm going to go over clinical points of SARD-ILD, and for the considerations of uniformal terms, I'm going to refer to CTDs to SARD for the next slides, and I'm going to go over the international recommendations regarding screening, monitoring, and pharmacological management. ILD diagnosis, or in general, any medical conditions diagnosis, we go through two major pathways. Either you diagnose based on a strict adherence to a diagnostic criteria, or you just use your clinical gestalt, your clinical judgment. And that's not only applicable to the diagnosis, but also to the managements. And I'm sure most of us in many diseases, we follow the second path. We just go with the clinical practice because of the lack of the evidence-based guidelines recommendations. ILD diagnoses are very challenging, not because of CTD-ILD, no, but in general, they really are complex cases. We face a lot of negative points. We don't have enough samples to diagnose our patients after the surgical lung biopsy. We don't know what's going on in terms of their exposures. The evolving connective tissue disease, you know that 10% of CTD-ILD presents with the lung manifestations ahead of time, so we are the ones who encountered these patients. And finally, the importance of multidisciplinary discussion. So this is the path that we usually follow as in a complex ILD specialist. So we starts with early detection, screening in a high-risk patients, eliminate the risk factors, for instance, the exposure. And then you work on or confirm a working diagnosis after you assess for a differential diagnosis and assess the risk factors. And usually at this point where we involve the multidisciplinary discussion team, mainly in my institute runs by pulmonologist colleagues, radiologist and pathologist. And then you assess the ILD severities. The next ones up to the second MDD is usually done in the first or second clinics. You ascertain what the disease severity is my patient's having based on a clinical, physiological and radiographical findings. The progression of the ILD, whether what had happened in the last few years before my patients presented to my clinic or what had happened since I've been following him up. Assess the complications and comorbidities. These are very important to address because patients can have a negative outcome, not because of their ILD disease, but because of these two common variables that we have to look for. And then you have an idea about the prognosis, and then decide about treatment. Second MDD can usually be happening, and this is where we involve the rheumatologist to share about their ultimate input in terms of management and further investigations. And then you decide about the management, non-pharmacology, pharmacology, and monitoring. The importance of MDD, I'm sure you face challenging cases and your colleagues in pulmonology field had helped you. Same to us when we see or seek a rheumatologist opinion, we are enlightened about their input and vision. So this is nicely illustrated in this colorful slides. This is a study looked into their internal cohort, pre and post MDD diagnoses. You can see by the change of the colors, sinister diseases such as an IPF in the first column, the diagnoses have changed to a more benign courses, idiopathic NSIB or CTD-related ILD. And that's translated into treatment changes as well. Instead of keeping the patients on the antifibrotic, and immune modulatory drugs have been added to help with the disease because the final diagnosis have been altered. And in this slides, it highlights the importance of involving the other specialties, including the rheumatologist, because it clearly stated here, by following the MDD path, you could have saved invasive procedures to diagnose, bronchoscopies and surgical lung biopsies. If the patient is having an autoimmune flavor, we do not usually proceed with these two invasive procedures because it usually does not alter the ultimate diagnosis or treatment unless we're looking for infection or malignancy. So for the next slides, I divide them into screening, monitoring, and treatment based on the international guidelines. And I'm going to start with the American College of Rheumatology and the American College of Chest Physician 2023 guidelines for the SARD ILD. We're going to start with, so it's the ACR is the first guideline dedicated to ILD run by a rheumatology institute. It highlights the importance of MDT, and it helps the rheumatologist to identify ILD because على قولتهم الكورة في ملعبكم. You see most of these patients. So the majority of the talk is relying on the rheumatologist vigilant search for ILD. So the ACR guideline recommend screening using both tools, the pulmonary function test and CT. They recommend screening most patients with SSC, inflammatory myopathies, and mixed connective tissue disease with SSC phenotypes. And the other groups of SARD, they suggest screening the patients who had the risk factors. It was a general recommendations sentence. This is a very busy slide. This is where you look for the risk factors for development of ILD, but I'm going to summarize it points in the following slide. So for the SSC, these patients that usually they would have a high potential to develop ILD, the positivity of anti-SCL70, the ANA being a nucleolar pattern because that's where we see it with SSC or the overlap with myositis, diffuse subtypes, high skin fibrosis score, male gender, African American race, the early disease onset, non-Raynaud's phenomenon, the first few years, please screen these patients for ILD, and I'm sure you all guys do that. Increased inflammatory markers and the persistence of SO makes the patients at high risk to develop ILD. And the presence of RNA polymerase 3, which is not commonly encountered in clinical practice, but usually linked to a late onset ILD. For RA, high titer of autoantibodies, cigarette smoking, older age at RA onset, and being male, these similar to the IPF phenotypes. It's the triad of smoking, being male, and older that they are at high risk for developing ILD. The high disease activity, we do not like see a rheumatoid with ongoing arthritis and ILD. We know these patients would usually not only at risk of developing ILD, but to have a progressive course. High BMI and again increased inflammatory markers, which is markers of development of ILD among many CTDs. For inflammatory myopathies, the antisynthetase, myositis-specific autoantibodies, and the myositis-associated autoantibodies such as PMSL, CSL, or anti-RO antibody positivity. Mechanics hand, which falls into the antisynthetase criteria, older age, ulcerating lesions, and again the increased inflammatory markers. Mixed connective tissue disease, the most important is the presence of systemic sclerosis clinical or laboratory features, U1RMP, RO52, and increased inflammatory markers. These, the patients would have a high risk to develop ILD. Sjogren's, most important is the anti-RO52 autoantibodies, the presence of increased inflammatory markers in addition to the other features. So the guidelines recommend against screening using chest radiograph, which makes sense, 6-minute walk test makes sense again, ambulatory desaturation testing, which is a subset of the walk test, it's shorter period of tests, bronchoscopy and surgical lung biopsy, of course, nobody would do that to screen for disease. Now we're going to talk about the European ERS and EULAR 2025 guidelines. Again, we are in the screening slides. So the green boxes are the strongly recommended, the light blue is conditionally recommended, and the white boxes are based on the clinical practice. They strongly recommend screening all patients with SSC and mixed connective tissue disease and the inflammatory myopathies in the presence of risk factors. If there is no risk factors for the inflammatory myopathies, or there are risk factors for rheumatoid and Sjogren's, it's a conditional recommendations, and it's a clinical practice to screen the other ones with no clinical risk factors. We talked about the risk factors for developing ILD. For risk factors for poor outcome, the patients already had an ILD who had a high risk to progress and have a high and worse outcome of progressions and death. Highlighted in the guidelines, SSC, RA, and inflammatory myopathies. The first two, you can see they share demographic data of being male, older age, and the SSC having an African American ethnicity. These are the patients that we have to follow very closely because they are at high risk for progression. Circulating markers, persistent and elevation of autoantibodies such as the anti-CCP and rheumatoid factor makes the patients at high risk for developing a progressive ILD. Elevated ferritin, that's why we phenotype the patients with inflammatory myopathies by the serum ferritin at presentation. And of course the presence of anti-MDA5 and antisynthetase, not the JO1, JO1 is Latif, it's the PL7, PL12 and the other serology tests that usually the patient is rapidly progressing. The pulmonary function markers, the worse lung physiology impairment at baseline, the higher chance of having a progressive disease. And the extent of ILD, we do not like see the term extensive GGOs, reticulations, or even UIP pattern. These patients have a high risk to progress. And finally, the presence of RA, high articular disease, as I mentioned, controlling the joint symptoms are very crucial in controlling the overall inflammation, including the lung involvements. And for SSC, the presence of a recent onset of disease, as you know that, rapid skin fibrosis progressions and inflammatory markers, keep eye on these patients because they will probably progress. Now you screen and you find an ILD. This is a summary table for the pulmonologist because once you diagnose, you would assess the prognosis, assess the risk of progressions, and what type of disease the patients have, mild, moderate, or severe, by incorporating the clinical risk factors, the lung physiology, the extent of CT, the walk test, desaturation and distance meters, and the patient-reported outcomes. So it's always the clinical, physiological, radiographical pyramids that we usually address to see what the patient's phenotyping are. Now we're going to move on to monitoring. You screen, you diagnose, and how do you follow up these patients? Back to the American guidelines, they basically states patients with inflammatory myopathies and SSC, follow them 3 to 6 months with PFT and clinical assessment. Makes sense, right? Because these are the patients who presented usually with a cooking ILD and you want to make sure they are not progressing. CT to be done as needed. As needed means the patient's clinical status changed. You don't know if he had responded to the treatment and this is another insult happened, infection or fluid overload, which usually clinical status should help you to delineate either, or actually to assess the clinical response for treatment. We usually prefer to have a 9 to 12 month CT to say, oh, my patients had improved. And I'm very careful in the term improved, because sometimes with aggressive initial treatment, the GGOs, which is the hallmark of inflammation, and the CT doesn't go away. Fine. That for me is an achievement, because the progression of these GGO is I do not like. Otherwise, you will keep escalating, changing the immunosuppressants in elderly patients at high risk of infections. So you have to set up your treatment goals, including what do you want the patients to feel, how do you want, is it stabilization of lung functions or improvement, or it's fine to expect some decline in lung functions because the disease on the CT is already fibrotic, and we know fibrosis is escalating course on its own. And what you want to see on the CT in terms of improvement of ground glass and other inflammatory changes. And for rheumatoid, Sjogren's, and mixed connective, they suggested more liberal follow-up periods, up to 12 months. And the ambulatory desaturation testing is to be done on a spaced interval as well. They are conditionally recommend against the use of chest radiograph. Again, makes sense. It has a low sensitivity in detecting any ILD changes. Bronchoscopy and 6-minute walk test, which I do not personally concur with. 6-minute walk test, if you know exactly a good technician in your clinic who does it, you know exactly which numbers you are interpreting and what's the clinical value and prognostications. It's very, very crucial tool in follow-up in ILD in general, not only in CTD. Now in the European monitoring guidelines, they are more extensively elaborate on that. So starting with SSC ILD monitoring, you have to phenotype your patients according to a high risk, low risk, and disease duration. In your left hand, the patients at worse or higher risk of worse outcome and progression, which are the patients with high risk, as we mentioned, if you outline the risk factors that they have, and they have a recent disease within 3 to 5 years. They suggest very close monitoring. Makes sense again, right? كل 3-6 شهور بنعمل لهم PFT. أطول شوية ممكن نعمل لهم patient reported outcomes. I personally do the 6-minute walk test also 3 to 6 months. And CT recommended to do yearly. On your right hand is the patients with less risk factor for ILD development and the longer disease durations. You are relaxed in following up these patients up to 12 months interval in lung physiology and on patient-reported outcomes and the 6-minute walk tests. And the HRCT is as clinically indicated. Same path applies to the next of inflammatory myopathies and rheumatoid arthritis. Starting with the RA, high risk versus low risk. In your left hand, if it's a short disease durations, and let's say a patient's diagnosed at the age of 65 with active rheumatoid, he's male, he's active smoking, and at the same time ILD was found. These patients I do not want to set on their follow-up. I would like to follow them up between 3 to 6 months. And in the low risk group, which we see a lot of patients with RA and a long-standing ILD, these are the patients you have a liberal follow-up period for them. Inflammatory myopathies, the same pathway applied, but they nicely illustrates the importance of getting an HRCT in a close interval, 3 to 6 months. And I think that's a very valuable value because when you see a patient with inflammatory myopathies, let's say PL7 with extensive GGO and organizing pneumonia and CT, you aggressively treat these patients in the first few months. It does not make sense at all to wait up to 12 months to evaluate their clinical response because how rapidly these patients can have, and you don't want to set on under-managements or inappropriate managements, which can be masked by feeling okay. I'm feeling okay. Of course, the patients might feel okay. He started on a steroid. But how important the radiographic resolution for this disease, especially the inflammatory myopathies, is very crucially to follow up on with a close CT repeat image. And again, for the other CTDs, the same path. The British Society for Rheumatology published the guidelines for systemic sclerosis in 2024. I will highlight it in the next slide. So they recommend all the patients with SSC to be screened for ILD using HRCT and PFTs in concordance with the other guidelines. In confirmed cases of ILD, PFT to be repeated in a close interval and to be even for the first 3 to 5 years, and if the patient is stable, to space it later on. CT should be repeated to evaluate ILD progression if there is a clinical indications or pre-treatment initiation or at 1 year interval. So we're done the screening, monitoring. Now we're going to move on to the treatment recommendations. Going back to the American guidelines, for all the CTDs group, they recommend a preferred versus additional options of immune modulatory drugs. Mycophenolate is on the top list for all these diseases, I think mainly because of the extensive observational studies that's available for MMF, safety, relative safety profile, and the large clinical practice use of this drug. They recommend tocilizumab as a preferred for SSC and as additional options for MCTD, especially with SSC phenotypes. Rituximab again is recommended as a preferred agents across all the CTDs. Imuran, I personally do not like Imuran for ILD. It's usually a very weak drug, not only for CTD-ILD, but in general, but because of what happened in the last few years or 2 years, MMF has been on and off in the pharmacy, so I had to switch some patients to Imuran, and it did not show a strong benefit. Cyclophosphamide, I personally do not have a CTD on cyclophosphamide. I would like to hear from my rheumatologist colleagues in the discussion panel. The inflammatory myopathy, they recommend calcineurin inhibitor and JAK inhibitor as additional options. If the patient progresses based on the IMBOLD trial, the recommendation is to initiate antifibrotic with nintedanib. And they also suggest adding tocilizumab or pirfenidone if RA-ILD progressed. I personally have a good response of tocilizumab in RA-ILD as a first-line therapy, and that's suggested in the European guidelines as well. Rapidly progressive ILD, especially if there's a high suspicion for NTMDA5. Rapidly progressive inflammatory myopathies, we are very aggressive in treating these patients. Systemic steroids with pulse or mini-pulse regimen, with add-on biologic therapies, oral DMARDs, calcineurin inhibitors. I've had used on patients on tacrolimus or JAK inhibitors. MMF is also a good option with IVIG. So what does the European guideline state? Treating SSC-ILD, first of all, you have to phenotype your patients, map them. For example, patients with early diffuse SSC and signs of inflammation, as you see, the green box is a strong recommendation based on a moderate evidence from the FASCINATE and FOCUS trial to initiate tocilizumab on these patients. If the patient is having fibrosis of more than 10% less inflammation on CTD, nintedanib may be an option based on the census trial. In the interim, your patient is having relatively long-standing ILD, mild involvement of extrapulmonary disease, you can try them on mycophenolate. If the patient is high risk of progressions, early combination of antifibrotic regimen can be tried based on the census trial, and if the patient progressed based on the IMBOLD trial, combination of immunosuppressants, especially rituximab and MMF based on the EVER-ILD trial. And if there is a severe multi-organ involvement, cyclophosphamide or rituximab is the other options to go. For the inflammatory myopathies, although there is lack of a strong or moderate evidence, they strongly recommend early initiation, prompt initiation of immunosuppressive for inflammatory myopathies patients. Calcineurin inhibitors, it's mainly an American clinical practice of using calcineurin inhibitors. And I would like to hear, please, from your input regarding that here in Saudi. Mycophenolate and Imuran is another options. If the patients progress or high risk of progressions, have a low threshold to combine immunosuppressive therapy. For RA, the first things I look into is, are you happy with your joints? If the patient is having an ongoing arthritis, we are targeting with the consultation with the treating rheumatologist drug that helps both. Rituximab is a very good option to go, but there are more evidence supporting the use of abatacept or JAK inhibitors based on observational studies. Rituximab versus non-rituximab observational studies support the usefulness of the rituximab in stabilizing lung and joints in these patients. Tocilizumab, it's not recommended as conditionally or strong. It's a clinical practice because of lack of evidence in treating RA-ILD, but I personally find it very useful in controlling the ILD disease in RA. If the patient is severe to begin with or progressing, have a low threshold to add MMF to another agents, and antifibrotic to be considered if the patient is having extensive fibrosis, even as a start, because you want to salvage their lung, especially in a young patients otherwise healthy. Pirfenidone, especially if there's a UIB pattern, the evidence comes from the trail trials, and I personally do not have a patients on pirfenidone for RA-ILD because of its availability. Now we're having a couple of patients on nintedanib. And the same applies for the treating other CTD-ILD. The British Society has also highlighted the management of SSC-ILD. They very briefly stated the MMF as a first line and vaguely stated rituximab and Recyclu to be as an alternative. Consider tocilizumab as a first-line treatment, which makes sense as the other features, raised inflammation, early diffuse with rapidly progressive skin. And consider adding rituximab or tocilizumab to the background treatment of MMF. I do not have patients on tocilizumab and another DMARDs. You guys like it to be a solo or monotherapy tocilizumab, so very interested to hear from you the add-on to tocilizumab in your clinical practice. And they suggest adding the nintedanib in case of progressive pulmonary fibrosis, or a smart sentence if the patient is having a recurrent infection, just put them on antifibrotic. Last slide about the American Thoracic Society. In 2023, they published a very brief guidelines about the SSC-ILD. This is the only slide I presented for that. It's very brief. They strongly favoring mycophenolate based on the lot of observational studies in treating SSC-ILD and based on the SLS trials. Conditional in favor of the others. Research recommended pirfenidone because we do not have a great evidence for SSC-ILD treated with pirfenidone. And in my take-home message, co-managing SARD-ILD between pulmonologists and rheumatologists is very highly encouraged, appreciated, and mandated. Identify and label the patients with risk factor for developing ILD, and not only ILD development, but also who had a high risk for progressive course. Monitoring is as important as screening and management. And finally, there is still a lack of strong clinical evidence in treating SARD-ILD. And thank you so much for listening.
Thank you, Dr. Rahma, for this nice presentation. It's my pleasure to introduce the last speaker for today, Dr. Walid Hafid. Dr. Walid Hafid is Associate Professor. He's a Vice Dean in Qura Hospitals. He's a Consultant Rheumatology in the Noor Hospital. Dr. Walid, mic is yours.
Thank you, Mr. Chairman, for this kind introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. It's painful sometimes to see the same person twice, but hukm al-qadr. I would like to thank colleagues at Qasim Rheumatology Conference for this very warm invitation. And 5 years ago, I was standing here and I was celebrating with you all the first conference, and today we're actually witnessing the 5th. And inshallah, we will continue to see more and more success. So I will, try my best to be a light guest. This is the last talk. So why does, this topic really matter in 2025? We know that earlier identification of systemic sclerosis enables, prevention of irreversible damage. In 2025, we're now, able to better, risk stratify systemic sclerosis with the help of the serological markers, as well as some of the bedside teaching, or I would say bedside techniques that we usually do, along with images. Now, interstitial lung disease as well as pulmonary, hypertension are luckily modifiable, diseases, and the mortality trends are shifting. Trials are now targeting subsets and molecular endotypes, so we're not anymore talking about limited, diffuse. Now we talk more about fibrotic phenotype. Inflammatory phenotype, and of course, personalized medicine is really entering a clinical practice, and we will continue to see more and more of this personalized medicine. So this is not really the same 2015 systemic sclerosis that you used to manage 10 years ago. We know that systemic sclerosis is a rare, it's a complex, chronic connective tissue disease. We have the three pillars of pathophysiology, which is vasculopathy, inflammation, as well as fibrosis. And unfortunately, you can have patients with limited cutaneous systemic sclerosis who unfortunately, shows worse disease course compared to the diffuse, although previously it was thought that diffuse might, do worse. And it is a disease that can affect every single organ from the head all the way to the toes. In Saudi, we are still lacking the incidence and prevalence of this disease. But if you look at the international figures, I would say that, if we would like to extrapolate this, we can say that we have approximately 8,000 to 10,000 systemic sclerosis patients across the kingdom. And there are, two parts of the kingdom where we have a lot of cases. The northern part and the southern part of the kingdom, we tend to see a lot of systemic sclerosis cases. Our women tend to suffer from this disease more compared to men, and those with darker skin colors tend to suffer more compared to those with lighter skin color. So let's start with this case scenario, and then I'll walk you through the objectives. So this is a 43-year-old woman who was diagnosed with diffuse cutaneous systemic sclerosis in 2022. Her disease manifestations included Raynaud's phenomenon, skin thickening, abnormal nail fold capillaries, inflammatory arthritis, calcinosis, as well as gastroesophageal reflux disease. She also showed interstitial lung disease, and she has no pulmonary arterial hypertension. She has the rich serology, which is in form of ANA, anti-SCL70, RNA, anti-SSA, and please pay attention to this autoantibody that we usually do not tend to request in patients with systemic sclerosis, but I'm going to walk you through an abstract that showed some promising, I would say, association. And of course, her medications include nifedipine, methotrexate, esomeprazole, as well as mycophenolate. So how are we going to manage this complex patient in the light of the evidence that we have from the most recent EULAR 2025? So the objectives that I'll be walking you through, we will summarize key changes in the 2024 EULAR recommendations for systemic sclerosis. We'll try to interpret and apply new evidence that was presented at the EULAR 2025. We'll integrate some therapeutic decision-making across the different disease domains. We have 8 disease domains, and then we will identify gaps and future directions. Now, why would we consider EULAR 2025 as a source of an update? Is it really a big deal? Yes, it is, because many of the RCTs as well as registry, observational data, real-world evidence is usually presented at the EULAR, so it's really a source of update. And if you would like to go and search for the research that was presented at the EULAR, you can serve the Annals of Rheumatic Diseases, volume 84. You will find all the abstracts that were presented when it comes to systemic sclerosis. And of course, EUSTAR, which is the largest international registry for systemic sclerosis, they tend to present the majority of their research work at EULAR 2025. Key themes. So if you look at these abstracts, you will find that what is being done nowadays when it comes to systemic sclerosis? So we're actually shifting from monotherapy to combination therapy. Dr. Rahma beautifully elaborated on this when it comes to interstitial lung disease. Now, if you are interested in research in systemic sclerosis, again, this is a rich field where you can work on earlier detection as well as definition of progression, biomarkers, as well as some patient reported outcomes. And of course, we are now learning that serology can help in stratifying the disease rather than the clinical subtyping that we used to practice early. And then, at EULAR 2025, we had significant number of, real-world data. I have been attending EULAR since 2018. I must admit that this past EULAR at Barcelona was really rich when it comes to systemic sclerosis. There was a lot to present in systemic sclerosis. And of course, we have emerging pipelines. So we have always, used, for example, phosphodiesterase inhibitors in the management of digital vasculopathy as well as pulmonary hypertension. Guess what? Now there is an evidence that is emerging on the use of this medicine in interstitial lung disease. The updated recommendations, they represent the first biologic when it comes to the management of fibrotic domains of the disease. Recommendations beautifully cover 8 clinical domains, and there is an emphasis on the combination between different medications, either more than one vasodilator for the treatment of digital vasculopathy or pulmonary hypertension, or one immunosuppressive plus antifibrotic in the management of interstitial lung disease. Now, these are the different clinical domains, and this is a beautiful cartoon that presents the domains along with the medications that are listed in the management of these domains. These medications come with different, strength. So, for example, you have category A, B, C, and D. And as you can see here, that your old is always gold, but you have new, medications that are really joining as category A medications, such as nintedanib in interstitial lung disease, as well as other medications in other domains. This table, please feel free to take a screenshot of this. This contrasts and compares the EULAR 2017 and EULAR 2024 recommendations, and as you can see here, that the majority of the text is actually towards the 2024 guidelines. So what you can see here, that you have more medications in each domain. You have more evidence in each domain, and when it comes to research, there is more and more research towards that was mentioned in the 2024 recommendations. I'll walk you through these clinical domains. Now, the talk is interactive. I know being the last presenter is always challenging, so please pick up your cell phones and scan the QR code on the top right corner of this slide. I'll give you a few seconds because I think you might need to enter your name first and then click on submit and vote for the answer that you think is the most appropriate answer. In the meantime, I'll start reading the case for you. So this is a 52-year-old woman with limited cutaneous systemic sclerosis for 2 years, presents with recurrent painful fingertip ulcers despite being on nifedipine. Which of the following represents the most appropriate next therapeutic step in her management? Are you guys having any difficulty in voting? Wallah? Sorry. It's working, but we have to see the, so have you voted, Dr. Nizar? Because if you voted, we should be able to see that. So any problem in حيكون مشكلة مشكلة الvoting if it's not working. طيب, so let's do a different, I would say, way of voting it. So if you choose option number A, please raise your hands. B, so the majority went for B. How about C? So adding warfarin. D, Mafi, good. And E, begin high-dose corticosteroids. So the majority went for option B, which is adding a phosphodiesterase inhibitor. Now let's see if the updated guidelines really echo what the dear audience selected. So the first line, dihydropyridine calcium channel blockers, that's well known. Then phosphodiesterase inhibitors or tadalafil, such as sildenafil or tadalafil, should be considered as adjunct in patients with inadequate response. In severe refractory cases, IV iloprost is recommended after failure of oral therapy. And of course, you can use, for example, if your patients develop digital ulcers, then these are the medications that you can use. And avoid systemic anticoagulation unless there is an indication. So the guidelines are really moving away from the utilization of anticoagulation. Let's see if it works here. Again, once you just open and refresh the page, we'll see if the voting works. شغال عندك? Okay, no problem. I mean, technical issues are always, unfortunately there. So this is a 45-year-old man. Okay, excellent. It's working now. بس إن شاء الله مو أنت اللي صوت. Okay, تمام. Okay. So this is a 45-year-old man with newly diagnosed diffuse cutaneous systemic sclerosis for 6 months with very high modified Rodnan skin score, elevated inflammatory markers, and no interstitial lung disease so far. Minimal lung symptoms. Which of the following would be the most appropriate initial therapeutic approach? So the majority went for mycophenolate, rituximab, tocilizumab in inflammatory. So I agree with you. This is a patient who's showing extensive inflammatory, face of the disease, elevated inflammatory markers, elevated modified Rodnan skin score. So this is actually the face or I would say the inflammatory phenotype of the disease where your immunomodulatory as well as anti-inflammatory medications would, work the best. So try to be aggressive in managing such patients because these are the patients who tend to progress. And if you remember the talk of Dr. Rahma, this patient has many of the risk factors that can put him at risk for the progression of towards interstitial lung disease. So what comes as an update in terms of skin fibrosis? So they explicitly include mycophenolate as well as rituximab for skin fibrosis. In addition to older options like methotrexate, tocilizumab can be considered, especially if you are dealing with an early inflammatory, aggressive disease with elevated inflammatory markers. The concept of combining immunomodulation plus antifibrotic therapy is gaining, attention. And therapeutic inertia means that, try to watch and see. This is not the disease that you really want to watch and see. This is a disease that sometimes, overestimation or over-treatment is acceptable than under-treatment because your window of opportunity is really narrow. Okay, let's go for the third question. So this is a 60-year-old woman with limited cutaneous systemic sclerosis who shows a mild fibrosis on HRCT that is quantified to be 5%. Forced vital capacity is low, DLCO is low. Over the past 12 months, she showed further decline in her forced vital capacity by 7%. What is the most appropriate management strategy at this stage? Please vote. Okay, so the majority chose to initiate mycophenolate mofetil with the option to combine with nintedanib if progression continues. Dr. Rahma, do you agree? Excellent. Let's move on to the next slide. So let's see what the update, tells us about the interstitial lung disease, and I think Dr. Rahma covered that, so I'll walk you quickly through that. Again, so there is an emphasis on early detection of progression using, functional decline as well as imaging trajectories, and please pay attention to the progressive fibrosing, ILD criteria. And again, in 2025, the EULAR ARS guidelines for the management of CTD ILD were presented. We just had a talk on it, so I will skip that. Now, this is the last voting question that I have for you. So this is a 58-year-old woman with limited cutaneous systemic sclerosis, develops dyspnea, right heart catheterization confirms pulmonary arterial hypertension with elevated mean pulmonary arterial pressure, as well as elevated, I would say, peripheral vascular resistance. She is, WH class 2. She has no interstitial lung disease. What would be the most appropriate initial therapy for this patient? And the majority vote for starting first-line combination therapy with a phosphodiesterase inhibitor as well as endothelin receptor antagonist. Now let's see if the update echoes what was mentioned or what was the practice by the audience. So the updated recommendation: favor first-line combination therapy for newly diagnosed SSC-related pulmonary arterial hypertension. Your combo to go is a phosphodiesterase inhibitor along with an endothelin receptor antagonist. For more severe cases, of course, you can further escalate your treatment to include IV prostanoids as well as other prostacyclin analogs. Riociguat is a consideration in some patients, and the recommendation explicitly discourage routine anticoagulation. So anticoagulation is not anymore a medication that we use in the management of digital vasculopathy or vascular domains of the disease unless there is an indication. So how about the other clinical domains such as scleroderma renal crisis? Again, this is an area that is still lacking and there is a lot of unmet need. So it reinforced the recommendation of immediate utilization of ACE inhibitors if there is a suspicion of a scleroderma renal crisis. We have to monitor patients on high-dose glucocorticoids closely, and of course try to minimize the steroids exposure as much as possible. And of course, steroids dosing is still debated in patients with systemic sclerosis, but in general, we try to avoid a dose higher than 15 milligram daily. And how about gastrointestinal manifestations? So PPI is recommended when you have patients with reflux, ulcer, as well as those with esophageal sphincter or stricture. Prokinetic agents are given for those who have motility issues. And of course, rotating antibiotics for small intestinal bacterial overgrowth, and there is an emphasis on individualized, symptomatic care and nutritional support. So there isn't really much when it comes to gastrointestinal, manifestations of systemic sclerosis, but now antifibrotics are being tested in patients with GI manifestations, because it was found that GI fibrosis is really the precursor for these manifestations. No major changes, but more attention to patient-reported outcomes as well as symptomatic management. Other domains, methotrexate is now explicitly recommended for musculoskeletal manifestations of the disease, but you can still use other medications such as tocilizumab. We have learned from rheumatoid arthritis that it's an excellent medication for inflammatory arthritis. Calcinosis remains the poor and the neglected, I would say, domain of the disease. We do not really have much. Dr. Lujain early on today, she presented a few slides on carcinosis. The majority of the evidence that is extrapolated in systemic sclerosis come actually from juvenile dermatomyositis as well as inflammatory myopathies. And biomarkers are really gaining attention, and of course the word VIDOS, or very early onset systemic sclerosis, is now being discussed more and more. The last part of my talk is the abstract, so I will walk you through 3 abstracts. So this is the abstract in which they try to assess the the association of a double positivity of anti-SSA along with rheumatoid factor and the development of interstitial lung disease. So key findings from the study: it was noted that patients with dual anti-SSA and rheumatoid factor positivity, they show higher occurrence of SSC-associated interstitial lung disease. We do not really request these investigations or these antibodies when it comes to systemic sclerosis. However, if you have a patient with risk factors for progression of interstitial lung disease, you might want to consider requesting these autoantibodies. These autoantibodies, when they are both positive, they all are also shown to be associated with more severe disease compared to those who have negative SSA as well as negative rheumatoid factor. So clinical implication findings suggest that testing for rheumatoid factor in addition to anti-SSA antibodies can improve the identification and risk assessment of SSC ILD. I'm not saying that we have to do this in our practice, but if you have patients with high risk, you might want to consider this because this will help you risk stratify. The second and the last before the least abstract is on the vasoactive vasodilator therapy. And what was found in this abstract, that study found a statistically significant association between exposure to vasoactive vasodilator therapy and lower risk of new onset interstitial lung disease in systemic sclerosis patients. What are these medications, such as sildenafil or iloprost? Digital ulcers, again, it was noted that these medications provided protective, I would say, benefit against the development of digital ulcers in these patients. So the implications in clinical practice findings suggest that vasodilator therapy could have a preventative role in the development of interstitial lung disease and systemic sclerosis. This is, a strong, I would say, statement. It needs further, research to solidify it. The last abstract is on, the outcomes of upfront combination versus monotherapy. So they actually assessed patients who were on combination therapy of mycophenolate along with rituximab versus patients who were on monotherapy, either mycophenolate or rituximab, to see the and the impact of this on interstitial lung disease. So key findings were kind of like surprising. They did not find superiority of combination therapy over monotherapy in patients with systemic sclerosis when it comes to the prevention of forced vital capacity decline at 12 months. However, the study consolidates the fact that these medications are effective when it comes to the management of interstitial lung disease that is associated with systemic sclerosis, and of course more and more work is needed to address the superiority of combination therapy over monotherapy in patients with interstitial lung disease secondary to systemic sclerosis. So takeaway messages, ladies and gentlemen, Mr. Chairman, I would say that 2025 ULR updates represent paradigm shift. Immunomodulation plus antifibrotic combination strategies are now part of standard consideration in the fibrotic domains of the disease. Early detection of ILD progression is really critical. Do not wait for overt worsening. Remember that you cannot bring the patient back. And in pulmonary arterial hypertension, first-line combination therapy is now recommended, is the recommended standard. And serologic stratification and phenotyping of the disease, and then deciding based on the phenotyping really matter. And we saw that with this abstract that was presented on the double positivity of anti-SSA plus rheumatoid factor. And my last take-home message is that many uncertainties still remain. There are unmet needs when it comes to some organ domains. In this, we really need clinical judgment, patient selection, as well as multidisciplinary care. With that, I would like to thank you for your kind attention and listening.
Thank you, Dr. Walid, to update us about the recent ULR recommendation for the scleroderma. I would invite you for the discussion, and Dr. Rahma will open the floor for the question. Yes, Dr. Naif.
Assalamu alaikum. I have one question for Dr. Rahman and one question for Dr. Walid. For Dr. Rahman, my question is there any CT scan feature of ILD that indicate that or tell you that this patient needs steroid? I know that some respirologists, what they do, that if they see ground glass opacity, extensive ground glass opacity, and they ruled out infection, they said, okay, this patient needs steroid in addition to antifibrotic agents. And my question is to Dr.
Walid, is about the GI manifestation treatment for scleroderma. Is two questions. Should we use prophylactic PPI for all patients, even if they don't have GERD or they don't have dysphagia? And there were some reports suggest using some antidepressant to treat some GI manifestation for scleroderma, and they want to know your opinion.
So thank you, doctor, for the question. So what does dictate the initiation of steroid? For such patients are radiographical features in addition to the clinical presentations. We see patients that are minimally symptomatic, yet they have reticulations, I mean not the fibrotic type, ground glass, nodular opacity for organizing pneumonia, but at the same time we're not in hurry to initiate steroid. For example, they are very obese, they have a poor diabetic control, their lung physiology is not bad. These patients we can initiate MMF ahead of time and have a couple of patients for that. Because what are you treating is what patient feels. That's not commonly encountered. This is just a subset of patients. The most commonly encountered is the patients when there is inflammation, as I mentioned, with these features. Patients is having trouble breathing, intractable cough. Their FVC we're not happy with, so we initiate steroid. The dose, the frequency, the taper varies from patients to the other, but that's the general clinical practice that we follow.
Thank you, Dr. Naif. This is really an important question that addresses an important unmet need in systemic sclerosis. GI manifestations are really poorly understood and studied. Now, the first part of the question is with respect to the use of prophylactic PPI in patients with systemic sclerosis. Now, we all know that these medications are not placebo. They are not without side effects. So you always have to weigh risks versus benefits if you want to start prophylactic PPI in these patients. Having said that, there are patients who you might want to start them on these medications, this group of medications, if they are, for example, patients with interstitial lung disease. So you will minimize the aspiration pneumonia, for example. If you have patients who are really having stress, and that stress is going to cause further GI upset in these patients. So these are, but in the guidelines, what is mentioned so far is you want to treat based on the symptoms. Now moving to the second question with respect to the use of antidepressants in the management of GI manifestations. Our worst GI symptoms used to be when we were in the exam part back in the school. So stress worsens GI upset, it worsens the gastroesophageal reflux disease. So it is so the role of antidepressant in GI manifestations of systemic sclerosis is really similar to the role of these medications in the management of Raynaud's phenomenon. Many of our patients, they tend to have Raynaud's phenomenon that does not usually respond to the vasodilator therapy is because of the fact that they are really having stress or they're anxious or they're having a lot of social issues. Once you put them on a tricyclic antidepressant or an SSRI, they dramatically respond. And this is something that we see beautifully in patients with Raynaud's phenomenon. So we might want to generalize this on the GI manifestations that might be secondary to stress rather than the disease itself. And using antidepressant, if it's going to improve the overall quality of life of this patient, I think I will do that.
Yes, Dr. Fahda, you want the mic there?
Thanks, Dr. Walid, for mentioning this association of different antibodies like anti-Ro with rheumatoid factor carries higher risk of ILD. What about anti-U1 RMP that we encounter with lupus carries higher? So what about have you encountered anything like that?
Yeah, thanks, Dr. Fahda, for this important question. Again, unfortunately, because we do not usually test these different, I would say less frequent antibodies in our patients, so we do not have that kind of association. But looking at the U-STAR cohort, so I applied personally to have my patients to be part of the U-STAR. But if you look at the data collection sheet that they have, it's huge. They request a lot of information that we usually don't have on our patients. So there are associations between different, autoantibodies with the different, organ domains in systemic sclerosis. For example, if you have an anti-ACL PM antibody, this is highly associated with myopathy as well as with cardiac manifestations of systemic sclerosis. L1 antibody, RNP1 antibody, again, there are no clear, I would say, associations so far, but literature actually points towards the development of overlap syndromes such as lupus and the other diseases, but we still need, much work to risk stratify these antibodies with certain either disease associations or maybe overlap syndrome with other diseases.
Thank you. Another question to Dr. Rahma. Thanks, Yani, for your great talk. We commonly, with our colleagues, pulmonologists, and the, discussing comments on the radiologists, CT, lung, this is UIP, NSIP. We as rheumatologists, we know our patients, they are immunosuppressed, and the risk of infection is there, and the risk of reactivation of the disease is also there. So this is, most of the time, it's like, a clinical a bit dilemma, We tend to consider both, but, from educational, how important is this UIP or NSIP or, the radiological interpretation of the CT?
It's on its own a fibrotic, purely fibrotic definition of ILD. It usually has 3 stages, whether it's a definite, probable, or indeterminate for UIP. Indeterminate can be admixed with NSIP mixtures, but the probable and most importantly the definite UIP, the honeycombing, this is a fibrotic. If I understand your question, Dr. Fahda, is when to exclude
the radiological description of different pneumonitis, and it's important to differentiate between the possibility of infection there plus, I know there is interstitial lung disease, but add on infection or
clinical, number 1. Clinical presentations. We have a low threshold to bronch these patients to rule out infections, especially the indolent infections, the PCPs. They can present within 2 to 3 weeks of ground glass changes, intractable cough, no fever. Yet we have to rule it out by bronchoscopy samples. So again, how the patient had been feeling. If there is a change in the sputum, the cough should be dry. When it starts to be productive, yellow, green, this is a sign of infection. Before proceeding with bronchoscopy, we give them empiric antibiotic. We hold the DMARDs. We tend to hold it. I know some rheumatologists usually continue that, but we hold it for 1 to 2 weeks till the presumed infection clears. If there is no improvement, we have a low threshold to bronch, especially the non-tuberculous infections, some sort of gram-negative infections. Sometimes we found MRSA and MSSE on the cultures of the bronchoscopy. The radiographic, when there's a definite UIP or fibrotic UIP, and then new insults, nodules, aggregates of ground glass, new organizing pneumonia, and the patient is fully suppressed, I do not think of why the disease is flaring. Infection number is 1.
Thank you.
You're welcome.
Okay. Any other question? Yes, Doctora.
Thank you so much, both of the speakers. Very nice talks. Again, just to emphasize on the fact that, especially for patient who is known to have an autoimmune disease, so they're not newly diagnosed, and those who are not immunosuppressive naive, so they're already immunosuppressive, including steroid, and then they present with worsening of respiratory status. It's very important, as you've already mentioned, to consider other possibility before jumping to rapidly progressive ILD, even if they have the predictors like MDA5, 52-row, double RO with the rheumatoid or anti-ASR, etc., etc. And I know it's quite difficult radiologically, even for the most expert chest radiologists or respirologists, to differentiate between both, especially if the consolidation, ground glass attenuation is not really going either way. Infection is always a problem, and to be ruled out very much meticulously. It might not be possible in the beginning to really have evidence of infection right away, and because the approach otherwise is aggressive triple therapy with including rituximab, etc. So this is very crucial, very critical, very important. And I think infection, we have to really differentiate between those who are not known to have autoimmune disease and those who are not, and those who are immunosuppressive naive versus those who's already immunosuppressive, including steroid, because they oftentimes they don't manifest clearly as someone else who's immunosuppressive naive. Thank you.
I'd like to comment on this point. The acute exacerbations of ILD in the setting of cystic connective tissue disease, some studies support an underlying infection as a triggering for that exacerbations. So it's not even a flip of coin, 50-50, the chance of infection playing a role. It's even higher than that. But again, putting together the clinical, the culture samples, the inflammatory markers, including the procalcitonin level, and believe me, the good radiologist should delineate either way. Infection can have specific features of CT, nodularity, aggregates of consolidative patch. In comparing to the other previous, the patient will not have an infection that's been cooking for weeks. Usually it's either clear on its own or progress to a worse outcome. So again, incorporating all of these would help you guide. And in either way, setting on a presumed rapidly progressive inflammatory myopathies, especially if the patients had been hit very hard with antimicrobial agents periodically, including even antifungal and bacterial prophylaxis, is not encouraged clinically, because even if the patient deteriorated and had a death as an outcome, the clinical practice stating you have to be aggressive, because I was afraid of infection. Infection, if not present at the present time, it would evolve. It's unfortunate 70% mortality for these patients, whether they will die of infection or the natural disease progression.
Yeah, thank you. But they're not necessarily manifest the same way as immunosuppressive naive. They often, and organism sometimes takes weeks to. I know it's many cases are quite difficult, I know, but always infection is something we should take into, especially the fastidious organism that might hospital acquired that might take weeks to grow. And we have seen this in our experience. Thank you.
Threshold to bronch these patients, and in the ICU setting, tracheal aspirates is as good samples as the deep lavage. And we had patients, we do a full bronchoscopy on them while they are mechanical ventilation. So again, working with the treating physicians in the ICU or admitting the patients for that, just to get them bronch. Sometimes the patients on high oxygen requirements, we get them on non-rebreather, high flow oxygen flow, nasal flow, because we want to get them a bronchoscopy. Even in the expense, they will get deteriorate with gas exchange and end up intubation, but at least you will have your samples before empirically hit them hard with immunomodulatory therapies.
Dr. Abdul Latif.
Thank you. Excellent talk, both speaker. Excellent talk. Two questions. First to Dr. Hafid Walid. Practical point. Several patients who have rhinoid scleroderma, not uncommon that they have baseline blood pressure is low blood pressure. So we some patients not improving with nifedipine, and sometimes we have to add BDI. And I noticed several they will have side effect with hypotension. So sometimes I change to replace nifedipine to BDI, but there is no clear guideline for that point. This is my first question. Second question to Dr. Rahma. We have an issue with in general hospital that don't have specialized pulmonologists. I think the same problem that we have with ankylosing spondylitis, there is general radiologists who have poor interpretation of sacroiliitis. So the same thing with general radiologists. So they are not doing proactive work in co-management with us. So most of the time, in the end, I will do everything and I will instruct them what to do. But if there is any recommendation that even that hospital don't have specialized pulmonologists to see, and even in another area, specialized pulmonologists, because this prognosis, if not has critical, and the patient may end in transplant of the lung. Thank you.
Thanks, Dr. Abdul Latif. Yeah, this is a common observation actually in the clinic, that patients with systemic sclerosis, they tend to have, baseline low systolic blood pressure that ranges between 90 to 100, and it's sometimes challenging to treat them with the vasodilator therapy. But my personal observation with these patients that if you start them on these vasodilator therapies for their digital vasculopathy, these medications tend to act actually peripherally more than, I would say, centrally. So they tolerate it very well. Now, you will still have patients who will definitely show low levels of blood pressure when they're put on these medications. That's why we can treat them with other medications. So we have, for example, pentoxifillin. We have, although they're not part of the guidelines, we have these medications, the SSRI, the antidepressants, because they can tackle not only the vasoconstriction, I would say, pathology of Raynaud's phenomenon, but also don't forget like the neuropathic component of vasoconstriction that can happen, which responds beautifully to these medications. So it's you can individualize and tailor the treatment according to the patient. If you fail to do that, then you end up with procedures such as sympathectomy and the others. But my personal observation, they usually do fine when it comes to stabilization of blood pressure on these vasodilator therapies.
طيب لقد سألت عن عظيم يا دكتور. It's very hard to motivate people to be involved in multidisciplinary team. ILD is a very complex disease, and we have a lot of shortage in Saudi Arabia still. And I highly encourage the general pulmonologists and the training fellows to get themselves exposed, because they will end up in one of the hospitals. There's no ILD backup, yet they have a sick patient that they should get an input towards them. It's different than, for example, sleep medicine. I'm not interested in sleep. The patient will not die if he doesn't have a sleep disorder breathing evaluations. So it's maybe hard to answer that question, and maybe a lot of work is going to be on you rather than when you had not only an ILD, but interested ILD specialist in collaboration with rheumatologists, because the same apply with the rheumatologists. Not all of them are interested in ILD, and perhaps you find in one center rather than the other, you collaborate with some of your rheumatologist colleagues, and the others, they just briefly communicate with you. So I think there is a background, a lot of backgrounds behind that: personality, training level, confidence level, and the overall interest. So good luck in finding interested pulmonologists in that. But we're always happy to collaborate. And there is a national MDD ILD meetings established over the 10 months past. It's a national around the Saudi. We conducted Zoom. So the attendance is very high for our pulmonologists to discuss cases with ILD experts. And we invited rheumatologists into that. If you want, I can forward you the meeting agenda and the timeline for that.
Thank you very much. That's great news.
We have.
Assalamu alaikum. Thank you for enriched information, Dr. Rahma, Dr. Walid. I have one question for Dr. Rahma. In the last guideline, ERS or EULAR guideline, they didn't mention about the family history of idiopathic lung disease or idiopathic fibrosis as a risk factor for our strategy for screening for rheumatoid or Sjögren disease. Do you think they are ignored this point? As I know, you have a lot of information, or you have a lot of expert in idiopathic lung disease, and you know the importance of genetics mutation.
Yeah, so there's still lack even in pulmonology guidelines regarding who to screen in the patients with one single family of pulmonary fibrosis. Let's say the father had an ILD, IPF. The guidelines do not recommend this to screen the first generation, including the kids, unless 2 or more of family members already been affected and exceeding the age of 50. So there is a lot of lack in the usefulness of screening these people if they do not have a well-established pulmonary fibrosis, familial pulmonary fibrosis background, let alone extrapolating that into connective tissue disease. So you can closely screen these patients, auscultate them for crackles, monitor them very closely, and if they fall into any of these criteria who would need the screening anyhow or fulfill the criteria for screening, you can screen them from that perspective, but not as a familial pulmonary fibrosis perspective.
Thank you.
You're welcome.
Any other question?
Yes, I do have, please, to the rheumatologist. Any inflammatory myopathies expert can give us the input of calcineurin inhibitor use. Because I personally had one patient I had to stop. She developed very high hypertension, sky hypertension emergency. But the guidelines insistently recommend calcineurin inhibitors, including tacrolimus and cyclosporin A. So any experience from your perspective?
So, you know, our myositis expert is Dr. Mahal Mackenzie, but I don't see her. If she's around, she can actually answer.
You can answer,
I will
Dr. Walid.
volunteer. Now, I'm not expert in inflammatory myopathies, and in fact, it's a disease that we don't usually see commonly compared to some more common diseases such as rheumatoid arthritis and the others. Now, our experience with this medication comes actually from lupus, you know, patients with lupus nephritis, or those, for example, from the transplant. I have never used this medicine in the management of you know, patients with rheumatic diseases, but I concur what was mentioned by you, is that it's a medication is now mentioned in the guidelines when it comes to the management of inflammatory myopathies. I have seen very few patients who were receiving this medicine in RA-ILD. And I don't know what was the rationale behind putting them on tacrolimus, provided that we have many other options that can be used in the management of RA-ILD. But I think it might be based on, I would say, case series or retrospective studies. I don't have much of information with respect to that. Any of our rheumatology colleagues?
Just to give a short comment, immune myositis is not as common as other connective tissue disease. For me, I never reached the stage that I have to use tacrolimus. They do well on methotrexate, rituximab, Cellcept, to be honest, I never reached the stage that they are refractory to all of these options, then I have to use. But using, calcineurin inhibitor, tacrolimus and cyclosporin, yes, I've used them, in a wide number of patients, and they are excellent medicine, except with some side effects, the high blood pressure and the increment of creatinine, increase also in glucose level, but mainly, what limits me is the refractory hypertension and the high creatinine level. But they are excellent option,
At the end, I would thank you all to attend our program today, and I would thank our speakers, Dr. Walid and Dr. Rahma. See you tomorrow, inshallah.
The last satellite will be sponsored by Brunger and will be presented by Dr. Aus Abu Abat. He is consultant rheumatology with the subspecialty in scleroderma. He's consultant in King Saud University. Welcome, Dr. Aus.
Assalamu alaikum jami'an. So today I would like to thank Boehringer for their invite, and the short talk today will be about progressive fibrosing interstitial lung disease phenotype and the implication of it on patients' outcomes and therapies. So to start, pulmonary fibrosis can occur in a wide variety of interstitial lung diseases. It often leads to progressive destruction of the lung architecture. Triggers for ILDs include viral infection, for example, certain exposures in our diseases, specifically in our patients' population, autoimmunity and autoimmune ILDs. The course of interstitial lung disease is variable. Some patients can have very mild, stable disease, while other patients can progress rapidly, and this leads, when they progress, it leads to respiratory failure and death. So that's why detection and monitoring is quite important. So this is the classification of ILDs based on their etiology. So we can classify ILDs based on the cause or based on the behavior. So if you look at the causes, there are more than 200 different distinct phenotype or causes of interstitial lung disease. What we're more concerned about is the second category of autoimmune ILDs, which include our common systemic autoimmune rheumatic disease-associated ILDs, along with this research classification of IPAF, interstitial pneumonia with autoimmune features, where patients can have interstitial lung disease with some autoimmune features, like, for example, Raynaud's phenomena or certain autoantibodies, without meeting a classification criteria for a solid systemic autoimmune rheumatic disease. So when we classify ILDs based on behavior, you can see that some ILDs remain stable and self-limited, where others can progress despite treatment, and some progress and can be halted with treatment. And you can see that this progressive phenotype cuts through multiple etiologies of interstitial lung disease. So we can see it in, for example, RA-ILD, we can see it in idiopathic pulmonary fibrosis, we can see it in scleroderma-ILD or other forms of interstitial lung diseases. It's characterized by progression of pulmonary fibrosis on HRCT, and we'll talk about the criteria for that in a bit, worsening respiratory symptoms or worsening dyspnea scales, and reduction in forced vital capacity and DLCO. It's estimated that about 3 in 10 patients with systemic autoimmune rheumatic diseases, ILDs, are at risk of developing this progressive fibrosing phenotype. And if you look at the patient's journey when they're diagnosed or when they develop the onset of symptoms of ILD with this fibrosing phenotype, you can see there is significant delay between the initial symptoms of ILD to the diagnosis of ILD, to the development of this progressive phenotype, to detection by physician, and ultimately death. So there is a significant delay in diagnosis and initiation of treatment. And that's what we, as rheumatologists and with our pulmonology colleagues, need to work on to cut this duration. In fact, in our center, we have some unpublished data to look at screening practices and monitoring practices based on the recent SARD ACR ILD guidelines for monitoring and screening. And we found there are some significant delays with predictors being essentially the logistical issues of getting HRCTs right on time, getting PFTs right on time, especially in large tertiary centers where patients can follow from usually outside of the province, which may cause significant delays in diagnosis. So if you look at the impact of this disease, we can see that this fibrosing progressive phenotype, regardless of the etiology, behaves similarly to idiopathic pulmonary fibrosis. So it behaves similarly to IPF. So patients can have early mortality, deterioration of lung function, and worsening respiratory symptoms and exacerbation. And if you look at this, for example, RA study looking at RA-ILD, you can see that around the 5-year mark, patients continue to accumulate significant reduction in their FVC and DLCO, and almost 1/3 of them end up being oxygen dependent. So when this fibrosing progressive phenotype occurs, it leads to significant morbidity. And these patients with the progressive phenotype are at risk of developing acute exacerbation. So for example, so I am a scleroderma specialist, so I see a lot of patients with scleroderma. Scleroderma ILD rarely develop acute exacerbation. So their course is very chronic, with chronic reduction in their FVC, and they have chronic worsening of their symptoms. They rarely develop acute exacerbation. However, in these patients with the progressive fibrosing phenotype, specifically in the RA-ILD population, can develop acute exacerbation. In this study of looking at RA-ILD patients, 17% of them developed acute exacerbation. So not very common. However, when it occurs, 93% of them die within 6 weeks of that acute exacerbation. So it's quite deadly. And if we look at physicians who see ILD, and when they're essentially surveyed in survey studies, they estimate that their patients with progressive fibrosing phenotype die in about 4 to 5 years. So it's a quite deadly disease when it occurs. I'm not going to spend so much time on monitoring because that was covered in the screening and monitoring presentation by Dr. Rahma, so I'm going to skip over that. But I will talk about some clinical evidence of what can work. So nintedanib is a tyrosine kinase inhibitor that blocks receptors to multiple mediators of fibrosis. So it blocks the receptors for platelet-derived growth factor, fibroblast growth factor, and vascular endothelial growth factor receptors. And when it blocks that receptor or binds that receptor, it blocks the fibroblast proliferation and migration, and it also blocks the differentiation of these fibroblasts into myofibroblasts. Therefore, it blocks the fibrosis pathway. So essentially the rationale behind the trial of NBuild, which looked at nintedanib in the treatment of this progressive phenotype specifically, there was some data from the NPulses trial which looked at this, the nintedanib in the treatment of IPF. And since this progressive phenotype or progressive fibrosing phenotype that cuts across multiple etiologies, specifically SARS-associated ILDs, the rationale was maybe if we use nintedanib in this phenotype, despite or irrespective, it would help stabilize the FVC. So that was the rationale behind this trial. So this trial of the NBuild trial was a multi-center, multi-site phase 3 randomized controlled trial that included 663 patients across multiple countries. Unfortunately, Middle Eastern and Arab countries were not represented. And they randomized patients into 2 arms. The first arm was 150 milligram of nintedanib versus placebo, and they had a 52 weeks core arm and the core period and an extension blinded period after that. The primary endpoint for the study was the absolute reduction in forced vital capacity. This is a very common primary endpoint for a lot of ILD trials, and they looked at also secondary endpoints, which were the absolute reduction in the KeyBuild questionnaire. This is a patient-reported outcome looking at quality of life. And they also looked at the time until the first acute exacerbation or death. And I'm going to look over the baseline characteristics, or the inclusion criteria. So they included patients with diagnosis of progressive fibrosing ILD. So patients had to have some fibrotic features on their HRCT, whether it's reticulation, honeycombing, or traction bronchiectasis. And patients had to have an FVC more than 45%. So they wanted patients with some residual lung function to measure the difference between, or measurable difference between the treatment and the placebo. And they also wanted patients to have some also residual diffusion capacity. So they wanted patients from 30 to more than 30% and less than 80%. The other inclusion criteria were, so if you had to have fibrosing ILD at baseline, and then you had to have a progression 2 years prior to randomization. The definition of progression was if you had a reduction in your FVC by 10%, or a combination of reduction between 5 to 10% and radiographic progression, or to FVC between 5 to 10% and clinical worsening of symptoms, or without, they did not include the FVC. If you had progression radiographically and worsening symptoms, you were considered to have a progression of your fibrosing ILD. So that was the patient population. They also stratified patients in the randomization based on if they had a UIP-like, so more quote-unquote fibrotic, and non-UIP-like. So I'm going to skip over this and go over the key exclusion criteria. So they excluded patients who had IPF. And the reason behind this is they already showed that nintedanib worked in IPF in the NPulses trial. So a lot of our patients were included, so patients with autoimmune ILDs. The other key exclusion criteria were patients who had liver enzyme elevation or hepatic impairment, and patients who had known bleeding risk were not included. They allowed background therapy, which is, I thought, very helpful because that's what we do in practice. So background therapy had to be stable and were allowed. They just excluded patients who had recent changes or introduction of their immune suppressive therapy within the respective half-lives. They also allowed physicians to add immune suppressive therapy, but provided they had to be stable on an nintedanib without an added immune suppressive therapy for 6 months. And these are the essentially results. So if you look at the baseline characteristics, it was essentially a balanced trial in age, sex, and ethnicity. So this was a multi-ethnic study, which was very helpful in terms of generalizability. And you can see that they stratified patients into UIP-like versus non-UIP-like pattern on CT, and they had a balanced FVC and DLCO capacity at baseline. And if you look at the classification based on etiology to the orange slice, these are the autoimmune ILDs. So the most common ILD that was included in the trial were the RA ILD patients, followed by systemic sclerosis ILD, followed by mixed connective tissue disease ILDs. So these represented the majority of the autoimmune ILDs in this trial. The primary endpoint was met, so patients, the FVC has significantly stabilized in the nintedanib group by a difference of 57%, measured by 107 ml per year in the forced vital capacity. And if you look at the secondary outcomes, patients actually did not have a meaningful difference in terms of the patient-reported outcomes or quality of life, and this is actually consistent with what we saw with nintedanib in other trials, specifically the census trial in patients with scleroderma ILD. However, numerically, it favored nintedanib. And you can see that the lines beautifully separates early on between the placebo and nintedanib, and this effect is sustained at 52 weeks. Although we can't really technically compare trials head-to-head because this was not a head-to-head trial, but you can see that the effect of nintedanib is demonstrated in this progressive fibrosing phenotype compared to systemic sclerosis ILD as well as IPF patients without autoimmune ILDs. And I think in terms of the secondary endpoint, the most important thing was the acute exacerbation. So remember I told you about acute exacerbation in RA-ILD being really fatal when it occurs. And nintedanib reduced the risk of at 52 weeks by 33%. And we already talked about patient-reported outcomes. In terms of the side effects, we can see the investigators for this study learned from the issues with the GI side effects from nintedanib in the census trial and the impulses trial. So they astutely and immediately managed diarrhea for patients with loperamide and dose reduction from 150 to 100. Therefore, less than 60% of patients discontinued the drug because of GI side effects, specifically diarrhea. And that was the most commonly reported side effects. If you look at the other side effects, liver enzymes increases were also significantly higher in nintedanib, but these were managed with dose of the drug. There was no difference in bleeding risks as well as major cardiovascular events between the two groups. And I think that's essentially it for me. My key messages or the summary of this presentation is that the progressive fibrosing phenotype is rare but deadly complication of a lot of our autoimmune ILDs. Detection and early detection and monitoring is key, and I would draw your attention to Dr. Rahma's presentation about monitoring and screening, as well as the early introduction of immunosuppressive therapy followed by nintedanib for the treatment of this phenotype. And I'm happy to take any questions.
Thank you, Dr. Aus, for this nice presentation. Any question for Dr. Aus? Okay, we'll end our session for today. Thank you.